Thank you.
Thank you so much, chairpersons and speakers. I now request our guest of honor and our guest of honor, Dr. Gopal Rawal sir, and our course director, Dr. Shivani Swami, ma'am, of stage and state honors, chairpersons and speakers.
First chairperson. Around school, come on. Name, sir.
First, we'd like to thank Penn State, Dr. Nancy, ma'am.
Nancy Goodwin. Yeah. He's got Nancy Goodwin. Sir.
First, ma'am to Penn State, Rajeshwari, ma'am. We request sir to Penn State, Shankar ma'am. And we request both of them together to Penn State as speaker, Dr. Kavita ma'am. Thank you so much, speakers and chairpersons. We request our guest of honor and our course director to stay on stage. We'll quickly break from the academic session and have a lucky draw session, and then we proceed with the day's rest of the academic programs.
Finish. Anyone start? Come on.
Insert your friends.
This is I may request Dr. Shivani Swami and Dr. Gopal Rawal. Gopal Rawal is our Vice President of CSM. He is Secretary of the ICSD conference at Ahmedabad. So, just a name.
Reshmika Balan.
Reshmika Balan.
That's your.
No. Yeah, you get a Dr. Jabarani Jivita. Dr. Jabarani. Okay, next session. Next. Okay,
So, like announcements. One, we will not be exactly waiting for the tea break. The tea station will open. Anybody who wants to join can please go outside. Quickly, you can go quickly grab the coffee or tea and then come back and we continue with the academic sessions. That's one. Second announcement. If your question demands a long answer, kindly keep it off stage. Any short things that need to be addressed, we keep it on stage. Thank you.
Next, we have a very, very interesting case-based panel discussion. So I request the moderator, Dr. Gayatri ma'am. Gayatri ma'am, senior consultant pulmonologist in Apollo Main Hospital, Chennai. So ma'am is a very vast experience in respiratory, sleep, and critical care medicine. So over to Dr. Gayatri ma'am for the case-based panel discussion. I request everyone stay tuned. There is no official tea break. Just to take the coffee, tea, and come inside and enjoy this program. Thank you. Over to moderator, Dr. Gayatri ma'am.
Standing there. Ground on arrow. So, hello everyone. We will now proceed with the panel discussion. This panel discussion is on sleep disorders in women. So, last week we had the International Women's Day. So, we thought we'll have this panel discussion on sleep disorders in women. So, I feel that as a lady pulmonologist, I find that women are quite ignored from the sleep disorder breathing therapy and the treatment part of it. Basically, I think women bear a lot of things and they don't complain much. So to learn a bit more about this, so we have a panel. The panel is a mixed panel. We have a physician on the panel, a pulmonologist who deals a lot with geriatric patients. We've got a physician with the special interest in women's health. We've got a psychiatrist. We also got a nurse pulmonologist. And we've got Dr. Shivani Swami here. So I welcome the panelists on stage. Dr. Kavita, physician, please. Mic.
Set up.
Dr. Kavita ma'am. So Dr. Kavita ma'am is a physician with a special interest in sleep medicine. Next, I invite Dr. Sridevi, pulmonologist. She works in a hospital with which deals with geriatric patients. So, and then we invite Dr. Sujata Gadhira. Madam is an physician with a special interest in women's health. Dr. Ramya Sampath, psychiatrist with the special interest in sleep medicine. To add flavor to the session, we have Dr. Mani Maran, among all the ladies on the panel, and Dr. Shivani Swami from Jaipur, our season secretary. Please, madam, welcome you on stage. So we've got the panel questions that so it will be a little bit more informative people with sleep medicine and also dealing with a lot of patients who might have some sleep disorders but who are not picked up. So I'll pose my first question to Dr. Kavita, physician. As a physician, what sleep related complaints do your female patients complain of, which really highlights what needs to be done? Over to you, ma'am.
Thank you, ma'am, for the question. Actually, we do come across with, especially the women candidates, with a lot more complaints with regards to sleep. But I will categorize it according to the priority. They say it is disturbed sleep, and of course, they are trying to fall asleep and maintain continue the sleep as such. And definitely, they all complain about daytime fatigue or tiredness or irritability because they have lack of sleep. These are the major complaints, ma'am. In my general practice, I get these complaints.
Thanks, ma'am. So I think we should be a bit more alert to what kind of complaints the women really come to us with. It should not be really ignored. We should just have some credence to those complaints and deal with it accordingly and maybe investigate further.
And that will also throw a light whether it is coming under the category of insomnia. Because if anybody is not feeling having good sleep for more than 3 nights in a week, continuously for more than 3 months, yes, it comes under insomnia. That goes with the definition. So definitely you'll have to ask further questions to the patients whenever they come with these sleep complaints.
Thank you, ma'am. See, now with all this rising access to a lot of junk food and a very sedentary lifestyle, we've actually noticed a lot of obesity in teenage girls and with a lot of PCOS happening. My question is after Dr. Sujata ma'am. With the most of the PCOS in the population of patients, are you also observing sleep-related disorders in these patients? Can you throw some light on this, ma'am?
Yeah, especially young girls and college goers or office goers. Everybody, they don't sleep at the right time, which we say at least minimum 10 or 9 o'clock. They have these gadgets, the blue light radiation is so much they are exposed to. So their obviously their circadian rhythm is affected. The cortisol level increases. So this has a toll on the HPA axis, hypothalamic pituitary axis. So the cortisol level is increased, or there is an imbalance. So this affects the hormones. There is the hunger hormone and the satiety hormone, ghrelin and leptin. So invariably, these kids know they have this midnight snacking. So whatever it is available, they are hungry, they are under stress. So they feel whatever is available there at home, irrespective of the calories or what thing they take. So this in turn leads to obesity in these young girls, and they go into this metabolic syndrome. So it also affects their hypothalamic pituitary ovarian axis. So the sleeplessness leads to the decrease in the follicle stimulating hormone. So indirectly, their menstrual pattern is affected. They have daytime sleepiness. Sometimes because of obesity, they can land up in OSA also.
There's a very interesting point we have to realize. So with this modern lifestyle, it's not only the adults who are getting affected, all these problems are starting at an earlier age itself, in the teen age itself. And especially teen girls, I think sometimes they are ignored. Some parents do bring the child off for consultation, for obesity treatment and all those things. But sometimes, unfortunately, it may be ignored. And that time it may really lead on to very bad consequences. Thank you, ma'am, for highlighting on this. See, Dr. Manimaran, a quick question to you. Are women forthcoming with sleep-related complaints? What actually prompts you to elicit the complaint of a sleep-related breathing disorder in women?
Asthma was it's often underdiagnosed, especially in women actually. So தமிழ்ல சொல்ல போனா பொண்ணுங்களுக்கு மனசுல இருக்கிறதே கண்டுபிடிக்க முடியாது, பொண்ணுங்களுக்கு ஸ்லீப் அப்படியே இருக்கிறதையும் கண்டுபிடிக்க முடியாது. Because they present with subtle symptoms like insomnia, depression.
Translation, please.
They will present subtle symptoms like anxiety, depression.
So what he is actually tell, girl, you can't even find out what's in her heart. So if you don't even, you can't even find that out, what on earth are you going to find out about sleep apnea? So that's what he is quoted. So the monthly don't worry.
Usually they won't have the loud snoring or apneic spells like that. Usually they present with depression, anxiety, insomnia, those things, but usually often confused with the post-menopause symptoms. That's why usually you'll be missing these typical symptoms of sleep, in females especially.
So thanks, Dr. Mani Maharaj. This is a very gray area. We see some women, or most women won't be forthcoming with this kind of complaint. Sometimes it's very embarrassing. Won't tell someone, I'm not sleeping well, do something about it. So it's something we really have to pay more credence to and see what needs to be done.
So as a life partner, usually wives only will find out the problem for husband, but definitely husband won't find things maybe in sleep.
Just call out to all husbands and future husbands also. Please have a look at your spouse. Is she feeling well? Does she have OSA? Did you do something to make her have OSA? A quick question on to Dr. Sridevi. Sridevi actually is a pulmonologist. Also, she works in a center which deals with a lot of geriatric patients. So, Dr. Sridevi, with the number of geriatric age female patients that you encounter in your practice, What specific differences are you encountering in the sleep related breathing disorders in women
Yeah, thank you.
as compared to the general population?
Thank you for that question, ma'am. Geriatrics, I hope we all are aware that is age group more than 65 years. And as everybody is discussing, definitely the geriatric female to present with a different set of, symptoms as compared to the typical patients in the younger age group or the men of the same age group. So the typical symptoms would be snoring, weakness, apneas, or excessive daytime sleepiness. But women, they don't present with these typical symptoms. It present more with symptoms like insomnia or nocturia or tiredness, lethargy, mood disturbances or memory issues, something like that, and which can land them with a psychiatrist or some other specialty and not with a sleep physician as such. So, and also they have multiple comorbids to complicate the entire symptoms and the issue as such. So most of them, they are obese, they have diabetes, hypertension, hypothyroidism, and some OADs, the obstructive airway diseases, and all these can complicate the symptomatology further. And when you do sleep study in a female, so present with the typical increase in AHI, even though they are so symptomatic, so AHI index will be quite less when you test them. And they present more with hypopneas, or and there can be REM clustering, wherein the apneas can be present in the REM phase of the sleep, and even the desaturations cannot be very significant. So I think it is important to watch out for any female with these unusual symptoms and subject them to a proper diagnosis, and also treat them properly, even if they don't have the typical AHI, increased AHI or anything like that. So based on the symptoms, I think they deserve to be treated. Thank you.
Yes, very valid point of Sridhari. It's like when you're treating a child, I think if treating a person in a geriatric age group, especially a woman, is almost equivalent to that. They will not be able to express their symptoms. Like how pediatricians do so much of, I would say, CBI, CID job to find out what's happening. I think that same principle has to be applied to the elderly population, also the geriatric population, especially women of that age group. Because I think after a certain point, I think the women's say thinking process is less direct. They've born so many things in in their heart, in their lives. So they won't really pay much attention to some kind of sleep disorder. So sometimes it really gets ignored. So that I think we really have to keep an eye open for all those other aspects happening in the geriatric age group also. So now I would like to ask Dr. Shivani ma'am. What very unusual situations that you have picked up sleep related breathing disorders in women, especially in cross conversations? Like I think we don't even come in for sleep consultation, but you would have picked up your practice in a very unusual. Can you share some of your experiences in that aspect also, ma'am?
Uh, Thank you for the question, ma'am. I think my esteemed colleagues have discussed in great detail the most common presentation that we of course see in women, which sometimes is missed by general practitioners, is definitely perception insomnia. So they perceive it as insomnia, that they're not sleeping well, but it actually is obstructive sleep apnea when you subject them to a sleep study, in which, like Dr. Sri Devi pointed out, that the AHI may not be very high because they present more like a upper airway resistance syndrome. The desaturations may not be really high. They may have a lot of interruptions in their sleep. They do have a lot of wake periods. So all of that thing is very common when it comes to female subjects. In unusual circumstances, we've even picked up obstructive sleep apnea in a patient who actually, female patient, presented with restless leg syndrome and was being treated as restless leg syndrome by the neurologist for a very long time. And since she did not have any improvement, she was then subjected to a sleep study and was found to have sleep apnea. That's one. Fibromyalgia is another thing where a person has been labeled as fibromyalgia for aches and pains, and then was found to have sleep apnea. So those are very common that I see in my practice. I'm not sure about if others want to contribute.
Yes, would anyone like to add whatever ma'am has described about the unusual symptoms and presentations? So I'd like to add that sometimes the sleep apnea is actually picked up in consults as a pre-op evaluation. I would have been actually asked for, please come and see this patient and give a clearance for surgery. So the question sounds very simple. See the patient, assess, see the scoring on this post-operative complications. But when we get into the history, look at the patients, the habitus, everything, something really clicks that, okay, we might have to look for sleep apnea as well. As you are aware that after anesthesia, person with sleep apnea will go into respiratory failure. Sometimes they may have the component of obesity, hyperventilation syndrome. We go to type 2 respiratory failure post-op. So we also have to keep an eye on things. And with all the rising costs in medical care, sometimes doing something like a sleep study, if possible, before the surgery, is better to be done. Not able to have it done, at least get a CPAP organized for the patient. Patients are having type 2 respiratory failure. Maybe someone paid them because bypass for some time. So sometimes they are not even agreeing for anything. No CPAP, no bypass. So one of the things which I found is maybe put the extubation, put an nasopharyngeal airway, keep the airways patent so that they not fall over and cause an asphyxiating episode at that point of time.
Also, arrhythmias, recurrent arrhythmias is also another thing that we see, which is very.
So one more subtle thing which is not noticed so much is infertility. And when you go to the history, mainly it's because of their night shifts, irregular sleep pattern, late night because of the gadgets or watching movies or series, web series and all that. So this is not addressed, but basically if you track all these lifestyle itself, there's a lot of improvement in the fertility.
It's a very valid point.
With regards to both of you, I have to say that Dr. Gayatri ma'am, I would like to give an information to our medical fraternity. The one doctor who was behind this assessment during anesthesia is Dr. Malambati. Malambati score is the major thing when considering OSA diagnosis or the grading of palm scale or with the test is easy to intubate. That sir has recently passed away just 40 a month ago. Okay. Thank you for sharing this. And with Dr. Suchata's thing, shift workers have a special mention, especially if they are women. See, SCN, that is suprachiasmatic nucleus, has got both estrogen and progesterone receptors in that. So they have lot of workplace incidents and accidents in case, and their sleep need has to be activated in a very different manner. And even the pharmacotherapy for sleep effective in women than in women. For example, I think I will be right with Dr. Jamil's opinion. Zolpidem has been shown now to give only half the dose, not the regular dose which is given to the common community, which is to be given for women. So they act and respond in a different way and they perceive in a different way and they complain in a different way. That is the thing we have to focus when it comes to women patients.
So women are special. So remember that. That's the highlight. So what frequent complaints I hear in the clinic is like when we ask the patient, are you having any other complaints? Are you sleeping well? Are you eating well and all that? Most of the people can't sleep at all. This from the women. They can't sleep at all. So that's such a frequent complaint that I encounter. The question is asked to Dr. Ramya. Is this they can't sleep? Is it a psychosomatic complaint? Is it psychological? Is it a real complaint? Can you throw some light on this?
Somebody says, I can't sleep, so I think it is causing distress for the patient, and it should actually cause distress for the person on the other side of the table as well. So if you see, I mean, 1/3 of our lives is spent sleeping. So on an average 8 hours you sleep. So on our overall lifetime, we spend 1/3 of our life just sleeping. For 3 days. So look at the gravity with which we address the tissue or pursue the tissue. So if somebody says I can't sleep, usually the person may be meaning not 1 or 2 days, it will be for months or years together. So it should definitely trigger an alarm on the clinician's head. And we should not disregard the complaint. So many times people self-medicate or try to use some unhealthy coping strategies and just survive with the. But if we are to really get the gravity of the issue, we have to understand that it is a real complaint and it is often underdiagnosed and missed. So there is nothing like the mind-body duality is no longer valid in this scientific era where mind is conceived only as a function of brain.
So I needless to say, all the supranational plays around. It's not a hypothetical entity that I want to sleep, but I can't sleep. So it's a very, very real entity. It's a biological entity. So we need to really consider the complaint with so much of clarity, and we have to look at the complaint with the biological, psychological, and social angle. Does the person have an adequate opportunity to sleep? Does the person have an adequate environment or the stress level or the lifestyle permits him or her to have a good sleep? Are there biological factors ranging from simple things like anemia, thyroid issues, PCOD, hormone imbalance? So, what are the other morbidity that can contribute to a poor sleep? So, definitely not to ignore somebody who's saying, I can't sleep well, doc.
So don't ignore that complaint of insomnia. It's something to be really dealt with. So going on that kind of a track, a question off to Dr. Kavita ma'am. See, as a physician, how do you deal with all these women coming in and asking we prescribe all those sleeping tablets? Are you having a low threshold for the prescription, or would you really want to know that does that prescription really hold true? So I find this is a very common this one request from the patients like, I'm not able to sleep. Please give me sleeping tablets. So I think it's all those cinema. You take one tablet and you become flat and unconscious. So I tell my patient nothing is going to happen like that, but let me know from where. What do you feel about that?
It's a very important aspect of sleep practice. Yes, my answer will be a polite no if they ask for a prescription for a sleep drug, but I will never express it though. What I will do is I will just ask them to be more specific about their why they're asking this and what's exactly the complaint they have which has made them to give this request to me. And I will definitely explain to them, even if it is insomnia diagnosed per se, pharmacotherapy is going to be a short-term relief only. It is not the recommended treatment for insomnia anymore. Insomnia has been identified as a unique morbidity or a disease of its own. Definitely, pharmacotherapy is not the first line treatment for that, whereas CBTI, the cognitive behavioral therapy for insomnia, and another one which is also in the software apps and most of the digital devices, they do incorporate something is known as BBTI. Cognitive behavioral therapy to treat insomnia, but everything acts together in that because for a short while, maybe under the prescribed thing from a physician, they can have, but definitely do not let them request or even ask for a prescription.
Yeah, 100% agree with you, Dr. Kavita ma'am. So the request may be there. You don't have to. It's not that you have to sit and tell yes for all those requests. So put your foot down, see what needs to be done, and deal with it. That's what I really want to emphasize. Writing a prescription is hardly going to be 10 to 30 seconds for us, but it's going to be abused over and over again. I think that we should not encourage. So now I'd like to have a question now to Dr. Sugata ma'am about the type of sleep disorders you encountered in the special category of patients, the pregnant women. What do you really say? Because I think as women pulmonologists and women physicians, we might get a lot of other consultations other than pulmonology actually. So we like to learn from you also then.
First, when a pregnant lady comes, my first statement will be pregnancy is not a disease, and it is more physiological changes which happens in your body. So the lady should understand that because for each and every small thing, otherwise it will keep on coming to us. Just that we have to instill. And there is a lot of hormonal shift which is happening in the so early pregnancy because of
पापा बहुत जल्दी उठ गए ना हम लोग 7 बजे
all that she'll have frequency
मुझे
of
भी नींद आ रही है मैं तो 3 o'clock उठ गए
and towards later when there is head compression of that maturation with frequency will be there. So because of that, sleep will be disturbed. Other than that, because of the growth,
खाना था शिबू
the abdomen,
शिबू कीड़े बोला नहीं खाना खा के जाना
she
पनीर
have
ले लो
back pain, more of leg cramps,
ठीक है
all that, and because of the
और वो
fetal
रोटी ले लो
movements, her sleep is definitely takes a toll. So the circadian rhythm in the pregnant female is affected. So morning time also she might be little not very active and she'll want to sleep in the afternoon. So her sleep pattern is totally affected. Most of the last trimester or just 1 month before delivery, they'll say, "தூக்கமே வரவே இல்ல," அப்படின்னு. So we have to counsel them. So the counseling plays a major role. And not that the anxiety about, to deliver the delivery, what will be the process, what will be the pain schedule. And she has to, take a break in her career, that psychological impact. And about raising a child, everything that all these put together, definitely the sleep disturbance will be there in the pregnant female. But I feel counseling helps a lot. Recently I had a female, I could diagnose it was postpartum blues going into depression, but it was rightly addressed by the family. The husband brought her, so I said, let her go back to her mom's place and relax for 2 weeks. So it's just a small things, but if the females are able to come out and talk to us, that will be very good. So each time it is not, as madam said, it takes hardly 30 seconds to prescribe, but counseling helps a lot. I feel counseling helps for more than 50% in our day-to-day practice.
Yes, I 100% agree with you, ma'am. I think as physicians who are all always are dealing with a special category of patients and various forms actually to pregnant women. I think keep your ear about 1,000 times bigger than what you give it off to other people. Listen to them, not then come on. Oh, I have a friend and I'm not allowed to do anything. That's what I tell my patients. You can't simply prescribe something because I would say the earlier generation was a little bit acceptable, but the newer generation, give me something, I want to sleep, I want to do this, I want to do that. So they said, can even climb the mountain, can do a marathon also, but not now. So wait for some time, and then everything will be sorted out. So I think we just have to keep reassuring them as well as us also, so they don't get into other issues. Very interesting question to Dr. Manivaran. How actually the female patients accept the diagnosis of OSA? It's been a challenge to me actually. Are they shocked? Are they very reluctant to accept it? Are they very disappointed? Can you share your experience, please?
Very easy to convince the husbands they have sleep apnea. So usually what I tell, instead of sleeping with your wife, you have to sleep with the sleep apnea. So usually they'll get convinced. But we can't say the same thing.
Then they will use it like cancer.
It's a very, very difficult situation. So I find it very difficult to counsel. When the counseling the husband was much easier. Counseling the wife was very difficult.
As I used to say, in Western countries, one of the farmers customers divorces after the sleep apnea, this is not. So usually explain the consequences definitely will get convinced.
Yeah, I think we should also give them what's the ground reality and hope that they don't land up with another divorce lawyer. But seriously, when you're dealing with all these elderly women with the insomnia, especially associated with dementia, what challenges do you feel in treating them?
Thank you, ma'am. I think I don't face any challenge because I don't see insomnia dementia per se, as a respiratory physician. So I think most of the patients just go primarily to a psychiatrist or a neurologist to start with. But some of my patients who have obstructive airway diseases, they do come to me with the symptoms of insomnia. And especially in a patient with dementia, I think they don't they will be handled by some other person, caretaker or a caregiver, they'll be handling and they will be the ones who will come and tell me that the patient is not sleeping at night. So first, what I do is I take a proper history, as to what activities the patient is having in the daytime and how is the sleep pattern. And what I feel is most of these dementia patients, they will be sleeping most of the times, multiple naps during the daytime. And that is the reason why they're not sleeping at night. I tell them that the cycle has to be reversed to start with. And also, the stimulants in the evening, what they're consuming, that has to be cut down. And if at all, if this is not helping, so probably I'll discuss with my psychiatrist or, the geriatrician to start if it is okay with a small dose of melatonin. And, it can be, really challenging for the psychiatrist also to, administer a cognitive behavioral therapy in a patient who is demented. And also the other, the drugs which we normally give for a patient with insomnia can be, have its own side effects and complications. So I think all these are the challenges.
So basically, what you're trying to tell us, it's a team effort. I think it's not the pulmonologist, it's not only the psychiatrist, not only the geriatric physicians. All of us have to put in our head thinking caps and start treating the patient. So this is a carrying question from Dr. Manivaran's thing to Dr. Shivani. What challenges do you face when counseling the women with obesity to use an overnight CPAP? Are they accepting it, or what's your experience actually?
So, see, ma'am, in our country, the mental framework of women is usually of the caregiver. You know, they are like caring for their families always, and they do not give their own health priority over providing care to the rest of the family. And I think that is a major reason that women present late. They do not really present with symptoms of sleep apnea because they do not think that they have a problem. For anything and everything, women just tend to delay going to a doctor until it is to a point where they cannot take it anymore. So I think that underdiagnosis definitely remains a major challenge. But giving CPAP therapy to realize that women actually need lower pressures. So it was always a challenge for females to accept PAP therapy because they would always find it more uncomfortable. Also, the masks are not made for a female's facial structure. They were usually designed for a man's facial structure. So the mask leak is going to be extremely high, again, adding to the discomfort for the female patient. So all of these things and the entire acceptance of them having to sleep with an equipment overnight, like sir said that it's easy for him to tell a male patient that they'll have to sleep with the machine instead of their wife. And like sir correctly said, that we cannot say the same thing to a female. So I similarly, that entire stigma for them is much, much more than it is for males still.
Yes, certainly, ma'am. You see, that is the key word, stigma. That's what I see. You see, one of the patients who had come in for the clinic recently, the son-in-law is using CPAP. So she knows what is that CPAP, what is the sound, what's this machine, and all those things. So she almost agreed to the sleep study. She was diagnosed to have sleep apnea. Counseled her for lifestyle changes, weight reduction, everything. But when it came to the point of the CPAP use, she said, no, I won't keep it. Vachimata. So still she's in the counseling process. We know by next year, I think, what is going to happen to her. So, so you have an interesting set of questions, and I'll end the panel with just a quick question to ma'am, to Dr. Shivani ma'am. So we've got all those anti-obesity drugs coming in the market. Each company is coming head over heels and coming and meeting all of us. Please prescribe this. It's as well something like on B12 injection actually. So what do you feel about the role of those anti-obesity drugs in the management of obesity? Is it a one-stop solution? Is it going to give a miraculous recovery to them? What's your view, ma'am?
So a few things on that, ma'am. First and foremost, that PAP therapy still remains the gold standard for treatment for sleep apnea. Anti-obesity injections, drugs are actually pharmacological therapy is still an adjunct or an alternative form of therapy when people are not actually agreeing to use PAP therapy. So that is where we stand with that. Now, in terms of course, there are side effects, but we also need to remember that in India, it is only actually yet approved for obesity and not for treatment of obstructive sleep apnea. It can actually be, in the US FDA has approved it for both obstructive sleep apnea and obesity. But in Indian regulations, it is still only approved for obesity and not for primary treatment of obstructive sleep apnea. Now, in obese patients, of course, sleep apnea is more commonly seen. The reduction in AHI because of loss of weight and adiposity could be a result of the loss of weight, and obesity could result in the lowering of AHI, but you cannot prescribe only because the patient has obstructive sleep apnea. And even in patients of obstructive sleep apnea, if and when it gets approved, the BMI criteria has to be kept in mind that it is not for anybody and everybody with OSA. We have to keep in mind that it is only for obese people with OSA that we can eventually prescribe it. So far, I am not prescribing it myself. I am sending my patients who I think would fit into the criteria of obesity and diabetes to the endocrinologist because we are actually not approved to be prescribing it ourselves. So that is what I do in my practice, because it's important that they keep in mind, of course, not only how the patient's sugars are behaving or what kind of weight loss that the patient has had, but also keep in mind that there is a lot of muscle mass that happens. So that myopathy is also something that needs to be addressed um, along with that. So these are things that they should keep in mind when we are prescribing, especially terzepatide, which is the new kid on the block. In terms of side effects, there are now few reports of retinopathy, probably because of rapid control of sugars. So retinopathy is another thing that we must keep in mind. And especially since we are talking about a female obstructive sleep apnea, in females of reproductive age group who are on oral contraceptive pills, if we put them on terzepatide actually lowers the efficacy of the oral contraceptive pills. So that's something that we must really keep in mind.
Thank you so much, ma'am, because for highlighting on this anti-obesity drugs, because many of the patients are Googling and a lot of WhatsApp messages are there. They've sort of marketing it as a miraculous drug. So I think it has to be taken with not a pinch of salt, with a bucket of salt.
Just very nice just highlighting about the GA agonist. The thing is about in women, the gallstones incidence very high. And when once you give this, it is a very good drugs. Some may get 10-15%, correct? But sudden drop of weight may result in cholesterol. So one has to be careful. The other thing is not that about some reports that few interior have been reported. So it's very the worst thing is that it's effectiveness. Many people discuss it after a year. So it is evolving like you sleep contemplating. We hope that DM so that we can discuss along well.
Thank you so much, sir, for highlighting those points as well. So now we'll come to the end of this panel. Discussion on sleep performance in women. I thank all my co-panelists, Dr. Kavita ma'am, Dr. Simani ma'am, Manimaran, Dr. Ramya, Dr. Sridevi, and Dr. Sujata ma'am for sharing their insights on sleep disorders in women and practical realities and how we deal with this condition in the very special population of women. Thank you.
Thank you so much. Thank you so much, panelists and our moderator. So we call upon Dr. Gopal Rawal sir to come up and felicitate all our panelists and the moderator for the Mahavir Modi sir. We also call upon Dr. Mahavir Modi sir to please come up on stage and felicitate our guests. First, we call upon Gopal Rawal sir to felicitate Shivani Swami ma'am. Mahavir Modi sir will now felicitate Dr. Sridevi ma'am.
Come. Correct. Proceed. Yes.
Request Gopal Rawal sir to felicitate Sujata ma'am. And now request Modi sir to felicitate Manimaran sir.
I request Jaraman sir to felicitate Rana Sampath ma'am. Now I request Shivani Swami ma'am to felicitate our moderator for the session, Gayatri Devi ma'am. Thank you so much. Thank you so much, our respected faculties and our moderator. So, in the bizarre world that we exist in, the first solution that we come up with to keep track of our routine pace is to give up sleep. This forum has been construed to ensure that this vital essential routine is not given up and we sleep well and come up with viable solution to live better. We now move on to the first keynote session for the day on the topic sleep health and solutions, sleep solutions. I now invite our chairpersons for the session to occupy the seats on the dais in a minute. I now invite Dr. Prasanna Kumar Thomas sir, our very own Prasanna Kumar Thomas sir, senior consultant pulmonologist from MGM Healthcare. Sir has been guest faculty, guest lecturer at various international and national forums, and he is known for his oration worldwide. So I welcome you onto the dais, sir. Next, I invite on the stage Dr. Balamurugan, sir. Balamurugan, sir, is consultant pulmonologist, professor, Department of Respiratory Medicine from ACS Medical College and Hospital, Chennai. He has been principal investigator for over 75 clinical trials. He is published over 20 different publications in various international journals. And he has presented papers in national and international forums, various scales on various.
She's a secretary of Southeast Academy of Sleep Medicine, secretary Sleep Education and Research Society. She's a member of governing body ICS. Now it's my great honor to once again welcome our chief guest, Dr. Mahavir M. Modi, as the keynote speaker. He is the director of Modi Clinic Excellence in Chest and ENT Pune. He is a consultant pulmonologist in Ruby Hall Clinic. President Sesam, we are truly privileged to have you on, sir.
From there on.
To one and all, I think it's a great pleasure and a privilege for each and every one of us sitting here to be present in this place. And I thank Dr. Jayaraman and the team for having invited us here. And I thank the audience for having spent their mornings here with us as well. We have with us a very eminent person, a person that I've known for a very long time, an excellent and a great friend of mine, Dr. Mahavir Modi, and I think it's a great pleasure to introduce him from Pune. I don't honestly think he needs any big introduction. The fact that he's a man who is committed to things that he's really committed with, and I think that's really very important. When you look at things that people are committed with, and I think if the commitment is whole and wholesome, I think it makes him a totally different person. That's exactly what he is standing in front of us today. Sir, it's a great pleasure for having you taking time off to be with us this morning. And we welcome you with open hearts and open hands to this auditorium to give your talk on sleep. Thank you very much, and please go ahead.
Thank you. Thank you so much, sir. Thank you for those encouraging words. Really made my day. I think uh, calling me sir itself means a lot to me from a professor who's so senior to me. So thank you, everyone. Thank you, Dr. Jayaraman. Thank you, Shivani and Gopal, for through CSM, we are doing these kind of activities. And Jayaraman, your activities are always so much with enthusiasm and so much of wisdom in all of whatever you do. So my talk is basically about sleep health and then what kind of solutions we can give to these kind of sleep problems. Recently, American Heart Association has added this 8 critical point or a marker in everybody's day-to-day life so that the health or the patient's well-being can become better and better. Of course, we all know that the weight, the lipid profile, blood pressure, sugar management, daily exercise, what you eat, they all are important. But the 8th factor which has been added by the American Heart Association is the sleep. And we all should follow a proper sleep pattern. And that's the reason the sleep health is very important. And this year's the tagline for the sleep this 2026 is basically sleep well, live better. Okay, so we all have to improve our sleep health. So when we say about sleep, what are the different functions of sleep? So of course, anybody, as I just mentioned, that if you don't sleep even for one night, and then the second day you feel like as if you're a zombie, you don't know what you are going through. So sleep is important for n number of functions. Most importantly, the hormonal functions are very important because we have growth hormone, the thyroid, the corticosteroids, they all have balances during their sleep pattern. So one has to be very important to know that, what all sleep functions are there. Along with this, in my 20 years of practice, what I have understood is sleep is of paramount importance, basically to improve your immune function. Anybody who is having recurrent infections and all our respiratory patients, those who with asthma, COPD. So if we just ask them to improve their sleep pattern, because all your basically immune system, the T2 cells, they basically get stimulated in your deep sleep. So sleep is of paramount importance for improving your immune system. Third and the most important is, of course, the cardiovascular health for all of our patients. Then your memory function. Okay, so sometimes if you just want to revise certain things, and just before going to bed also, if you try to revise certain things and go to sleep, it is said that, and you can also of course observe that you can implement those things better in your life. That is because the sleep can actually improve your memory functions, and the cognitive functions are all very much developed during your sleep pattern. Along with this, the cardiovascular health is of paramount importance, and sorry, I'm just not able to see this. And the hunger control, because the hormones like ghrelin and leptin, they're all released during sleep. And somebody who's not having proper sleep, they are more prone to even develop obesity, because it is not only the obesity causing sleep issues, but even the sleep issues can lead to obesity, because your ghrelin, leptin, both the hormones, they have strong association with the sleep. So somebody who's sleep deprived, definitely we can have people around us, those who are sleep deprived. And these people, they may have a lot of central or the cognitive impairment. They may have memory imbalances. There may be autonomic dysfunction or the poor immune system, because of which there can be development of n number of diseases. There is strong association of this pancreatic cell functioning, and because of which patients with poor sleep, they are more tend to develop diabetes and insulin resistance. In the heart, there can be improper irregular heart rate, and the risk of heart disease is maximum if the patients are not sleeping well. And of course, in the muscle, joint, and pains and aches, as well as the risk of obesity, they are all related with the sleep deprivation. So it's all important when we are having a holistic approach towards any kind of disease for our patients. We have to ask them to improve their sleep pattern. So, of course, we have these certain kind of functions which are important for each and every individual. But thought I will just bring your attention to the sleep and athletes. Okay, so anybody can tell me that how much Roger Federer must be sleeping, or how much your marathon runner, what's his name, Hussein Bolt, how much these people they sleep? They sleep around 12 hours a day. Okay, it is not that we should sleep 12 hours a day. It is basically for athletes that these people they should sleep more to just improve their muscle functions. So muscle recovery, high levels of testosterone and low levels of cortisol, they are required, and they are all basically achieved by sleeping proper. Memory retention, as I was just saying that, there are N3 sleep, there is REM sleep, and in REM sleep, what you can basically develop is something which is called as a procedural memory. So somebody who's having how to win over the crisis, or how to attack the opponent, okay, how to win your laps. So all those things, they can be basically be learned and then remembered better when you are sleeping well. So it is very important for all of you to have a better REM sleep as well as N3 sleep. N3 sleep or the deep sleep is something which is very important to have an explicit memory. For example, when is Dr. Gopal's birthday, or when is Dr. Shivani's birthday? So some people, they can immediately recall birthdays, they can immediately recall certain kind of memories. And what is this? This is because of the proper N3 sleep or deep sleep. If they have, then there will be definitely more and more memory. So the athletes also, they need these kind of memories because they have to attack the opponent, and these kind of micro movements, the fine tuning can be done by having a better sleep quality. So this is something which is very important, that the athletes, those who sleep for maybe less than 6 hours, they have more chances of developing injury. Okay, so that is again one of the important function of developing sleep. So once we know about the functions of sleep, we just discussed about what all detrimental effects can happen if a person is sleep deprived. Now I will take you through one agenda about the sleep characteristics, how is the sleep architecture, and what is the component, or what is how the multidimensional sleep health is described in our day-to-day life. So we have two types of sleep. One is a non-rapid eye movement or non-REM sleep, and another is the REM sleep. And the humans, they go through this non-REM followed by REM. So that kind of sleep cycle. So each sleep cycle is basically, there will be N1, N2, N3 sleep, there will be REM sleep, and there is period of wakefulness in between this. And we can study all of this by doing an overnight sleep study, where we'll have EEG, EOG, EMG, chest and abdominal movements, and by which we'll be able to find out what kind of sleep stages the person is having. So when we say a sleep cycle, what does a sleep cycle means? That, the moment you go to sleep, since that time to the end of your REM sleep or the first REM sleep, that is one sleep cycle. So N1, N2, N3 are N1, N2, N3 are. So that is how your body should go through the stages of sleep. Sometimes it may go from N1, N2 directly to REM sleep, and sometimes it may not enter into REM sleep. So patients with sleep apnea, they basically are very light sleepers. The moment they go into N3 or deep sleep or into the REM sleep, the body will keep on giving them arousals. These micro arousals keep on happening, and that is the reason they don't enter inside the REM sleep. So their sleep cycles are fragmented, or they are not complete, and that is the reason they will develop a lot of daytime somnolence and other whatever dysfunctions of sleep deprivations, what we just thought about, what we talked about. So the sleep architecture, roughly, we spend most of our night into N2 sleep, but we should have around 20-25% of REM sleep, around 20-25% of your deep or the N3 sleep. So patients, those who are having sleep disorders, they may not be able to pass through all these sleep stages, and making them more and more vulnerable to the certain kind of lifestyle diseases. We have a lot of youngsters, but similarly, we have a lot of elderly population also over here. And sleep architecture in elderly, because we get a lot of patients, sir, neend hi nahi aata hai. Okay. So we just have to understand that a neonate sleeps for around 20 hours. Similarly, an elderly individual may be able to sleep only 5 to 6 hours. So as you age, the sleep automatically it goes down. Also, these patients, they will fall early in the bed, or they will fall asleep early in the bed, and they will rise also in the morning. So they have a early or the advanced circadian phase kind of pattern. So you don't have to keep on giving sedative to these kind of patients. So this is a physiological thing which we all should be able to understand and implement in our clinical practice. There are certain kind of sleep parameters when we talk about the sleep health. And when you just look at your sleep report, so I think we should be able to see whether the patient's sleep, all these sleep parameters are fulfilled or not fulfilled. For example, sleep onset latency. The moment you try to sleep, and since that time when you go into the sleep, so that is a sleep onset latency, it should be around 10 to 20 minutes. So in your sleep report, you should be able to see how much is the sleep onset latency. Anybody who's having a sleep onset latency of more than 30 minutes, we say that it is abnormal, and then these patients, they need some kind of medical help. REM latency, the moment you go into the REM sleep, that is your REM latency, it is around 90 to 110 minutes. Some patients, they may not go into REM sleep because of their obstructive sleep apnea or because of other kind of disorders. So again, they will need evaluation. There is one more parameter which you can see in your sleep pattern, in your sleep report, and that is called WASO, which is wake after sleep onset. After going to bed, how many times did you actually get up, and what was the total duration? Suppose you're sleeping for around, say, 7 hours. So out of that, the total time when you're actually awake, that should be less than 20 minutes. So anybody who's having wake after sleep onset, or they are awake throughout night for more than 20 minutes, then it is abnormal. Total sleep time, it should be between 7 to 9 hours. Anybody who's sleeping maybe less than 6 hours or even more than 9 hours. So studies have shown that, not about athletes, but about other people like you and me, if we are sleeping for more than 9 to 9.5 hours, again, there are more chances of developing cardiovascular morbidity and mortality. The reason being, you are spending more time in the bed and you are giving less time for yourself and for the activity. Okay. So 7 to 9 hours of sleep is something which is important for all of us. And sleep efficiency, how much time you were actually in the bed and how much time you slept. The ratio of these two, it should be more than 85%. So if you see these basic 5 parameters in your sleep study report, I think you should be able to know if you are a normal sleeper or you need some kind of advice, or you need some kind of further kind of treatment to improve all of your sleep parameters. So when we talk about sleep health, we as a doctor, we always keep on asking the patients only one particular thing. Kitna ghanta sota hai? Okay, so they may say 6 hours, somebody may say 5 hours, and on the weekends I sleep for 8 hours. Otherwise, I get only 4 hours of sleep. So duration is not the only thing which is important for when we call about sleep health. Sleep health is basically multidimensional. We have to not only consider the sleep health for the sleep duration, but we have to give a lot of importance to the regularity of the sleep. That means what time you actually go to bed, and each time out of 7 days, there may be maximum of around, say, 30 minutes to 1 hour of a difference can be there, but otherwise it should be a sleep regularity, which is very important. Satisfaction, how refreshing your sleep was in the next day, how alert you were the next day, the timing for the sleep, and the efficiency. So it's not only duration, it is along with the duration, you have to see about the regularity, about the alertness, about the satisfaction, timings, and the efficiency. So when you consider all these parameters, then you will be able to know if your sleep health is proper or no. So how do you remember this, and what is the most important? So we can say there are some primary targets in achieving the sleep health, and there are some secondary targets in achieving the sleep health. So primary targets are basically regularity of the sleep, timing of the sleep, and duration of the sleep. So if the secondary targets are, if you follow your regularity of going to the bed, timing of going to the bed, and duration of the sleep, your secondary targets like your efficiency, alertness, and satisfaction, they all should automatically improve. And if you want to follow only one thing which you want to tell your patients, so I think what is most important is ask your patients to go to bed at one particular time. Okay. Even if they just start following this particular thing, definitely their sleep health can improve a lot. So after the sleep duration comes the sleep regularity. As I said, that there should be less than 1 hour of difference in each day out of all 7 days, because there is a lot of trend nowadays, especially in the youngsters or those who are working in the IT sector, that they will compensate their sleep by sleeping more on the weekends. So they may sleep 10 hours on the weekends and 4 hours in the other 5 days. And it definitely doesn't help them for sleeping, for improving their sleep health. It has to be regularity, which has to be maintained all 7 days. Sleep timing. So a lot of literature that what time I should go to bed. So I basically feel that we all have to tell our patients and to ourselves that we have to follow circadian rhythm. So whatever is as per the sunlight, so you have to follow the same kind of pattern. It refers to sleep period in 24 hours, and we have to calculate what is called as sleep midpoint. So somebody who's sleeping between 11 o'clock at night to 6 o'clock in the morning, so around 7 hours of sleep. So midpoint of this is around 2:30. So your sleep midpoint should be between 2:30 to 3:30 a.m. So if your sleep midpoint is between 2:30 to 3:30, so that means that your sleep timing is perfect. So somebody who's sleeping at night or 2 o'clock and getting up in the morning at 10 o'clock, so then that is not supposed to be a perfect sleep timing. So we just discussed about this particular slide, but there is one particular scale. Sorry for the, I mean, it's quite blurred, but there is one particular way by which you can remember this, that is called are you sated? Okay. So in this, the R means the regularity, that how regular is your sleep. Then S is for the satisfied, how satisfied are you with your sleep. A is for the alertness, that are you able to stay awake throughout the day and you are not excessively daytime sleepy. About the timing, if their midpoint of the sleep is between 2:30 to 3:30 a.m. The efficiency, as per the sleep report, if it is more than 85%, and the last one is about the duration. So duration comes last in this particular scale of are you sated. So you can use this particular scale to know if your sleep health is proper or not proper. So if your sleep health is not proper, there are certain kind of disorders, and I think we have a lot of sessions today to know about all of these patterns, what we can have. But the most important sleep issue because of improper sleep health is the insomnia. For insomnia, we don't have to keep on prescribing tablets to the patients because gone are the days where you have to keep on writing sedative pills for these patients. And we have behavioral therapies and cognitive behavioral therapies which can be used for these patients. Then we are going to discuss a lot in detail about obstructive sleep apnea and about the CPAP and those kind of therapies. Then we have disorders like hypersomnia or the patient, those who feel excessive daytime sleepiness. Again, when we are having a patient, those who have hypersomnia, take detailed sleep history because the inadequate sleep at night is the commonest cause of hypersomnia in the daytime. And then there can be certain medical disorders which can cause this. There can be cataplexy, there can be narcolepsy. So those kind of disorders are also there. Biological clock disorders, they are again very important. We have a lot of patients, those who work in the shift, they work at night time and in the daytime they have to go to, circadian rhythm disorders, or in the adolescents because they go to bed at night, and in the elderly, those who go to bed early. So we have advanced circadian sleep disorder in elderly, and we have delayed circadian rhythm in adolescents. Then there can be parasomnias. Recently, I had a patient, those, they walk in the sleep, they talk in sleep, they can fight in sleep. So there are all kind of parasomnias which are there. And then there can be sleep-related movement disorders. Okay, there are people, those who tend to eat a lot during night. So these are all disorders which come across the spectrum of sleep disorders. And of course, we are going to discuss many of them today in our later part of the day. One more address or one more key thing which I want to discuss is about, and we should be telling our patient, is about to maintain their circadian rhythm, because we all have a biological clock in our brain, and that is your suprachiasmatic nucleus. And the suprachiasmatic nucleus basically functions by the sun rays. So the sun rays enter through the sun rays enter in your eyes through the retina, and through the retina ganglionic cells, through the optic nerves, it gets into the suprachiasmatic nucleus. So we have this biological clock, and this biological clock will function in accordance with all other biological clocks. So you will be surprised to know that each and every organ in our body, they have their peripheral clocks. For example, liver has its peripheral clock, lung has its peripheral clock, heart has its peripheral clock. All these clocks, they relate to the suprachiasmatic nucleus, which is your major clock in the body, and they interrelate with each other so as to have a harmony inside your body. So anywhere where you are trying to disrupt the circadian rhythm, it is definitely going to cause n number of diseases, and there are certain kind of even cancers which are related because of the dysfunction of the circadian rhythm. So we have to follow, and we have to tell our patients to take help of the sun rays and follow the circadian rhythm, not only for the sleep, but the circadian rhythm has to be followed even for eating, even for exercise, for sleeping, and for your daily activities. For everything, if you follow the circadian rhythm, it will definitely be useful to improve your not only sleep health, but overall health quality. So some more facts which I always tend to discuss, we are going more into the physiology about the temperature regulation and sleep. So how do we sleep? We all sleep not in the sitting position, but we all sleep in the lying down position. And why we sleep in the lying down position? Because there is a dissemination of the energy. When you lie down flat, all of your energy from your body, it is disseminated to the surface. So surface area increases, and that's the reason you sleep in the lying down position. So you always ask your patients to lie down supine and not like semi-recumbent position. And what it is basically to do with is we have to create a micro environment around us. Because of this micro environment, for example, have a chadar, have a pillow. So all this we are creating a micro environment. It will basically help to disseminate in a temperature from your body. And that is the reason, because you will normally fall sleepy when the temperature of your body is on the falling curve. Okay, so that is the reason that we should be always following this. If somebody asks you what kind of mattress I should take, the mattress should have the high heat absorbing capacity. For example, coir mattress. Why you tend to fall sleepy on the coir mattress easily? Because the coir is something which will absorb heat from your body. The body temperature, core temperature will go down, and that's the reason you can ask your patients to have certain kind of advices if they are not falling sleepy, especially in the elderly. I tell all my patients that if you're not falling sleepy, you should take a warm shower bath 2 hours before going to bed. Okay, because again the vasodilation happens 2 hours before, and then your body gets cool, and that is the reason there will be vasoconstriction and the patients can go to sleep very easily. Similarly, they can keep iPad on their eyes, or they can put a hot pillow on their shoulders half an hour before going to bed. So they all have been used as a specific scientific method, because your temperature regulation center in your brain and your sleep promoting center in the brain, they are side by side. If your temperature regulating center is controlled, then the neurons from this temperature regulating center, it will definitely intermingle with the suprachiasmatic nucleus, and you will be able to fall sleepy immediately. So that is the reason that you should be able to use certain kind of these advices for your patients. Keep 3 hours of gap between dinner and sleep. Again, very important thing. For example, there are certain kind of religious places, religions in India, and Gopal must be aware that they don't eat after sunset, and this has a lot of logic. Because if there is 3 and 4 hours of gap between your bedtime and if you're eating, definitely you will get a better sleep quality, and all your diseases can be in between. I read in one of the Ayurvedic books that if you follow this particular thing, 100 years of life is guaranteed, but it has to be from the first day of your life. I think we have already lost it, but still we should be able to practice it as much as possible. Keep a good gap between of 3 hours between eating and going to bed, because you are even the lower tone of the GI sphincter. So it also has a, it has a lower tone at night, and there is a more and more regurgitation. So our patients with obstructive sleep apnea, they can come to you with a lot of dry cough. And what's the reason of dry cough is because of obstructive sleep apnea, they get micro arousals. During arousals, there is a lot of reflux, and because of this reflux, they basically present with dry cough. So they get more and more predisposed to GERD. So it is not the GERD causing obstructive sleep apnea, but it is even the obstructive sleep apnea causing GERD in these kind of patients. Coffee and sleep. So I think many of us, we need coffee nowadays, and at present, because of this monotonous lecture, if it is going on. So coffee, basically it is adenosine antagonism. So how does coffee can actually decrease your sleep is, and adenosine is something which is required to for the maintenance of the sleep. So if you're having adenosine antagonism, definitely coffee can block this adenosine, and because of which you tend to become more awake throughout the day. Also, coffee can cause vasoconstriction in your hand and in your legs, because of which again temperature regulation, and you may not be able to fall sleepy during that particular time. So I think there are certain things which we have. If I have some more time, we will just go through what are sleep solutions for these kind of then sleep health. We have certain kind of sleep clinics, and I think Jayaraman also is running a beautiful sleep clinic in the city of Chennai. And we have different kind of sleep laboratories. We have this home sleep apnea test. Then we have watchpad kind of devices. Recently, I was in NHS, and over there, each and every person who wants to get a sleep study done, they get basically screened by this device, which is called watchpad. So they just wear this kind of wearable device at night, and they do the study for 2 to 3 nights. And over there, they will become to know how much is the sleep efficiency, how much is the REM sleep, non-REM sleep, depending upon their peripheral arterial tonometry. So these kind of devices, watchpad, should be available in India soon, because your one night of sleep data, what we are doing on that particular night, it may not be able to actually reflect it's what's happening to the patient for all 7 days a week. Okay, because on the day of sleep study, the patient may be anxious, the patient may not have slept properly. So that one night of sleep study may not be able to give you the complete picture. So that is the reason we can have these kind of devices, which along with your sleep study can definitely aid in the treatment. Then we have certain kind of devices. One of these devices called actigraphy. So actigraphy is basically accelerometer, which the patient wears in his just on the wrist again. And these devices will basically know how much is the activity of the person throughout the day. So they can be devices can be used for disorders like insomnia, for patient those who say that they know they don't actually go to sleep, but they are actually sleeping. So how much time the patient was active throughout the day. So 14 days of data and the circadian kind of disorders, they can be all diagnosed with the help of devices called actigraphy. And as I was saying that because your one night of sleep study may not be able to give you the entire duration of 7 to what is happening to the patients every night sleep. So there are devices which are like kept inside the patient's bed. So they are called as a balastocardiogram. So these are like they will determine the oscillations during your heart and respiratory movements. They are put inside the patient's mattress, and they can give the data about the patient's sleep efficiency. Nowadays, we all have Apple Watch, and the patients come with Apple Watch data, and then they will say that, see, I am not able to sleep well, but they are the one which will be able to give you some kind of sleep efficiency. They can never replace a sleep study, but you should be able to know how to interpret this data from your Apple phone or whatever the wearable devices these patients are using. So community level of sleep studies, again, something which is becoming very, very important. And we have to have access for all these kind of, I think this is the future for sleep medicine. And as sir was saying that even endocrinologist and neurologist and ENT, so all these they should be part of your sleep management. So multidisciplinary management is something which is very important because along with the weight reduction, we have ENT approach, we have psychiatric approach, we have endocrine approach, and we have newer and newer drugs like tirzepatide with this Vermont OSA trial coming up in big way for weight reduction, and that is how it can help in patients with OSA. Of course, CPAP, dental, oral appliances, and mandibular advancement devices, and better dental practitioners are also coming. Recently, I came across in Pune, one dentist referred a patient after doing a sleep study to me, and I was very happy to see that the circle is definitely improving. And as at CSM also, we are all inclusive, and we want more and more patients to more and more people to come over, be a part of CSM, and spread the word by mouth. That more and more specialties can get involved in this kind of multidisciplinary treatment. Surgeries, role of surgeries for tonsils, for adenoids, for septoplasty. So I think we have discussed almost a lot of things. I first discussed about the functions of sleep, about from the memory enhancement to the hormonal balances to the immune system. Then we discussed about what can be the improper sleep and what can be the detrimental effects on the health. We discussed about sleep in athletes and how REM sleep and NP sleep are basically important in improving your explicit memory and procedural memory, and how much time athletes are actually sleeping and they should sleep. We talked about different kind of sleep stages, about non-REM, REM, what is the sleep cycle, and what happens in obstructive sleep apnea, that they are not going into the deep sleep. And we talked about multidimensional aspect about sleep health, where we don't give only importance to the sleep duration, but we should be giving importance to their timing, their regularity, about their satisfaction, alertness. So all these 6 components should be taken into consideration when we are talking about sleep health. We talked about the RU Sated scale, where we can come to know about your sleep health. We talked about circadian rhythm and how your brain, the suprachiasmatic nucleus, and various other peripheral clocks in your body, they can work hand in hand, and it can improve your day-to-day function as well as holistic approach towards the health. We talked about temperature regulation, about lying down, and the intermingling of neurons between the suprachiasmatic nucleus and temperature control and the in your brain. We talked about the eating timing. We talked about coffee. Then the different kind of PSG devices, actigraphy, home sleep apnea testing, watchpad devices, and community level of sleep studying, and a variety of sleep solutions. So I think this was basically just to give an overview about what all we expect from in a sleep clinic. So thank you very much. Any questions, comments, I can definitely take them. Thank you.
Hello. Hello, can I ask you a question?
Thank you.
Just wanted to ask you, if you want. So not audible.
And they will, even if the sleep efficiency goes down to less than 80%, they will immediately come up to say, sir, I am not a. So we can, I mean, what I normally do in my practice, I tend to ask them that what happened on that particular night, what happened on the nights where their sleep efficiency is 100%. So then they themselves will be able to analyze and they will be able to improve their sleep quality. So.
That's a good presentation, sir.
Thank you.
And, when it comes to lifestyle interventions, sleep and exercise are real underrated tools. So you clearly explained how sleep deprivation affects the cardiovascular outcomes, the hormonal health, especially where it causes increase in cortisol, decrease in testosterone.
Yes.
And also in elderly people, sleep deprivation is one of the reasons for cognitive decline, early cognitive decline. And all patients should be assessed for depression, anxiety also. And Sarah's beautifully explained about the circadian rhythm, which should be maintained and simple interventions. I also tell the same advice to my people, to the patients. Take a warm bath 2 hours before, and you beautifully explained that.
Yes. Because dementia and other Alzheimer's disease, they are also having a good association with sleep. Even Parkinson's also, the patient, those who have frequent awakenings, and you are something known as glymphatic system. So similar to lymphatic system, there is something called as glymphatic system, GLY. So this glymphatic system is something which will take out all your toxins, amyloid-like material from your brain, especially when you are sleeping. And there are studies which have shown that if you're sleeping on your right lateral position, then your glymphatic system is more active. So if some patient asks you that which position I should be sleeping to prevent my neurological functioning better, I think it is right lateral position, which is more effective for clearing away your toxins and decreasing your chances of developing dementia, Alzheimer's disease. So that is one of the. Yes, sir.
I'll try to talk on three perspectives. One, from the patient's perspective, most of the patients, they are not aware that this such a disease occurs. Because most of them, they think it is a part and parcel of aging.
Yes.
One way. I'm happy to know that the awareness is increasing among physicians, but I think it should be much more than what we currently have. And the third thing is, I think someone talked about the incorporation of this particular thing into the curriculum of these students. I think that's a welcome move.
Absolutely. Absolutely. I mean, we have to take it forward, and it's a point well taken. So Shivani, as a secretary of CSM, we have to take it to the medical schools and colleges, where we should be able to have this as a curriculum presentation. Thank you.
Sleep studies on a sunny Sunday. Very nice. See, the sleep disturbances and deficiencies are very common among asthmatics and more COPD.
Absolutely.
Before this OSC and all, did you screen for this sleep disturbance in your OPD? How do you manage? Because we are worried that whether they have effect on sleep center and all. Did you find it is a prevalent, it's an ancient one. Did you address those things in the past? Or what is the plan?
So I feel now, although I have done dye of my hair, but in my 22 years of practice with some graying of hair, I have understood one thing, and what I said in my presentation is that definitely patients with asthma, COPD are those who have very improper sleep pattern, absolutely improper sleep pattern. And I relate it more to the immune function because your all T2 cells, they basically get stimulated at night. So those who have improper sleep, especially asthmatic patients, they are the one those who get recurrent exacerbations. They are the one those who get recurrent infections. So point very well taken. So
We don't want to increase the sleep at all.
yeah.
Poor people. Rubicon is like internet. Sleep is very good. Like the sleep flow like something.
Thank you.
So,
Person.
What is the best remedy? I didn't get actually.
It's almost the start. Within a short period of 7 you got illness, mental function, its behavior, appetite, and other mental functions. Reverse once is the thing.
Oh, I think for reversal again, I feel time is something which needs to be given and improving their lifestyle because majority of the diseases what we see nowadays are all lifestyle diseases. Just by improving their sleep health, I think that was a question, Gopal. I didn't get it actually.
Actually, the sleep deprivation. Yeah. So it becomes a complication. Yes.
Okay, and then how do you manage? How do you manage those patients? No, he will be able to. I mean, there are nothing like even obstructive sleep apnea and whatever microarousals and the hypoxemia is happening and it is causing cardiovascular. It's a very long story. It doesn't happen overnight. It takes 3, 5, 10 years for these patients to develop those kind of cardiac complications. So it is not something which, there is no control there. We can definitely reverse many of these things by improving the patient's lifestyle. That's what I feel. Yeah.
Since more than 9 hours a day, chance of higher stroke incidence.
Yeah, I just address in my talk because this was very interesting study which was done and patients those who sleep for more than 9 hours, they definitely have more chances of developing not only stroke but even hypertension and cardiac morbidity. The reason what they mentioned and what they found out was basically because these patients they were less active throughout the day. Okay, so there was no time spent in the exercise. There may not be proper food intake or they may be more obese and that's the reason that there were more chances of developing cardiovascular morbidity.
So you explained about coffee, excellent, sir. But other foods which decrease the sleep, which other food increase the sleep? That's one thing. Second question is, patients are taking more drugs nowadays because they are diabetic, hypertensive, hypothyroidism, and everything. It impairs the sleep patterns. Especially they are taking at night times, they are taking diabetic pills and everything.
Yeah, I mean it's a big list. It's a big list, but certain things which we always should, for example, common drugs like beta blockers. Okay, they can cause a lot of insomnia. Steroids, they cause a lot of insomnias. Then drugs like ACE inhibitors, which we tend to take in the morning, it doesn't work actually. So ACE inhibitors should be always prescribed at night. Your beta blocker, your H2 antagonists, your antacids, they should be given at night, especially ranitidine and those kind of drugs, because that's the time when they will have more impact depending upon the gastric acid secretion. So there are certain these kind of things. And about the other drugs, sleep promoting medications, I think I tell my patients to take saffron, kesar. So that is something which is very good in improving the sleep. Zyphod, I don't know what they call in English. Zyphod, poppy seeds, yes. So there are certain things which can, and all aerated drinks, and even tea also after 6 o'clock in the evening. So these are all things which can actually disrupt your sleep pattern, and all aerated drinks also because they can give you actually energy boost, lot of sugar rush.
What about metformin and other things? But patients are commonly taking metformin before inhibitors.
Yeah, but metformin definitely. I mean, I don't think it has a lot of implications on the sleep pattern that way.
Sir, can I answer this question, sir?
Yes, please.
So regarding the diabetic medications, what you asked, regarding the diabetic medications, it's not metformin. There's another class called SGLT2 inhibitors. We use empagliflozin, dapagliflozin. See, one of the causes of sleep disturbance is nocturia. So SGLT2 inhibitors increases diuresis. So if it's one of the common drugs which being recommended now. So use the drug in the morning.
In the morning.
Sometimes it's given in the night. It comes as a dual drug combination also. So make sure when you're using a diabetic drug, especially SGLT2 inhibitors, use it in the morning. That can cause sleep deprivation.
Nice.
Thank you, chairs, for this wonderful keynote session. Thank you all. Now, Sanjana.
Right lateral, sir. Is it right lateral or left lateral?
It is right lateral.
More.
Lymphatic drainage, that is, I mean, it is one of the theories for just prevention of the neurological disorders. Okay. Or it has been shown that those who sleep more on right lateral position, their lymphatic system is better. But that doesn't mean that you should not sleep on left lateral. For example, in pregnancy and
Placement of thoracic duct and the drainage of lymphatic.
yes, exactly. For the
More on this.
on the left lateral. I said in the pregnancy and only for neurological issues, there are some studies which say that right lateral position is better. Okay. Even for position dependent sleep apnea, we ask patients not to sleep flat. Otherwise, there are so many those who feel better even in the flat position also.
Thank you very much. We had a wonderful keynote session. Thank you, Dr. Mandali. That's welcome. May I request Dr. Gopal sir? May I request our Gopal sir, Vice President of CSM, so to come to the stage and give the mementos to the chairpersons and our speakers. Gopal, may I request Professor Raghunandan sir, please come guys and give the memento to our chairpersons. Sir, Balmurugan sir. Ma'am, please come and give the memento to Dr. Sivaraj. Thank you, Professor Raghunandan sir. Raghunandan sir is our senior member from Tamil Nadu Medical Council. Thank you very much. May I request Draga ma'am give the memento to Sivaraj. Thank you all. Over to scientific.
Yeah, before we start with the inauguration, I request all the PGs who have gathered here, can you raise your hands? All the postgraduates. So I want you all to stay back before lunch because the quiz preliminary round will start before lunch. And it is mandatory if you want your CMA credit points. Okay, preliminary round is mandatory for all the postgraduates. Okay, among which we'll be selecting 5 teams. So for the preliminary round, I think you have to team up as a team of 2. Okay, it's mandatory for all the postgraduates. Okay, the preliminary round. It will be a written session. All right, yeah.
Again, a quick break from our academic sessions. We will now have the formal inaugural felicitation ceremony. So I request our chief guest, Dr. Mahavir Modi sir, President CSM, to occupy his seat on the dais. Inaugural. Request Dr. Mahavir Modi sir to please occupy a seat on the dais for the formal inaugural ceremony. I invite Dr. Gopal Rawal sir, Vice President CSF, and our guest of honor to occupy a seat on the dais. I invite our Secretary CSM, Dr. Shivani Swami ma'am, to occupy her seat on the dais. I invite our patron, Dr. Prasanna Kumar Thomas sir, to please occupy the seat on the dais. Dr. Sujata ma'am, Sujata Gajendran ma'am, President-elect Rotary Medical Fraternity to please occupy the seat of desk. Our scientific chairpersons, Dr. Tilakavati ma'am and Dr. Gayatri Devi ma'am, to please come on the desk. And Dr. Meenakshi ma'am, Dean of Chettinad Health Research Institute, to please come to the desk. We'll now move on to the honoring our guests for the day. I request Dr. Jayaraman sir to kindly honor Mahavir Modi sir, our chief guest for the day and President CSM. Request Jayaraman sir to honor and welcome Dr. Gopal Rawal sir, Vice President CSM. Now Jayaraman sir will be honoring Dr. Shivani Swami, our Secretary from CSM and Course Director. Request Jayaraman sir to honor our patron Dr. Prasanna Kumar Thomas sir.
I have the stomach pain is there or it could after food pain. Morning.
Request sir to honor Meenakshi ma'am, Dean and consultant pulmonologist from Chettinad Health Research Institute. Now I request ma'am to kindly sir to kindly honor Sujata Gajendran ma'am, President-elect Rotary Medical Fraternity this year. And a token of our love to Dr. Tilakavati ma'am and Dr. Gayatri Devi ma'am, our scientific chairpersons for the event.
That is not a problem. Not a problem. Blood?
Normally begin the event by lighting the lamp to illuminate our thoughts and improve meaningful discussion throughout the summit. I invite our dignitaries to light the ceremonial lamp and inaugurate the event.
I will write that.
May I request Dr. Nalini Jaini ma'am, please come to the dais for the lighting lamp.
Because of
Sridevi,
infection
please join.
Yeah, infection is there. The steroid is because of vasculitis. Steroid is not because of infection. Steroid is because of steroid. When steroid you are giving already the body immunity will be low. Okay. So when body immunity will be low, infection can occur at any time. Okay. So for abdominal pain, steroid is not there. Steroid is for vascular deformity. Stomach pain plus steroid. Okay, ma'am. Today, May 7. Tomorrow, after taking medicines, we'll see. Thank you. Okay. Thank you, sir. அவ்வளவுதான். இது பண்ணி இருக்கு. முன்னாடி பண்ணிட்டு pues வாந்தி மாதிரி இருக்கேம்மா மாதிரி இல்ல கொஞ்சம் இம்ப்ரூவ்மெண்ட் இருக்கு கொஞ்சம் இம்ப்ரூவ்மெண்ட் இருக்கு
So we would now like to show our appreciation to two delegates who have come all the way from Australia. We have Dr. Swati Ilanko, ma'am. She here.
Kumari.
Please come to the dais.
They're here for vacation. But when I told this conference going on, they ready to accept our invitation. And she's Dr. Swati doing pediatric fellowship at Sydney University. I would like to honor by Dr. Mahavir Modi to honor her. Thank you.
यहाँ से भेजा हुआ बहनों के बहनों बोले कि फोटो सब बात किए बुधवार को करने से लिखे बुधवार को लिख दिए वो लिखने के लिए करने ठीक है वो आज
I'd like to call Dr. Shantini. She's a general practitioner from Sydney.
न्यूरोलॉजी फिटनेस की ले लेंगे
I'd like to ask Dr. Mahavir Modi to honor her and the certificate.
वही जो एनोमो है ना वो कहीं उसको ऐसे प्रॉब्लम ना हो इसलिए हमारा सजेशन के लिए तो ऐसे सारा चीज रिपोर्ट वगैरह सब टेंशन वेंशन मत लिया कीजिएगा ज्यादा चढ़ेगा हाँ आज एक और चढ़ा दे
Sweet events require a sweet beginning and a sweet formal beginning as well. We will now be cutting a cake and celebrate what was celebrated 2 days ago, 13th of March, World Sleep Day.
What happened, Sister Ji?
No request, so yesterday they didn't.
Well, the cake cutting is happening now, but we will relish it while we are in the buffet later during the lunch break.
What a pain, huh?
You don't know. I entered the ACL at Apollo.
What happened, Sister Ji?
Next year.
It's the conservative management, everything.
Thank you so much, respected dignitaries. You may please take your seats amidst the other audience. Thank you so much. We will now be proceeding to with our second keynote session.
Oh.
Now we are moving on to the next keynote session of the day. Why do we need sleep clinic? Dedicated sleep clinics play a crucial role in early detection, evaluation, and management of sleep disorders. For the session, I would like to welcome the chairpersons, Dr. A. Mahalmanan sir, Professor and HOD, Department of Pulmonology, ESIC, KK Nagar, Senior Consultant Pulmonologist in Apollo Hospitals. Yes, sir. And also, I will also like to welcome
How much
Dr.
they
N.
charge
Meenakshi,
actually?
Lead Chettinad Hospital and Research
So
Institute,
much.
Chennai,
5
Professor and
lakhs.
HOD, Department of Respiratory Medicine, Chettinad
So I
Hospital
was having
and
some
Research
grade one
Institute.
water
We
Malaysia
welcome you,
Patala.
ma'am.
They have done, I don't know what.
I'll
for the
also
problem of
invite
this
Dr.
testing,
N. Nalini
they
Jayanti, ma'am,
they will do some
Professor
like
and
what
HOD,
they
Department of
get in
Pulmonology,
the
SRM,
mode, they get
and
the single tendon
NTEP
and
Nominal
ganglion
Officer.
research. That
We
is
welcome you, ma'am.
neuroplasty. And then in AC always some loose particles will be there, removal. And then hospital
Welcome,
bill was
ma'am.
around 4.45
I would also
lakhs.
like to invite
And
Dr.
in 25
Supraja, ma'am,
also they have asked for
Medway,
this
Director of
and all sorts of
Pulmonology,
things.
Medway Institute
With
of
everything,
Pulmonology.
which is 5 lakhs. So Apollo is always mostly. That you green
And,
lights.
I'm also privileged to welcome the guest of
They don't
honor,
have
Dr. Gopal
insurance,
Rahul
huh?
sir, as the speaker of the
Actually,
session.
that was having drink water.
Is a consultant pulmonologist, critical care and sleep disorder
It was in
specialist
my
in
MGM
Ahmedabad.
healthcare team.
We welcome you, sir.
My husband claimed from his unit actually.
The MGM
5
healthcare
lakhs he
team,
claimed from his unit.
the MGM healthcare team, there's a lot of disturbance.
First of all of you the have World Sleep Day that 2 days before on Friday. Then also the Happy Women Day last Sunday. And this is my second visit in Chennai in next 2 weeks. Last 2 weeks before I came here for the Criticare. So I think I love Chennai very much. And thanks for the great hospitality by Dr. Jayaraman and team and MGM Healthcare for organizing such a wonderful sleep summit. All topics are very well important to the day-to-day life and the PG, particularly the PG students. So how to develop the sleep clinics, because sleep is a subject not pertaining to the pulmonologist, but it is involving the all the other specialties. So next 25 to 30 minutes, then I'm going to speak about the why do we need a sleep clinic? Because it's not like that patient comes to you with the sleep reports and you prescribe the CPAP. Initially, what was that done? And when I started my practice 2 decades before, and when I suspect the patient to have a sleep apnea, nobody is ready to accept that such a disease is there. And in Gujarati, Gujarati those who are understanding the Gujarati, Naskorato Tandurastini Nishani, એવું કહેવાય. Okay, so it's a snoring is a sign of a good health. Okay, so just I'm going to speak about why do we need a so first of all that all we know this we have seen that sleep well lie better every year. The World Sleep Society on celebration of the sleep day, they come with a new quote and slogan for the World Sleep Day, and all the slogans are important to maintaining the health. We all know that sleep is needed for the physical and the mental health. So you have to treat your patient not the physically, but the mentally you have to treat your patient. That's important thing. Forward. Yeah. So these are the some contributing factors for the poor sleep. We all know that's alcohol, pills, jet lag, that's circadian rhythms, that work from home, shift work, bedroom light, technology. The most important thing. Yeah. The coffee, as my colleague Mahavir has mentioned, and a lot of questioning occurs that when to take the coffee is a good thing. We need the coffee to maintain ourselves awake, but particular time, at that time you have to take the coffee. And the temperatures, we are seeing that we are trying from winter entering into the summer, so that temperature is also affecting the sleep pattern. Yeah, so this is the important things for the PGs. They should understand why should we are more bothered about the disturbing sleep. So we all know that's a
sleep, then there is a chances of upper airway closure, which leads to hypoxemia, and hypercapnia leads to arousal, which leads to upper airway opening. But during this process, the important thing occurs, that is a sympathetic nervous system surge that increase the blood pressure and heart rate, which is responsible for the consequences which related to not treating the sleep disorder. And the important thing is the sleep fragmentation. That's the most important thing. This sleep fragmentation leads to a certain daytime symptoms of the patients. Now, this is the consequences of not breathing during the sleep. So cessation of breathing usually cause micro arousal, leading to a sleep fragmentation, and that leads to patient experience of some effect of the sleep deprivation. They are not satisfied that my sleep is adequately. Then a decrease or cessation of breathing leads to oxygen desaturation in blood and increased heart rate, which increase the risk of cardiovascular problem. Increase in the sympathetic nerve activity that result from inability to breathe can increase the risk of stroke. So these particular things which occurs during the sleep, if we are not taking care of that part, then it leads to various system involvement occurs. The effects of sleep apnea are linked to the higher incidence of obesity, metabolic syndrome, and type 2 diabetes. And the important thing, particularly in our resident group, the consequences of the sleep deprivation. Our PGs and youngsters, those who have a delayed phase of syndrome and not having the particular sleep. So what occurs, that my colleague Dr. Mahavir has also mentioned in his talk, that decreased alertness, particularly in our residents, the alertness is decreased. There are a lot of chances of misinterpretation of certain biochemical reports, ECG, and the things that study was done, particularly on PG students. Lack of concentration and judgment, decline in the productivity. Then there is high risk of anxiety, depressions, traffic accidents, chances of obesity, cardiovascular disease risk, and type 2 diabetes. So these are the consequences. If the person or our PGs are sleep deprived, then what can happen to him? Okay. And this beautiful slide, that's the pathological consequences of OSA. So mainly the metabolic, cardiovascular, behavioral, and others. So insulin resistance, chances of metabolic syndromes, weight gain, nocturia, sexual dysfunction, in cardiovascular hypertension, mainly the resistant hypertension, refractory hypertension, rhythmic problem, particularly those related with the, even in the women's, they were discussing about the women problems. So arrhythmias also. So you have to pick up that arrhythmia early and proper diagnosis of sleep disorders. Then the behavioral, cognitive, and memory problems, irritability, concentration difficulties, premature aging. That Mahavir was telling that the dying should be now, but now the age of dying is increased little bit preponed to 2030s. We have seen students, our students, they have a more gray hair rather than us. If I'm not wrong, and the professors are sitting in front of me. So, and that depression is a common things that you have to take in the minds. And a lot of that my psychiatrist colleagues are sitting here. So a lot of depressions comes in the early age group also. Then excessive daytime, fatigue related accidents, and the headache. So these things are you have to, and this is the beautiful pictorial that sleep apnea is prevalent. You have to find out from a certain disease that this patient might have sleep apnea. You have to diagnose it, and you have to properly treat that condition. So heart failure, sometimes heart failure coexisting in OSA in 76%, drug resistant hypertension in 83%. Then the coronary artery disease, 57%, atrial fibrillation, the commonest arrhythmia in the ICU, commonest arrhythmia. So registrars should pick up that if the patient having atrial fibrillation, then he might have a coexistent obstructive sleep apnea. Then the stroke, depressions, then type 2 diabetes. So these things, if you have in your mind on your patient, then you have to suspect that high index of the suspicions should be keeping in your mind, and you have to pick up And this is the very good slide, I think old slide, that's what are the physiological perturbations, intermediate mechanism, and the clinical outcomes related to the obstructive sleep apnea. So effective diagnostic and treatment strategies are needed to minimize the negative health impact and to maximize the cost effectiveness. So we need to diagnose sleep apnea or other sleep related breathing disorder properly in the time. And this is the slide which I made, that sleep disorder is not related to the pulmonologist. It's pulmonologist, intensivist, cardiologist, urologist, ENT, dentist, neurologist. That's why our CSM, they're conglomerating all specialty. We try to make the all, this is the teamwork, and which we have seen in last Sunday, that we won the World Cup T20. So that is a teamwork is needed to overcome such a hazardous disorder, syndromic disorders coming in our health. Okay. So we need these words. Sorry. So actually, we want to make the sleep board. Why we need a sleep board? That's a multidisciplinary approach, and I think Dr. Jayaraman is his first person who is establishing the very good sleep clinic in the city of Chennai. I wish that that should come in all over India. So we should have a sleep board. That is a proper sleep clinic. In that, you have to diagnose the sleep related breathing disorder. So not a single person going that without diagnosis. So multidisciplinary, we all know that other disease like ILD we have. So that kind of board should be there, and proper treatment. We all know that OSA endotypes and phenotypes. Not all patients needed CPAP. Some patients needed a good behavioral therapy, positional therapy, or some medications, oral appliance, or some bariatric surgery. So that should be decided in a proper sleep board and sleep clinic. So these are the protocols which I follow in my practice for last 20 years. When the sleep disorder patient comes to my clinic, proper history and physical way that taught by our teachers from the medical school days, the history and the examination is the most important thing. Then do certain basic tests. Specialist consultation, you have to refer your colleagues also sometimes if needed. Then the proper sleep questionnaires, what the questionnaires which are you are using, that you have to use. And I mentioned the level 1 to level 4 sleep study, because nowadays we are getting a lot of sleep study, level 3 sleep study, level 4 sleep study. So you have to mention in your prescription that I want level 1 sleep study in this patient, I want level 3 sleep study, because we all know that India is developing country. Cost is the main factor for the sleep diet. But now with grace of our prime ministers, we are near to a developed. We are near to a developed. So if we suspect that these patients need a level 1 sleep study, always prefer that level 1 sleep study. That is the gold standard. And this is the screening, particularly for the PG students, how to screen OSA with the clinical examinations, history, clinical examination. Though we know that there are no specific history or clinical findings for OSA, and therefore diagnostic test is required. That things you have to keep in your mind. High risk population. Which population? That's a particularly extreme obesity. You can suspect that when the patients are not complaining related to sleep related breathing disorders. You have to suspect diabetes, that is poorly controlled, congestive heart failure, the patient having the refractory or repeated heart failure admission in the hospital. You have to tell your cardiologist colleague that this patient might have the underlying OSA or sleep-related breathing disorder, coronary artery disease, hypertension, because nowadays we have seen a lot of young hypertensive patients. In that, there is a resistance, refractory hypertension. So in that, early you picked up, you can prevent the hazardous effect of sleep-related breathing disorder. Stroke, particularly the recurrent stroke, and even the nocturnal epilepsy, your neurologist should refer you for the sleep study. Then the nocturnal dysarrhythmia, and always that we were discussing in the panel, preoperative, because most of time we miss certain things in the pre-operative assessment. If you timely picked up that this patient having the sleep disorder, you can prevent the post-operative complications. So in pre-operative assessment, comprehensive sleep examination should be included. And even in, we mentioned that in the cardiology guidelines, that person having the pulmonary hypertension, so they have mentioned that such patients should be evaluated for the sleep apnea. Sorry. In patients suspected to have OSA, secondary cause of hypothyroidism, facial abnormality, tonsil and adenoids, particularly in the children, young children, that timely evaluation of this tonsil enlargement and adenoid should be done, and properly treatment should be done. Metabolic syndrome, coronary artery disease, stroke, and the gastroesophageal reflux. And as Dr. Mahavir was mentioned, never forget to these comorbid conditions also when you are treating sleep disorders like allergic rhinosinusitis, nasal polyps, asthma, COPD, obesity, hypoventilation syndrome, and kyphoscoliosis. Because if you miss this diagnosis, then the compliance and adherence of CPAP therapy or other therapy may be reduced because you have missed this underlying conditions. So always these things properly you have to evaluate. Now, this is a very good sleep question. You can ask, you can tell your assistant that he or she can ask to the patient that I have been told that I have snored. I have been told that I hold my breath when I sleep. I have high blood pressure. My friends and family says often I'm grumpy and irritable. I wish that I had a more energy. Certain question you have to just prepare in your clinic, and you can put in your waiting room that the person can see, and then they can evaluate themselves that whether I have sleep apnea or not. I get a morning headaches. I often wake up with a gasping for breath. I'm overweight. I often feel sleepy and struggle remain alert during the day. I frequently wake with a dry mouth. Then these are certain questions that in insomnia, not because most of time what happens when we started the sleep practice, sleep is always OSA. So this is beyond OSA, you have to think, because nowadays we are getting patients for insomnia and other sleep disorder also as a pulmonologist. Then I have a difficulty falling asleep. I anticipate problem with sleep several times a week. I often wake up and having trouble going back to sleep. I often feel sad or depressed because I can't sleep. Then I have noticed or other have commented that parts of my body is jerking during the sleep. I have been told that I kick or jerk during sleep. This is the parasomnia, sleep related night disorders, NREM, REM related. When trying to go to sleep, I experience aching and crawling sensation in my leg. I experience leg pain and cramps at night. Then sometimes I can't keep my legs still at night. I just have to move them, because sometimes we also learn from medical school the negative history is also important. So you have to ask, you have to initiate such questions to the patient that whether they have such question or not. Even though I slept through the night, I feel sleepy during the day. So such questions you have to keep in your mind and ask your patient that whether they have some sleep related breathing disorder or not. And always don't jump to the diagnosis, because give proper time to your patient in sleep clinic. Why? Our aim to develop the sleep clinic, it's not the 5-10 minutes just asking history, examine the patient and prescribe the medicine. Proper give. If you don't have that much time, then keep a 1 or 2 days in a week for a proper dedicated sleep clinic. So then and then you will able to find out certain hidden sleep related breathing disorders. You just explain your patient to maintain the sleep diary. That is the most important thing. Then these are the questionnaires tools. I'm not going detail. In my practice, I generally use Epworth Sleepiness Scale and Stop Banks. This Stop Bank is a very good questionnaires. Those who are PG stat, when for the pre-op evaluation, you can use this Stop Banks questionnaires to assess that whether the patient having sleep related breathing disorder or not. This is Epworth Sleepiness Scale. And this is the stop bank scale. Very simple, that chances of dosing during certain situation you can assess. This is the stop bank questionnaires that mnemonic stop bank itself is suggesting, which this is objective and subjective questionnaires. On that basis, even you can predict, you can tell your surgeon also that this patient have chances of sleep related breathing disorder and might have some post-operative problem. Types of sleep study that I mentioned: diagnostic, CPAP titration, split night study, MSLT and MWT. I'm not going in detail for this, but you should know, and you have to explain the patient what things I'm going to do. Okay, that's the most important. Most of time what happens, the patients call you that I want, just someone is advised me to go for a sleep study. Then don't give technician's name, number, and then do the sleep study and come to the OPD. Always first assess your explain the patients, counseling the patient. That is the most important thing to develop. This is our sleep room. Very good dedicated sleep room. Then it is a hookup in sleep room. And always tell your technician, ask your patient why we call the patient prior the sleep study, to know the what is his bedtime and everything. So before that you have to call him and explain, and proper hookup should be done. And your technician comments, that is the most important thing, because this is the only you are assessing your sleep patient's sleep related problem in just one day, because on that day he may not have that symptoms also. So your technician comments is also helpful. These are the, I'm not going in detail, the evaluation what we are doing in the sleep assessment. So these are the pros and cons, because before the COVID, we have a very good dedicated sleep room. But now after the COVID, we generally prefer level 2 study at home also. And patients are also ready, because to tell the OSA patient as a patient, they don't like. Okay, so they usually prefer to go for study at home also. So these are the pros and cons, because always the left one is the better diagnosis of other sleep disorder also, but the cost is less in a this home-based sleep study. These are the indication of sleep study. Detailed indication, you can explain your patient why I'm going for a sleep study. Then because to find out other sleep related breathing disorders. Then 10% change in the weight when your patient having treated with the CPAP, then you can ask him for the when to do a repeat sleep study. So diagnosis of nocturnal epilepsy. And remember this thing, sleep study is not indicated adequately treated with CPAP. Certain parasomnia, seizure disorder, restless, insomnia. Insomnic patient also just don't jump for the CPAP study. Circadian rhythm disorders, always do a proper counseling of that patient and then find out that whether he needs the sleep study or not. There are the interfering factors in the sleep study that always we remember that the first night effect, which is due to poor sleep, because patients are not acquainted with your sleep clinic area also. So sometimes patient may not have adequate sleep during that night also. So that things always keep in the mind. Medication that someone were asking about, that certain medication also interference with the PSG also. Some sleep disorder like nocturnal seizure and RBD may occur too infrequently. Always explain the patient, I may need your repeat your study also. So that things also increase the compliance and adherence of the treatment. Sleep study that points to be keep in the mind, particularly the PG students. When a PSG is determined to be necessary, the patient should be educated on the procedure and the potential outcome of the study. That should be explained properly. The patient's regular sleep schedule should be identified to allow for a optimum timing. Otherwise, what Dr. Mahavir was telling, the sleep latency and the REM latency and everything way haywire. Suppose that your patient is sleeping at delayed phase syndrome, like 1 o'clock, and you call him at 10 o'clock for the sleep study. Then you have a delayed sleep latency, and that improper diagnosis should be done. Okay. Alcohol use before a sleep study can have a similar effects like a benzodiazepine. They sorry, patient being evaluated for narcolepsy should be carefully screened for a medication before the PSG and MSLT. And always try to do a MSLT on the same sittings when you do a sleep study very next morning. So that's why clinical examination, history, everything is needed for certain patient. Now, what are the treatments? So we all know that behavioral position, positive airway pressures, pharmacotherapy, and the surgical therapy. Everything you have to discuss. So effective communication technique should be there. Active listening, open-ended questions, sleep diary reviews, empathy and validations. That has to be important things while prescribing, because it takes a lot of time, but then you have to dedicated time for your sleep clinic. Counseling areas and the sleep educations, sleep hygiene education, that is important. Now we change the word also, sleep bundles, like those who are intensivist practicing ventilators, VAP bundles and infective bundles. So we have to tell the patient that you have to maintain the sleep hygiene. Sleep bundle should be keep in your mind. Stress management, then the cognitive behavioral therapy for the insomnia. Most of time what happens that we generally, patient is also asking, sir koi ek tablet likh do na, neend nahi aa rahi dhang se. He might be on some other benzodiazepine, we write for zolpidem or melatonin or the things is then go haywire. So first you have to identify what kind of cause is responsible for the insomnia. Relaxation technique. Then important thing is the family counseling. Thank you. Then the behavioral, we all know that weight loss, nocturnal positions, and the maintaining of the sleep hygiene. And important thing is the avoidance of the sleep deprivation. I have a few patients, those who are coming with me for the hypersomnia. Actually, they were not narcolepsy because someone they diagnosed to have a narcolepsy, but they have a sleep deprivations. Most of that students, they come with the sleep deprivation and they have a excessive sleepiness. And particularly that culture like work from home and sleep adjustment, that during the weekdays, less sleep and weekends, very long sleep, that has to be avoided. Yoga, pranayam. Then we all know that PrEP therapy, explain the what kind of mask and what you are going to do in PrEP therapy. So that is also increasing the compliance and adherence of the PrEP therapy. Then why we should offer therapy beyond the CPAP? Because nowadays the terminology OS endotypes and phenotypes come. So not all obese patients, they have a sleep apnea, and not thin person, they do not have a sleep apnea. You have to identify which patient have which kind of phenotypes and endotypes. According to them, you have to offer the treatment. Oral appliance, we have a various oral appliance. So you can advise like tongue retaining device, mandibular advancement device. You can give for particularly the mild OSA patients. And how it works, that device that is most oral device advance the mandible. This pulls the cranioglossus forward. This pulls the tongue forward. Upper airway space is regained, and that reduce the snoring and sometimes the OSA eliminated. Then the surgical option, you can give your patient, or even you can ask your ENT colleague to that take his opinion for that. Bariatric surgery, certain patient, the bariatric surgery is the option. Then you can go for a bariatric surgeons. This is a new inspired that hypoglossal nerve stimulation that is also helpful to relieve. Like it's not available in India, but going soon availability in the India by Inspire. So that things you have to keep in the mind. Then these are the whole OSA targeted therapies, anatomical therapies on the base of OSA endotypes and phenotypes, loop gain therapies, arousal threshold therapies. These are the drugs. It's currently that is FDA approval, and orlistats, liraglutides. Generally, we are most famous with the semaglutide and the tirzepatide. So the weight reduction is 5 to 10% in the early state, but we could have a tirzepatide is a 18 to 20% reduction. But like retinopathy, and always keep in the mind Love-Bailey statement: 40 females fatty having gallstone. If my PGs remember that Love Belly is nicely given that on a gold stone. So that things always remember while before prescribing the terzepatide. Then this is the OS and terzepatide. I'm not going in detail, but always involve your endocrine colleagues, diabetologists, that whether this patient needs these therapies or not, and properly monitors. These are the medications. So I'm not going. So last, that snoring isn't just irritating, it is hurting your vital organs. 37% hypertension, 48% diabetic, 51% of OSA, 76 congestive heart failure. So have they been treated on time? Treated on time. So red line is important. Treated on time, such health complications should have been avoided. So treat your OSA patient before it's too late. That's the most important thing. With that, I'm concluding my talk. So sleep-related breathing disorder are spectrum of syndrome. You have to keep high index of suspicious with meticulous questionnaires and examination. Perform for good polysomnography. Sleep study should be done by the trained technician with guidance of the sleep specialist. That's the most important thing. And the best, these are two quotes I'm putting: the best bridge between the despair and hope is a good night's sleep, and sleep is that golden chain that ties health and our bodies together. With that, I'm inviting you for our CSAM, next CSAM conference. Sorry. Last slide. So our CSAM, 8th CSAM conference, which is going to be under the guidance of our presidents, Dr. Mahavir Modi and Dr. Shivani Swami, that which are going to organize at Ahmedabad, 21st to 23rd of August. So I inviting you to attend a wonderful conference. And we have seen last year, Dr. Jayaraman and his team has organized wonderful sleep conference. So thank you so much.
Thank you very much for that lucid presentation, sir. But you have presented everything about sleep. Are we all knowing about many people in public, no, like including doctors? My colleague, my junior colleague is having snoring during daytimes. He is having, but he is not into PhD. Though he tells he's an assistant professor, he teaches sleep medicine, but he doesn't follow it. So you have been running a sleep clinic for the past 20 years, you said. So what are your obstacles, sir? Have you seen that the patients come voluntarily or are they coming in?
Yeah, so that is a good question. That even that questions I asked when I started my practice, whether the patient will come to me or not. I should practice as a sleep specialist, or I have to enter in the IPs or like critical care. I continue with that, but the dedicated sleep practice is very much important. And first, that I took all top lectures in front of my cardiologist friends, diabetologist friends, and I make them first aware about that. So nowadays I am getting at least 4 or 5 patients from my cardiologist patients, 4 or 5 patients from my neurologist patients, and so many others specialists. So you have to develop. You have that I told that high index of suspicious and जो मैं just डराना चाहिए, थोड़ा बहुत डराना चाहिए because of that consequences of untreated sleep related breathing disorder. You have to discuss in front of your colleagues also, not the patients, but your colleague, and try to keep at least one talk on sleep medicine in each and every conference, like ENT, psychiatrists, cardiologists, endocrinologists, obesity, whatever neurologists, that things that will aware our colleagues that this patient might have sleep apnea also. That's why I kept that slide, that OAC is not related to the pulmonary. Even gynecologists, that discussion of Gayatri ma'am panel discussion, infertility, even is a common presentation, because the female are not coming with that proper symptoms like snoring, daytime sleepiness. They have most of fatigue, myalgia, and the mood changes. That's the mood changes. And the female, I have seen most of female, they have a unnoticed hypertension. That is the one of the cause for the underlying sleep apnea.
Very good presentation. And 1.5 decades back when we were students, they were telling us 6 cardinal symptoms of respiratory. They said I had snoring. Now my practice currently, I don't have snoring, I have sleep. So when patients are waiting in the OPD itself, we give one is stop and most important is the ISI, insomnia scoring index, where we find that the prevalence is so high, even if they do not present to us. And for us in the practice, when we say 20 minutes per patient or 30 minutes, if you're going to start on the question of sleep, it's going to be endless. They're going to go on and on about how they're not able to sleep. So if you're able to nudge them, get the points, and then identify who is at risk, then that makes
the important thing is in your waiting room, you can keep certain brochures related to the sleep related breathing disorders. You can keep a short video of the sleep related breathing disorder. By that, you can vaccination. What most of time we have seen the vaccination like pneumococcal prevenar and what kind of influenza, then the cervical that vaccination. So if the patient will see that, suppose the patient comes me for a asthma, but if their colleagues might have a sleep apnea syndrome, then definitely the patient tell that "Okay, I need your appointment for the sleep.
We do one more thing, we call it as an tracker, our institute's tracker, where we identify what is the time where they go to bed and what is the duration they sleep and the latency and the interruptions. And then we give them a score. And then next time, because people understand numbers, when I say your score is very low and then you have to improve, then every time they come and we then keep checking and you also feel better that they're improving. So in a way, when you're improving your sleep, your physical activity and your diet patterns, more on prevention aspect I'm talking about. So that also gives them a good feel aspect.
Yeah.
Sir, I feel that sleep statistics, I went through the sleep statistics of India from 11% even 30 to 35%. I think sleep should be taken very seriously. Moreover, the complications, even sudden death, we don't know. Sudden death actually, cardiovascular complications, arrhythmias, people don't know that's a primary snoring. What I feel is more awareness is also needed, and sleep clinic is I feel it is mandatory even in all medical colleges. We should teach the young faculty also. As we said, the multimodality disciplinary. We are getting cases even from dental patients.
Yeah.
So dentists also they are.
Yeah.
Awareness is not raised. That's a problem. Display and awareness even for the general patient. I feel in IMAs because these is all different patients from very prevalent slips. This is something reverse diagnosis. Our PGs also we gave some PG thesis, metabolic syndromes, as we said, fertility, everywhere in this case.
Okay.
So it's multimodality, but awareness should be raised. So
Yeah.
whenever they find some high risk, as you are saying that refractory hypertension, then PCOS, metabolic syndromes, they should be referred for our sleep clinic, and I feel that awareness, even at district level also, because they're snoring, they think it's only a normal pattern. So this creation of awareness, something like TB anti awareness we are creating, World Sleep Day, we are creating awareness. More of awareness is needed, and every medical college, it should be managed.
Yeah.
Sleep should become part and parcel of this.
And important thing in India, there is most of that non-obese sleep apneic patients are also more. So that even I myself, I'm doing sleep from Gujarat University. So my topic is the prevalence of OSA in obese and non-obese. That is the most important thing because most of time the colleagues, they believe that obese snoring, then they have a sleep apnea. It's not like that. Non-obese patient, other than snoring and other symptoms, they should be evaluated for the sleep apnea or any other disease.
Sleep clinic diagnosis, polysomnography, maybe to differentiate diagnosis also, as you say, all
Yeah, obviously.
hypersomnias, they are mistaken for also the other side is also. Actually.
One question, because you started on obesity. Most of your obesity patients always have breathlessness as their important problem when you diagnose. So how do you address that? Because let us say you give them a machine and you say breathlessness will be this is due to deconditioning of obesity. So what do you do for that?
Always that obesity that they related with the underlying airway disease also. Then the important thing is obesity hypoventilation syndrome. With CPAP, it is improving their nighttime and daytime sleep related symptoms. But the breathlessness, for that, they need a lifestyle modifications. weight reduction, proper positions, breathing exercise, and that is the most important thing. So that's why you have to give a proper time and timely call for the follow-up, for the evaluation and then symptom score also.
That's the issue because most of us prescribe a CPAP machine. Patient is not getting out of the bed and walking because he feels breathless because of the deconditioning. We have a lot of these issues that patient is not improving as far as that. So some of them come with dyspnea and they have obesity as their major issues.
From that for the weight reductions and lifestyle modifications. So that will helps them to reduce that deconditioning also. That by that way, that deconditioning will improve and that symptom score of breathlessness will be reduced.
As we are running behind schedule, we can have questions at the lunch hour. Sir will be available in the afternoon. So thank you so much, sir.
Thank you.
At the outside, I'd like to thank Dr. Jaren for this opportunity.
Thank
May I
you.
now invite our course director, Dr. Shivani ma'am, to facilitate the speakers and the chairpersons.
See, you call yourself as multi-speciality. You are not allowing them. See, some state is not confined to one only.
No, say that already.
No, no.
Told very
I will.
It's a multidisciplinary. Stand now and move and momentum and certificate. Momentum in action now. It is three. Please, sir.
It will come there.
Here you go. Yes, go on the action. To Nalini Jayanti ma'am. Mahir Naran sir. Prajana. May I now invite our speaker, Dr. Gopal Rao sir. Please. Okay, thank you, sir.
Super. Awesome.
Satisfaction is 3 बजे का है सर
It's my immense pleasure to invite our next esteemed speaker for panel discussion, Dr. G. Tilagavati ma'am, HOD and Senior Consultant in Respiratory and Sleep Medicine, India Group of Hospital. We proud to introduce my mentor whose wisdom and encouragement shaped our learning. Dr. G. Tilagavati ma'am will shed light on important yet often overlooked topic, pediatric obstructive sleep apnea. May I request ma'am to introduce the panelists and begin the session. Thank you.
Ma sapla mare.
That's right, sir.
Slice, image.
Oh, I think so.
Okay.
Good afternoon, everybody here. I know I'm standing between your lunch and the sessions. I will make it short, very interactive. And we have a wonderful panel here today. Let me introduce my panel. The topic is about pediatric obstructive sleep apnea. So you have been talking about adult women, everything. I think this is another field which really should be a take-home message for many of you here because it's not the same as adults. So let's welcome our panel. We have can you put the CV of Dr. Yuvarajan? Yeah, Dr. Yuvarajan is a young, energetic, enthusiastic, inspiring pulmonologist, I would say. Okay, Dr. Yuvarajan, thank you for being here. Please, we are looking forward to your insight. So this is actually a multidisciplinary approach, like how you all wanted. So it is not the only pulmonologist, only Dr. Yuvarajan and myself are pulmonologists here. The rest of them are from different fields. So it is truly a multidisciplinary approach here. So the next person is Dr. Vivekanandan, who's a pediatrician. Dr. Vivekanandan. Again, another inspiring pediatrician. I would love to learn from him on how he approaches pediatric OSA. The next is Dr. Roshan Ryan, who is a dentist. He's a sleep specialist. Welcome, sir. Thank you for being here. I'm looking forward to learning from you too. And the last but not the least in our panel, we have Dr. Karthike Priya, who is a psychiatrist, and I think the most needed and wanted person in pediatric OSA. So we know that in pediatric OSA, we know that children OSA is often unrecognized, underdiagnosed, undertreated, say what not, everything applies to them. So it's very, very important that we have an insight on pediatric OSA because it will help you within your family as well as outside as a practitioner. So to start with, I would say, so let's have an interaction. I want to know how much the audience know about pediatric OSA. So the first question to audience is, you have two different child. One child is sleepy and snoring. The other child is hyperactive. Whom do you think have OSA? Just a show of hands. Snoring and sleeping, how many of you say that it is the child has OSA? Superb. So how many of you will say if you have a hyperactive child that the child has OSA? Okay, so there is a mixed opinion. I think today we are going to have a clear vision as to what is going to be pediatric OSA from our eminent, excellent panel. Let's start. So the first thing about pediatric OSA is, I think these patients go to the pediatrician first. So let's start our question with Dr. Vivekanandan. Next slide, please. Okay, sorry, I'm having it. So we'll start with a case. So this is a 7-year-old boy who's a habitual snorer since age 4 and who has chronic mouth breathing. His normal BMI until age 6, but now he's slightly overweight. The patient reports poor attention, hyperactivity, irritability, bedwetting 2 to 3 times in a week, and restless sleep. Pediatrician started iron for fatigue and considered attention deficit hyperactivity disorder reference, but never screened for snoring. So should this is to Dr. Vivekanandan, should this child be screened for snoring OSA? As per, we have two important guidelines here. One is American Academy of Sleep Medicine and another is American Academy of Pediatrics. So these are the two guidelines we are going to be talking about. And this panel is going to help you to bring the guidelines to your practice. So according to the guidelines, who are the children to be screened for OSA? What are the early clinical clues that should make a pediatrician suspect OSA in a child beyond the classic snoring?
To answer the first question, 100%, there is no doubt that this child should be screened for OSA. As per the current guidelines, ASM or AAP or the Indian Academy of Pediatrics guidelines, any child who snores for more than 3 nights per week for more than 6 weeks, we consider them as an habitual snorer. Any child who snores for more than 3 nights per week for more than 6 to 12 weeks, if you take 100 children, 30% of them snore. Out of them, 12% snore regularly. What we call as regularly is 3 nights per week for more than 6 weeks. And out of those 12% who regularly snore, 2 to 7% of them obstructive sleep apnea as per pediatric statistics. So any child who fits into this criteria, which will also fall under the purview of ASM and AFA guidelines, with or without labored breathing or a paradoxical breathing, should be screened for OSA. To answer the last question, what are the clinical cues beyond snoring? So I would like to differentiate into daytime symptoms and nighttime symptoms and autonomic symptoms. So daytime symptoms particularly is a classical scenario which we have here. Attention, inactivity, hyperactivity, poor scholastics. Adults usually have excessive daytime sleepiness. Contrary, pediatric population usually have hyperactivity. And nighttime symptoms, apart from snoring, will be paradoxical breathing. Parents often refer to us with videos of pauses or apneic pauses during breathing. Also, there is also autonomic disturbances. We see a lot of children with secondary nocturnal enuresis beyond the 5th year of age, as well as children who have excessive sweating in the nighttime. So these are all the parameters apart from clinical clues, apart from regular snoring or habitual snoring, which will make us to point towards screening these children.
That was excellent. So the first diagnosis of pediatric OSA happens in a pediatric clinic, not in a sleep lab. That's the first basic difference between an adult and a pediatric OSA. So the first thing, going through this is the guidelines. So you can see that AAP says even for habitual snoring, you need to investigate. AASM says that snoring, behavioral learning problems, all the snoring is the least. Snoring is a sentinel event in a pediatric OSA. That's too late. So you need to identify these children before. So ironically, pediatric children who are sleepy or snory is not the child you should pick up. You should pick up early where they have behavioral problems and hyperactivity. That's the message Dr. Vivekanandan has said. Let's working on this. Now we have diagnosed that this patient has a behavior dominant pediatric OSA phenotype, ADHD-like behavior, plus upper airway symptoms, sleep fragmentation, and enuresis with an emerging obesity. This is the diagnosis for this child. Let's move on. So first, when you diagnose that this patient has OSA, so the first thing what you're going to do is you're going to subject this child to a polysomnography. So this is the finding of polysomnography. He undergoes in-lab polysomnography. He has AHI of 6.8, and REM predominant obstruction, mild hypoventilation, oxygen nadir is 88%. Arousal index is elevated, CO2 retention during REM. So we will post, we'll post the next question to Dr. Yuvarajan. So in children, how do you interpret AHI? It is the same as adults or is it different from adults? So let's listen to Dr. Yuvarajan.
AHI parameter actually is one of the age-old parameter we usually use to diagnose OSA, But last season meeting also we have stressed on this point. It is not only parameter. If you want to have a proper treatment, now we are moving more towards precision medicine. There are a lot of other parameters in the sleep, test, that is polysomnography we need to address. Coming on to this point, like AHI in pediatric population is entirely different. Numbers are entirely different because I have my personal, one of my case who was referred from Bangalore. She was having AHI of 5. She was told to use CPAP, but there was a physician who was there told that AHI 5 is normal and she was deferred CPAP for the case. So to add to that, in adults less than 5 is the normal, 5 to 50, 15 to 30, more than 30 is the score that we used to follow. Whereas in pediatric population, even AHI, the cutoff is 1. That is less than 1 is normal, 1 to 5, 5 to 10, more than 10. That means that even index coming out to the 1 or greater than 1 itself is a significant risk factor, significant factor you need to address. Not only that, all these things is because of the children's vulnerability to even a minimal airflow obstruction. And the architecture of sleep is entirely different. These are the two factors. Other factors like you have a narrow airway diameter, children have high metabolic demand. Then already I told you the vulnerability is very, very high. The risk of hyperventilation is very high. You don't see hyperventilation commonly in our adult OSAs. But in pediatric OSAs, what we are stressing is that there are 2 points I need to stress here. AHA score, that what I told number, is not at all the same. The lower AHA, whatever is there in adult, is considered as a significant problem in pediatric population. You should not, leave that. The second thing, don't miss hyperventilation, which is very common in pediatric population. And not only AHA, you need to see other factors that we will discuss in the subsequent section.
Yeah, yes. So that's awesome. So he made a very valid point. Even one event is supposed to be OSA in children. So this is what the guidelines say. It's not enough that you do only AHI. So always remember, whenever you do a sleep study, AHI tells you there is obstruction, but you need a lot of physiological changes going behind. We need to look at the oxygenation. We need to look at, in a children, CO2, and then ventilation. So many other parameters which we have to look, which points towards the sleep physiology. So AHI is only one small parameter in that. So we need to look beyond that in both children as well as in adult. One another important point is in the differences in the scoring system. So what do you call as apnea in an adult? It's dependent on the duration of the missed seconds. 10 seconds loss of breathing is apnea. But in a child, it is not the duration. It is missed breath, which is the most important parameter which you have to look. That's the difference in the scoring system. So you don't look for apnea events with the duration on seconds, but you look for missed breaths. That's the most important point here. Moving on this line, let's move on to the next. So this is just the full interpretation of what Dr. Yuvarajan has said. So this patient undergoes a CPLAB, and what is the child's? So what the PSG interpretation says, clearly it is moderate pediatric OSA. Please compare this. This is 6. And in adult, this is not considered moderate. Please remember that. And events are scored by missed breaths and not by adult 10-second rule. And then there is REM predominance. What does it mean in a child? That means it's an early disease. And in adults, we usually diagnose OSA and then we go straight away for CPAP. But here, you should rule out anatomical abnormalities. You should send the patient to an ENT surgeon to look for adenotonsillar hypertrophy and things like that. That's very, very important. And the nadir oxygen is also very important. I think we will discuss that in the next slides. And what the elevated arousal index shows is there is sleep fragmentation. All these are very, very important for the child's development, behavior, growth, etc. So moving on in this, of course, children is not easy to treat. So the neurobehavioral impact is the first presentation of any child. So I think rightly here we have a psychiatrist. So let's see, let's pose this question to Dr. Karthikeya Priya. How can undetected sleep apnea influence attention, behavior, and emotional regulation in children? Do you sometimes see children misdiagnosed with ADHD just like our child, or behavioral disorders when the underlying issue is actually sleep? Or indirectly, if you have a child who's not comes to you with behavioral impact and behavioral problems, do you do a sleep study regularly on those children, or how do you decide?
First of all, I think it's surprising that sleep disturbances are quite common in childhood, unlike the assumption that sleep problems happen in elderly individuals. So times are changing, and even they say up to 20% of children are affected by sleep problems. Sorry for going out of the topic, madam. It's like because not only OSA, other type of sleep problems are also affecting the children's growth. And any sleep problem can affect the brain development, the mood, and ultimately the behavior of the child, right from learning, executive functions, the intellectual development, their mood regulation, and the behavioral changes are going to be quite common in any type of sleep disturbance. More so in OSA because of the involved hypoxia and the sleep fragmentation. It's also serious because it's going to affect lot of other systems other than the neurocognitive aspect. Honestly, I have not seen many pediatric OSA with ADHD symptoms, but in most of the ADHD patients I have seen difficulties like increased latency to sleep, like getting the child to sleep itself is very difficult because the child is very aroused. It's very difficult for the child to relax and go to sleep immediately. But definitely it is understandable that this child is going to have a lot of irritability and behavioral disturbances. And research shows that by treating the OSA, the behavioral symptoms improve. There is evidence for this. So I think the early detection of OSA is very important in children. And I think this question regarding sleep now is mandatory for even a child or an adult. Any clinical situation, we have to evaluate sleep. It's very important for some to set that sleep clinics should be there in every medical college, and regularly we have to talk about sleep. So it is there in almost all conditions. It is multifactorial, and we have to thoroughly assess the patient to handle the sleep problems and the resulting behavioral problems as well.
Thank you. So if you see a child with behavioral disorders, do you refer the patient for sleep study?
Not directly, but now I'm learning that symptoms of OSA and
So awareness is picking up. Yeah. Thank you so much.
Sleep disturbances we have to question, and if they have these symptoms suggestive of OSA or other sleep difficulties, we have to refer them to sleep study.
Awesome. So this is truly a multidisciplinary field. It starts with a pediatrician and goes round. I think it needs the family, it needs the support of a psychiatrist, it needs even for diagnosis and treatment and to follow up. So building on that, we'll move to the next question. So because in this child, we noticed a high arched palate and a mild retrognathia. From a dental sleep specialist, we would like to ask him, how do craniofacial development and dental arch abnormalities contribute to pediatric OSA? Are dentists sometimes the first professionals to detect early signs of sleep disordered breathing? Like how we ask, do you see a child with all this? Do you routinely investigate the child for a sleep study, or you send them to a proper sleep lab for a sleep test? Maybe you are the starting point where you can it happens reversely. Go to a pediatrician, go to a psychiatrist, go for PAP. I think you are an awesome person to answer this. Please go ahead.
Well, this is actually two questions put up in a single question. I don't know.
Okay.
So the craniofacial development, how I put it as, it basically starts with the Moss functional matrix theory, what we say, where the growth and development is very closely linked to the function. The function is breadth, the form is the growth of the craniofacial structures. So when the function is altered, the form gets altered. So how this is happening? Whether the anatomy and the structure and the habit and the neuromuscular issue. So this is the chicken and the egg, or what we call.
Awesome,
Okay.
yeah.
So how the anatomy gets altered because of the function alteration, and over a point of time this becomes habitual. Sometimes there's an obstruction, adenotonsillar hypertrophy, making the child breathe through the mouth, because of which the function gets altered, the form gets altered. So it's an interlinked jig, but each child presents in a different manner. Each child is different, which is the primary issue, is what we look at it. Also, on top of it, the genetics, the parents' genetics also plays a major role. So this is how we look at the problem, and we analyze from the standpoint of which is the primary, which is the secondary, and which is the tertiary. And the end result is the loss of muscular tone. That is when we give the myofascial therapy and all those things. So this is how we look at the pathogenesis of the whole issue. And the next thing what you're asking is how we look at the problem, how we diagnose. So every child who walks into our clinic, 6 years and above, there is a sleep with the breathing questionnaire in the clinic. Along with the registration form, this breathing questionnaire is done. And based on that, if there are 4 or 5 positive signs, already the patient's parents will start asking us the question. They'll put forward the issue. And then from there, we start the screening process. That is how we go into it.
Thank you so much, sir. So when a dentist can do so much in sleep, I think all of us, that's the take-home message. How many pulmonologists here, how many endocrinologists here, how many general practitioners here talk about sleep to your patient? We don't even have time to address the issue which they've come for. So I think from this whole meeting, I think giving questionnaires, getting the feedback is one form of way where we can develop sleep medicine practice, I think, to the next level. So let's move on. Yeah.
Even when we ask, they don't tell. So that's how sleep studies, many studies show that the patient don't treat as a problem. So when you ask that if there is any sleep problem, they are willing to tell. We have to be specific in how like sleep questionnaires we can give it in the waiting area, or if possible, we can ask questions regarding the duration of sleep or any difficult.
Okay, so this takes us to the diagnosis of pediatric OSA. This takes us to the diagnosis as per guidelines, AASM and AAP. What is diagnosis of pediatric OSA involved? So there are 3 criteria which all of us have discussed today. So the A is presence of these symptoms which we discussed in this exact child which we saw, and B is from the polysomnography. Remember, you need to have A, B, and C, and always remember C. You should not. These symptoms are non-specific and they can overlap with many other disorders. Be sure that you're not missing something. You're not misdiagnosing pediatric OSA for another disease. So all this postgraduates can take a screenshot of this. This is the guideline recommended approach for diagnosis of pediatric OSA. So the case continues. So the child has just finished polysomnography. Now we know it is clearly OSA. It is an obstruction. Now we'll move on to the next question. So is the obstruction phenotype the same in adults? And the obstruction phenotype, is it same in adults as well as in children? That's our next addressation. So this patient, unfortunately, we don't have an ENT surgeon here, which would have been fantastic if we had one. So because the dominant pediatric endotype is adenotonsillar hypertrophy, the boy underwent a ENT workup. He had enlarged tonsils. So first you diagnose an adult, you're not going to go through this route. Most of us don't even look at all this because the most dominant phenotype is not obstruction. It's just the muscular issues which the ENT people cannot serve. So here the first referral should be to a dentist, to a ENT specialist, to a psychiatrist and all those things. So he had enlarged adenoids and tonsils with minimal turbinate hypertrophy. He undergoes adenotonsillectomy, which is the first line in most pediatric OSA. Post PSG at 12 weeks, he shows residual AHI of 3.2. So remember this 3.2 in adults, you're not going to do anything. 3.2 in a child after treatment. So remember, we talked about the AHI difference. So definitely the AHI has improved from 6 to 3, but it was persistent and mild OSA was there. So we will pose this question to the pediatrician, Dr. Vivek Anandan. What to do with this residual OSA now? What role does CPAP or BiPAP play in children?
So I'll answer this question in 2 parts. So with this scenario, so this child obviously has residual OSA and AHI is more than 1 or 1.5 per hour. This scenario is a case of a simple OSA because child has garden variety of adenotonsillectomy, some minimal turbinate hypertrophy. I would like to rule out coexisting allergies in this child. It could be part and parcel of this scenario. So I'm saying that this child has persistent allergic rhinitis. If the child has or does not have, the guidelines say that for a mild OSA, we do a trial of intranasal corticosteroids for 12 to 16 weeks, plus minus Montelukast. With the current FDA regulation on Montelukast, slowly moving away from using it. So this child remove allergies and give a course of intranasal steroids for 16 weeks and follow up on the symptoms. On the contrary, if the child has an AHI more than 5, if it's more than, then the steroids are not going to work. Then I will classify the child as whether the child has simple OSA or a complex OSA. Complex OSA is a child who has a craniofacial syndrome or a neuromuscular disease or has some other abnormalities or a genetic problem which is contributing to the OSA. So if I am not able to offer a site-specific therapy, is any orthodontic procedure, or I would do to usually with a complex OSA, I will proceed to do what is known as ICE, a drug-induced sedation endoscopy, and see if there is any level of obstruction which I can address. But if I cannot address, I will subject the child, particularly if the child has a neuromuscular problem, to long-term BiPAP, because we need a pressure support to wash out carbon dioxide in this child. But if it's a craniofacial syndrome and I'm not able to offer a site-specific therapy, I'll proceed to give a long-term CPAP for this child. But if it is a child with a garden variety OSA with residual AHI more than 5, I would rule out lingual tonsils. I do my eyes and make sure that I don't have any adenoid or tonsillar regrowth before I address CCAR for this.
Awesome. So he has driven a very, very important message here, which I would like to say. So rule out anatomical abnormalities. If there is some anatomical growth or something, address it with surgery. But in pediatric OSA, surgery is not the go-to for everything. Even after surgery, you need to address the nasal inflammation, the dental part, the other part, and then decide on whether to give CPAP or BiPAP. So much different from adult OSA. So we'll move, taking it forward. So in pediatric sleep study, this is the most important thing. And I think Dr. Yuvarajan is the right person to speak on this. In pediatric sleep studies, what additional parameters besides AHA should clinicians look for? So at this point of time, I am sure that all of you would have understood that AHI tells you obstruction, but there is a lot more parameters which are very, very important, more than AHI, which talks about the physiology of respiration, physiology of sleep, which can predict cardiometabolic risk and things like that. So let's address this beyond AHI. What do you see in a sleep study, which is very, very important?
Just to clarify everyone that it is mainly for pediatric, not only for pediatric sleep studies, also for adult sleep studies also. Just you move ahead from AHA. So you need to see other parameters. You need to give equal importance to other parameters in addition to AHA. For pediatric perspective, first thing you have to see the oxygenation. Oxygenation, 3 parameters. One is oxygen nadir, means the lowest oxygen saturation you see in your patient during the sleep study. Second thing, oxygen desaturation index. How many events of desaturation is there in the total sleep study? The third thing, how long or how much time that your patient spent in desaturation period. Because this carries more weightage and more insult to the patient, not just AHA. Because hypoxemia is potential risk factor for all the complications, all multi-organ dysfunctions. So you need to address all these things. First is oxygenation. Second is hypoventilation. This hypoventilation has to be addressed separately in pediatric population because in adults we don't see hypoventilation frequently except for obesity hypoventilation and other phenotypes are there. But in pediatric population, even in OSA also, you have a risk of getting hypoventilation depending on a lot of factors. So you need not miss the hypoventilation. So to assess the hypoventilation, for this you have to measure CO2 levels. So Madam has clearly pointed to the previous slide, CO2 level can be monitored by arterial measurement of PCO2, but it is very cumbersome. So I always prefer to use non-invasive, especially for sleep studies. It's non-invasive continuous monitoring of CO2 is very to assess the level of ventilation. For this, there are 2 methods. One is with the nasal cannula, what is available with the PSC, you can assess the nasal cannula capnography. The only disadvantage is that when the patient is having allergic rhinitis thermate hypertrophy, when you are not very sure about the genetic flow in the nasal cavity, sometimes it may underestimate your CO2. And that situation, if it is there, then you can use a transcutaneous. There are 2 forms, nasal cannula related capnography and transcutaneous capnography, where you can measure the CO2 levels because CO2 is the indirect marker that patient is having good ventilation. If you're having low ventilation, definitely CO2 will build up and this can be monitored. There are 2 oxygen, carbon dioxide I have seen. And third thing is that to assess the sleep architecture. In the sleep architecture, you see that how much REM and non-REM period that child spent in that. Because this is also very, because we have discussed that REM sleep, REM dominant OSA is very special in pediatric population. You should not miss that. And fourth thing is flow limitation. Obviously, sometimes AHA may be normal. In adult also we see that AHA may be normal or just above the normal level. But in this actually there is one more parameter called RERA. It's respiratory effort related arousals. So this shows that previously in adults we called it as upper airway resistance syndrome. This patient doesn't fit into your classical classification of all AHA and all. They may have a normal AHA. They have more upper airway resistance, which can be calculated by more respiratory effort during sleep and more arousals. Last but not least is sleep fragmentation and frequent arousals. This will tell you a complete sleep architecture. So just to sum up all these things, oxygenation has to be seen, ventilation has to be seen, flow limitation has to be addressed with RERA, and second is sleep architecture and sleep pattern has to be. These 4 things has to be assessed along with AHA for good assessment.
Excellent. So I think the take-home message, this is not only for pediatrics, this is for our adult sleep study also. Stop looking at AHI. It is only telling you a very part of the problem. You have so many other parameters related to physiology of sleep, ventilation, oxygenation, your heart rate. You can predict the cardiometabolic risk in adults if you follow all these parameters. Thank you so much, Dr. Ivarajan. So the next part of the question is, we are promoting treatment adherence in pediatric OSA. So we'll pose this question to Dr. Karthike Priya. So treatment adherence is not only about the patient. In adult, you give a CPAP, PAP therapy, you advise the patient what to do and you get away with it. But here, this is not the treatment which is related to the patient alone, it's related to the entire family. So it is all dependent on the family support, psychological support and everything. So from a psychological standpoint, how can we help children adapt to PAP therapy or orthodontic devices without anxiety or resistance?
So in any procedure for children, we have to first educate whatever we are going to do in detail to the family members first, the parents. And then according to the age of the child, we will try to explain maybe using pictures or videos specifically made for children to the children. How address the parents' anxieties, what are their fears about the treatment procedures and what are the risks involved. And as per that, we can make the family also cooperate for the treatment.
So I think it's a counseling for the family, counseling for the child. So it's pediatric OSA is not only a respiratory problem. Please be aware of that. It is a neurodevelopmental problem. That's what this panel is driving home. So the next we'll move on to Dr. Roshan. So the role of orthodontic interventions in pediatric OSA. Can you throw some light on this? What is the role of these devices on rapid maxillary expansion or oral appliances in children with OSA? And at what age do these interventions have the maximum benefit in modifying airway growth?
Looking at this, the appliances determined based on problem is skeletal in nature or it is habitual in nature. If it's a purely habitual in nature, we look at having thinking appliances like oral screen or a myo brace or something like that. If it's purely skeletal in nature, then the problem can be a maxillary posterior crossbite or an anterior crossbite, or it could be in the mandible where there can be a retrognathing mandible. So in those kind of situations, we want to promote the growth of the jaw. We give an appliance called a twin block appliance to promote the growth of the lower jaw. If you want to expand the maxilla, we give something like a hygienic rapid maxillary expansion appliance, which will improve the maxillary dimension. When we improve the maxillary dimension, it improves the nasal resistance is decreased. So the airflow is improved. So that is what the nasal cavity, the nasal floor, what we call it as the flow, oral cavity is the floor and the ENT is the roof. So the roof gets expanded, so automatically the flow is enhanced. So that is how we expand the maxilla. And when we bring forward the mandible forward, we improve the airway. So that is where we improve the for the children. If this problem is skeletal in nature, if it's purely habitual in nature, we try to improve the breathing pattern by giving these kind of appliances. And the age group in which we target these kind of appliances, when the skeletal growth is very good, so that's when. So the maxillary growth happens very well in the age group of between 6 to 9 years. And the mandible growth maximum starts between the pre-pubertal growth spurt is the time in which the mandibular growth starts. So that's a very good age is between 10 to 12 years. So pre-pubertal. So that's the time we target the mandible. 6 to 9 years is the best age we target the maxilla. And we have seen results when we expand the maxilla, nocturnal enuresis also comes down. Because antidiuretic hormone is the main hormone which holds the bladder. So oxygen saturation gets good. When the oxygen saturation is good, the antidiuretic hormone secretion is very good, very good. So when you expand the maxilla, that sometimes you also have proper enuresis getting stopped. So that's the take-home message.
I think all of you have got the message. Such a wonderful message. So he says between 6 to 12 years, you should be aware of this, even if a child in your family has these issues. So we need to consult a dentist for this. So that brings us to the So what happened to this child? We started on APAP due to residual OSA. As Dr. Vivekanandan rightly pointed out, this child intranasal steroids and allergy control was addressed for inflammatory endotype. APP adherence coaching was initiated. Weight optimization was done. Dental ortho follow-up for airway growth support was done. And what happened to the child at the end of 6 months? Behavior and school performance improved. Enuresis resolved. Snoring markedly reduced. PAP adherence was 5.5 hours per night. That is how you manage a pediatric OSA. So moving on. Okay, so what is the case-driven take-home message? I think I have, after each question, I have addressed this. But anyway, to sum it up, children don't present with sleepiness first. That's the message for all those who put up your hands. So sleepiness is not the symptom of sleepiness, and snoring is not the symptom. Hyperactive child, behavioral abnormalities, please address them. These are the children who are having OSA. So snoring is actually a red flag. It's also a sentinel event. Remember that. So growth clues matter, and so scoring is different. As I told you, scoring in adults is with the apnea, is with the duration. Here it is the missed breaths that's very important in pediatric OSA. And dominant pediatric endotype is slightly different from adult endotype. You have adenotonsillar anatomical issues. You have nasal inflammation, which we rightly pointed out in our case. So all these things you should keep in mind. What is the impact to the child if you don't address the OSA? So that's very, very important in adults. If you don't address the OSA, you're talking about cardiometabolic risk, like hypertension, resistant hypertension, arrhythmias, and things like that. But in pediatrics, it is about development of the child. Imagine that's so important. You're going to have a developmental abnormality if you don't address this OSA. And treatment strategy also differs from adults, which is anatomy first, as we really addressed during our panel discussion. So clearly, adult OSA, pediatric OSA is not the mini pajama of adult. Clearly, there is difference. I hope that message is put across. Address the anatomical issues, which are very, very important. And always have a multidisciplinary approach in a child. So, so let's have a rapid fire round. I think another 5 minutes. Okay, a rapid fire round. The first question, within 10 seconds, I would like my panelists to answer this. Pediatrician, one clinical sign that should never be ignored in a pediatric OSA.
Snoring and abnormal breathing.
Okay. Pulmonologist, he talked about many parameters. So one PSG parameter clinicians overlook most.
Look for hyperventilation in all your pediatric population. Slow monitoring.
Excellent. The dentist, one craniofacial feature that predicts airway narrowing.
Retrognathia. That is a short mandible.
Superb. So psychiatrist, one behavioral sign parents should not miss. Okay, thank you. So if a child sleeps better, he grows better, the family is happy, the family growth also better, the child becomes very productive, the family as such becomes productive, and then we are creating a generation which is very, very productive in the form of, learning and all the problems. So very, very important to address children in OSA to build a better, energizing India. Jai Hind, and thank you very much. Thank you to my wonderful panelists. They were so awesome. I didn't have to speak so much because they have driven a lot of points. Thank you, each one of you. Thank you.
Thank you. Thank you for the opportunity. One question to the pediatrician. Can you do anything to prevent OSA in children, or anything, any research has been done so far?
So that is like, now obesity is there even in children now. So we usually have malnutrition earlier. You were talking about malnutrition. Now we have malnutrition. I usually put that slide, malnutrition. Yuvraj, your mic.
In pediatric population, what I'm seeing is allergic rhinitis and post-nasal related issues are very, very common. The commonest clinical facts, what we see is a continuous pediatric population. I think pediatricians will agree that. Many pediatricians send to me, and most of the times we'll end up with UACS as a diagnosis or persistent bacterial bronchitis. UA upper airway cough syndrome, mostly they'll have underlying allergic rhinitis also.
So these type of patients, for unknown reason, these patients have a recurrent throat irritation. They will present with adenotonsillar hypertrophy, pulmonary hypertrophy, and these patients presents with all your symptoms. And you should address proper treatment for this. So in order to avoid this, see, adenoids actually will be there. So if you have a continuous, stimulation of this lymphoid structures in the throat, definitely go for hypertrophy. You need to do address that first. You can't completely prevent it. And all the syndromic things we can't avoid because so sometimes the child is having hypothyroid. So if you are delaying the diagnosis of hypothyroid, so definitely the child will be obese and all. So they will go for all this complication. So anatomical part to some extent we can avoid, but otherwise it's very difficult.
Yes, Dr. Vivekanand.
Mental stress, I'm never. One thing I would say is for the last 3 years, we have seen around 10 children with proven obesity less than 2 years of age due to significant adenotonsillar hypertrophy. We suspect there is a significant environmental stimulation which is causing early adenoid and tonsillar growth in a child less than 2 years of age because the lymphoid growth is going to happen only between 2 to 8 years of age. So, air quality index as well as environmental allergens, smoking, indoor aero allergens are also having a very, we haven't done any formal studies to prove it, but it plays the most important role to prevent OSA probably in that age group.
Very common thing. Like you told that these irritants, pollutants, and other factors like allergens, all these things. We need to address. I think research has to be done on this to see why this is.
Anything from the floor? Anybody wants to ask the panelists or me? Sure.
Question goes to Dr. Vivekanandan.
Dr. Vivekanandan, the question is to you.
So we do come across facial abnormalities and that being the cause for OSA. Sometimes we do get complaints after usage of PAP mask. They do get some facial, maybe some disalignment or something. How do we manage?
Take What's on? Okay, come here.
Can I get your first question? So, one question.
PAP therapy in children.
PAP therapy.
We say the reason for OSA could be facial abnormalities, facial abnormalities. But after using PAP mask, they do get some facial disalignment or something. They complain with regards to that.
Majority of the times we feel mask fit or seal might not be a problem. Like we routinely what we do is a mask fit acclimatization and then we titrate in the lab. So if problem of the mask fit or acclimatization or is titration issue, then these things definitely happen. So if there is an mask fit, which is actually particularly for children less than 2 years of age, we have a lot of difficulty in getting the appropriate interfaces. So we do some modifications. So if the mask fit is appropriate, usually we don't encounter this scenario.
Pediatric
We look at now we have access to all interfaces even from a early infancy. Like we want to send a chronic lung disease child of prematurity on a home CPAP, it is possible and we are doing it on a routine basis.
Thank you.
Interface is available even for adults, children, whatever sizes. But the point is, somebody would have prescribed the wrong mask, and then the children will not agree. Even adults, it happens. And then when you try to change to the correct interface, it costs them, like 5,000 rupees per. So much. Thank you for the wonderful audience, for the patient listening. Thank you very much. Thank you.
We now invite Dr. Shivani ma'am to kindly come onto the stage and show our appreciation to all our panelists and To Dr. Kartika Priyama. Dr. Roshan, sir. Dr. Vivekanand, sir. So Dr. Yuvarajan, sir. Last but not the least, to our scientific chairperson, Dr. Kalavarathan. We now request all the PGs to stay back in the hall. Others can quickly break for lunch and come back. We will now commence with our prelims for the quiz. All PGs to please stay back.
So all the postgraduates, can you please assemble in the front here so that we can start with a preliminary quiz round? So it will be MCQ based written test. Please.
airways, your thorax and abdomen efforts. The next one is mixed apnea. It is both mixed, means central and also obstructive. So it starts with central and then it ends up in obstructive. So that is what is called as mixed apnea. Like you can see here, so there is no flow. Initially there was central and then later it becomes obstructive. Okay, there is resolution of the movements of the chest and abdomen. So there's something called as hypopnea. Hypopnea is not as bad as apnea, but there is partial closure of the airways. So the criteria is, so these are the, like you can see, it is not completely flat, but there is still some tracings. So the criteria is ASM recommends more than 30% of flow reduction with 3% of desaturation, or there should be an arousal. There is other criteria also, acceptable one with 4% desaturation. That is one thing. So for this time, I am skipping few. So ultimately, we are boiling down to what? Apnea hypopnea index. Sure, yeah. Okay, so next thing is calculating the apnea hypopneas and AHI and RDIs. Okay, you know about apnea hypopnea index. What is RDI? RDI is the combination of apnea, hypopnea plus RERAS. RERAS means respiratory effort related arousals upon total sleep time. So this value, you know it, less than 5 to 15, more than 15, more than 30. So there are few things which you can take out from this presentation. What is REM related OSA? Means REM AHI should be more than 2 times the NREM AHI, means the REM and NREM stage. What is positional? Supine OSA should be more than or equal to 2 times of the non-supine. Also, there are few more indices which you can take away from this presentation. One is the ODI. Have you seen the report saying ODI? So every polysomnography report will have a AHI, a DI, there are multiple things. Okay, so ODI means it will be a relative desaturation, more than 3%. Yeah, more than 3% or 4% drop in saturation in the formula of it. Okay. So there are a few other things like T90, time less than 90%. The amount of time this slept, how much of time the saturation was less than 90%. And minimum oxygen saturation. If it is less than 80, it is like very severe hypoxemia. There is something called as a new metric called as hypoxic burden. And want of time is keeping that. So now what you have here is AHI, ODI, T90, lower saturation, hypoxic burden. Okay, so AHI is the even frequency, ODI is the desaturation frequency, T90 is the time in hypoxemia, nadir saturation is the worst oxygen level, and hypoxic burden is the quantum of the desaturation which is happening during the entire night. So if somebody is having some chronic complications of OSA, I will say that I'll have to look at their ODI, because these are the ones which can predict a chronic complication like arrhythmias or heart failure. So, but again, there are some things which can point to acute complications of OSA. For example, lowest saturation. The saturation to a lowest limit is like even close to 60. They might have acutely desaturation can put them into something called as sudden arrhythmia and death. Yeah, sure. So final few points. So more than sitting at the raw data, what you will have is a sheet of paper with polysomnography reports. What all to look at it is what is important. So this is just an example. Quickly go through. We have a patient here, young guy, 32-year-old male, AHI of 89. Is it severe? What category it is? Severe. Okay. Now you have some things here. What I'm highlighting, you just look at it. Sleep efficiency 85. Is it better? Not better. Did he sleep well? There was a lecture which said 85%. It's a very good sleep efficiency. Means he had slept properly. Okay. There is something called a sleep onset 1.5 minutes. Like the moment he slept, he had gone into sleep. Means what? Severely sleep deprived. It can be of multiple reasons. Okay, these are the sleep stages. You can see here, like Krishnaveni said, N1, it is too much. Means there is frequent disturbances of sleep. It should be like, say, less than 15, but here it is 42. Means the sleep is repeatedly getting disturbed. REM is reduced. Means he didn't go into REM or REM phase, deep stages of sleep he had not gone to. Okay, this is also important. What you have here is the respiratory data. So you can see the mean desaturation duration is 15.8, maximum desaturation duration is 33.5. You can see the overall index, AHI index of 89.2, REM index of 87.7. So these are the arousals. Arousals means the micro arousals, or it can be really awakenings. You can see because of respiratory, patient had 11 times he had arousal plus awakening, more than anything else, more than the leg movements or more than snoring or any spontaneous arousals. The other things are PLMS, periodic limb movements syndrome. where the actual cutoff is more than 15. Here, patient didn't reach that cutoff. Again, the arousals are also not that significant. It should be again close to 15, but he didn't have any symptoms secondary to PLMS. Okay, so these are some of the desaturations which are happening. Less than 90%, patient has spent almost 22% of the sleep time. The saturation was less than 90. That is very quite significant. Okay, which can determine as chronic complications of OAS. The minimum saturation is 71. And hypoxic burden was 293. More than 70, it is a very significant hypoxic burden, means he can end up in chronic complications of obstructive sleep apnea. And even the cardiac summary, if you look at it, highest heart rate was 162 and the lowest heart rate here was 28. You can see the variation in the lowest, highest. So patient, if he keeps swinging between lowest heart rate and highest heart rate, you imagine how the heart would be like pressurized to end up in something severe. Okay, so that can cause the vagal activation can cause bradycardia, the sympathetic surge can cause tachycardia, and it is not good for the patient's heart. So the final report, how I can put it is, patient has extremely severe sleep apnea with significant AHI, lower saturation of 71, T90 of 26%, ODA of 96 with massive hypoxic burden with marked sleep fragmentation, and then autonomic instability with lowest bradycardia of 28 and highest of 162. So I would say it's a significant thing, and I would advise that patient gets his CPAP titration or auto CPAP trial done as soon as possible. Also do weight reduction because his BMI was high. And at the end of the whole polysomnography, you will get an image like this, which is the entire night story. Okay, in a pictorial view. Okay, just to put it in a different patient, I want to show this. What you see here, this is a hypnogram. The red ones are REM stage. The other ones are other stages like N1, N2, N3. What you find here is, anybody? So these are the respiratory events. These are the desaturations. During REM phase, this patient is suffering to have desaturations, and you can see the frequency of the respiratory events which are happening. So this is REM predominant OSA. So usually it happens in REM phase, but more so you can see here the patient is suffering from REM phenotype of OSA. So finally, so what a polysomnography comprises is EEG data, where you look at the architecture, you look at the sleep stages. Respiratory data, where you look at the AHI, your RDI, positional, REM, central, kind stroke, longest event. Oximetry data, where you look at ODI, mean saturation, lowest saturation, hypoxic burden. Cardiac data, you look at arrhythmias, brady oscillations. Limb movement, you look at PLMS. And hypnogram, you look at the whole night picture. So this is what it comprises. I have some few practice slides. We will finish it now. And if anything, we can discuss in person. Thank you so much.
This. What's the Google match? Come. Please, half of you join us, leadership. And half of you please join us when NIT. Otherwise,
கொஞ்சம் ஒரு 5 minutes கொடுத்தீங்கன்னா நல்லா இருக்கும் எக்ஸ்ட்ரா.
I'll tell you something.
Yeah.
Workshop.
Mm.
First thing you have to understand who is your audience group.
Yeah,
Who is
I
your
understood like
Who is
the
your
elderly group.
Say, I am a bit for GPs.
Okay.
GP, you take too much on the thing.
Yeah.
So what you have to tell is,
I skip so much actually.
but it's different same GBM standard.
Even size.
No, you have to tell what
Mm.
device, how do you stop? Who do you
So we have also included a physiological parameter. See, basically we have an anesthesia monitor in all of our ICUs and theaters, right? So we take a live video recording of that monitor, and also we have an external video recording the upper part of the patient's face, so that we know whether the patient's jaw is falling back, he's keeping his mouth open, what procedures we are doing during the dice. All these things can be monitored, and it will be all these 3 videos will be integrated into a single video. Point is, when you pause the video at any point of this video, you will know exactly what's happening to the patient. You will know like what is the sedation at which the patient is, what is the position of the patient, what is happening to the endoscopy inside, what level we are, and what type of collapse is happening, and what is happening to the oxygen concentration, what is happening to the heart rate. The entire thing will be available in one shot. So that's what we call as DISE polygraphy, or in today's Gen Z term, a DP of an obstructive sleep apnea patient. Okay. So indications, like I said, I think it must be done. If not for the cost reasons, it must be done in all patients where you have diagnosed obstructive sleep apnea syndrome. And more specifically, it's almost absolutely necessary when you are considering alternatives to PAP therapy, and when you have subjected the patient to a treatment, be it PAP, be it surgery, be it an appliance therapy, and you feel that the patient is not responding, then this is mandatory. So you have to definitely do to understand why the patient is not responding. And you can also, we have extended DISE procedures, like you can do DISE when you are using CPAP. So it can be even used as a titrating procedure. You know, you can use CPAP, you can put a endoscope through the port in the CPAP. You can understand like what pressure the patient is having, an ideal opening of the airway. So that's called as extended DISE using CPAP itself. You can do with the oral appliance. You can do procedures like lateral position versus supine position. You can do jaw thrust. You can do simple mouth closure. All these things can be done to understand how these appliances or procedures are going to help. So, surgical failures, obviously, we have to understand. Any treatment failure for that matter, we have to do a DISE for sure. So, these are the contraindication. The absolute contraindications are very, very less. Very poor anesthesia risk patient, pregnancy, if there is any allergic to medication. And this morbid obesity, it's not a contraindication. It's just that you have to be a little bit extra careful when you do DISE for these patients. So equipments, obviously you need a flexible laryngoscope. You need all these standard equipments which are available in all the theater. You need a video recording device, BIS monitor, all these video recording devices we need. These are the devices that we will require. And nowadays, the flexible rhinolaryngoscopy have got very clearer. Nowadays, we have chip-on-tip endoscopes and we have very thin endoscope. The endoscopes that we use in our center is only 2.5 mm. So it's very convenient and comfortable for the patients because it's very thin. It does not disturb their sleep that much. So when it comes to drug, 3 drugs are mainly used: propofol, midazolam, dexmed. All these 3 things have their own advantages and disadvantages. So we generally leave it to the comfort of the anesthetist. When it comes to DISE, the anesthetist is the most important person. So that's very important because it is important to have an anesthetist who knows what we are trying to look out for. So the same DISE can be different with an inexperienced anesthetist. So we always make sure that we work with one anesthetist so that we are on the same page when it comes to things. So we always leave this thing to our anesthetist, whatever they are comfortable with, we are okay with. But these are the basic 3 drugs that we use. So these are the setup. Okay, this is the basically a device used by video professionals. What this allows is it allows 2-3 inputs, video inputs to be fed into this system, and it will deliver a picture in picture. So we are feeding 3 pictures like the endoscope, the parameter, and also the external video. So we want all of them to be fused. So this is that device. So this is how this device, that's the endoscope, and this is the laptop where it will get recorded. This is the camera recording the patient's head, and this is the camera which is recording the patient parameter. And we also attach a microphone to the patient, and also the surgeon has a microphone to give a live commentary so that we can verify what we observed. So this is the software which kind of integrates everything. And obviously, like I said, the clinician does the endoscopy. Anesthetist is the most important person in the team. And the third person to assist with all this, if you want to switch the patient, do mouth closure, you need one more person for that. This is the typical setup. The black scrub is the anesthetist, is monitoring everything. That's me, the surgeon, and that's the another staff helping us with the positioning. So when it comes to DISE, the sedation monitoring is the most important thing. So we need a tool to really have an idea whether the patient is awake, just sedated, or too deeply sedated. So we don't want the patient either to be awake nor deeply sedated. We want him somewhere in between, which can mimic the natural sleep. So we use certain tools. The first and most simple is the modified Ramsay sedation score, which is a clinical scoring, which will give us a rough idea about how deeply the patient is sedated. And then you have this EEG derived scores like the bispectral index. It is a device. You have leads, it will give waveform and the number, and that number will indicate how deeply the patient is sedated. So the ideal target is 65 to 75. Above 75 means the patient is awake. Below 65 means the patient is too deeply sedated. So we want him in that sweet spot. And we can, sometimes the BIS is not always reliable. We have had patients who need to be taken to 40 for them to actually sleep. And sometimes we have seen that patients kind of snore and have a lot of apneas even at 80. So you cannot just take this as it is. So that's why you have this clinical scoring also. So you have to correlate to achieve the best results. So this is the thing. And BIS monitoring, like I said, there is a waveform and a number which you get. And this is the modified Ramsay sedation score. And we want him in this 5 and 6. So you kind of be non-responsive, but if you kind of loudly call him out or give him a strong tap, he should be able to respond. And this 5 and 6 is the ideal plane we want him to be. So you start the endoscopy while the patient is awake. You put the scope, you do an upper airway endoscopy while the patient is fully awake. And then once you go there, then you ask the anesthetist to start the sedation. And once he gradually goes into the sleep, you wait for this obstructive sleep apnea patient. There is this cycle of apnea followed by snoring and then apnea. So this cycle keeps on repeating. So we want one cycle to pass and then you start the observation. You start at 3 levels. You observe, you keep your scope at the velum. So you keep it at the posterior end of the nasal septum, or what we call as the choana. The nasopharynx, you keep the scope. You observe 2 cycles, one apnea, snoring, then one apnea, snoring. So then you move on to the next level, which is the oropharynx. For the oropharynx, you keep the tip of the scope at the free edge of the soft palate. Once again, you observe 2 cycles there. Then you take it to the tongue and epiglottis. There you observe 2 cycles. So that completes the complete observation. And if you find on a polysomnography that the patient has positional OSA, then you will have to do it both in supine and lateral position. Each level you have to see and understand what is happening with the positional change. So you can do jaw thrust, mouth closure to see, some patients problem, they have a lot of collapse happening, tongue will be falling back, a lot of collapse will be happening. But the moment you close the mouth, everything will kind of disappear. So that means that they are just simple nose block patients with chronic mouth breathing, which is causing all the fallback. So you have to do all these maneuvers. Like I said, concomitant app therapy or oral appliances can be kept, and you can do the sleep endoscopy with that also. So when it comes to the reporting, this is the standard globally accepted way of reporting. It is called as a VOTE classification, standing for V for velopharynx, O for oropharynx, tongue and epiglottis. At each level, you are supposed to mention whether there is absence of collapse, that means 0, 1 is partial collapse, 2 is complete collapse. And you have to mention the orientation, whether it is anteroposterior, lateral, or concentric, you have to mention. So at the end of the day, this is how a reporting will look. So this is the video you will get. So you have the patient's external video, you have the endoscope, you have this vital parameter where this is the heart rate, this yellow graph, and the number is the BIS, and this is the SpO2, and you have the respiratory rate, BP, all the vital parameters you have. So at any point of time you pause, you exactly know what is happening to the patient. So it kind of opens up a lot of possibilities. Okay, it makes, so the DICE is a qualitative study. You just see what is happening inside. But with addition of all these additional tools, you kind of make it into a semi-quantitative study. So recently we had one patient, his AHI was only 10, but his lowest SpO2 was somewhere at 40%. So that's something that I've never seen in my 15 years of practice. It was referred by one another doctor. I said, something is not adding up. So I said, we'll do a DICE and see what's happening. So that patient had predominantly hypopnea. And nowhere did we see the oxygen concentration fall below 90%. So you can, in fact, verify if the polysomnography, see, many a times in our country, you don't get to see people coming with level 1 study. Most of the places we do only level 3. So you cannot ask your every patient to go back and get a level 1 study. So now you have a tool where you can verify. So we told that definitely that SpO2 parameter is not right, because in that half an hour to 45 minutes, the SpO2 never dropped below 90. So that means 40 is simply not possible. So it makes kind of those kind of advantages you get. So you can, like I said, you can confirm the polysomnography findings, because by the frequency of the apneas which are happening, the degree of the apnea, sometimes you have severe sleep apnea patient, it kind of completely collapses. It takes a lot of time, 1 minute, 1.5 minutes, with a lot of desaturation. So you kind of indirectly confirm the polysomnography finding, and you understand the physiological background, whether it is an anatomical, it's a neuromuscular incoordination, you get to understand with this, and you can decide whether the patient is a good candidate for upper airway surgery or a skeletal framework surgery or a mandibular advancement device. And this is important, risk profiling. So how the patient behaves when you sedate him is kind of like a preview to how he will behave when you are doing the actual airway procedure. So you kind of have a trial match before the actual match. So that's one more indication. And there are something called as this no-go patients. So the no-go patients are like, they behave very erratically. Even to a very small dose of propofol, they kind of desaturate rapidly. And those patients, as a surgeon, we would never want to go near them. So these are the indications that we have. So this is how a normal DICE would look like. So this is a patient, he presented with, lack of refreshing sleep. His polysomnography was normal, his AHI was less than 5. We did a drug-induced sleep endoscopy, so he is in 59, so he is in the right level. But you see that his airway is still patent. There is no collapse, nothing happening. Little bit of vibration in the palate. Apart from that, his airway is quite patent. So there is no collapse anywhere. So you know that the upper airway obstruction is not the problem for this patient. So this is an example of how a DICE would look in a normal patient. So this is in contrast. This patient is a simple snoring patient. His AHI was once again normal, and his problem was the snoring. So if you see this video in contrast to the previous video, you will see that still there is no complete collapse, but you see a lot of palatal vibrations. So this is a typical simple snoring patient. So generally we won't be giving PAP therapy for these patients, right? But still the patient has come to you for snoring. What do you do for them? So you identify, you can do some conservative palatal procedure to reduce this vibration alone. So this, in contrast, is a full-blown sleep apnea patient. See the difference, complete collapse happening. That is the difference that we are able to observe between a normal patient, a simple snoring patient, and a full-blown sleep apnea patient. So you have various types of collapse. This is an anteroposterior collapse of the palate, and this is a lateral collapse. So obviously you cannot do the same treatment for both of these patients. So these are the types of collapse, and you have this, that's a tongue base collapse. The tongue base is falling back and obstructing the airway. So that's a tongue base collapse, and you have this trapdoor epiglottis. So both this tongue base and your epiglottis collapse are the ones who are non-responders to PAP therapy. So these are the commonest reason why some people fail to respond to PAP therapy. So if you do a DICE before giving them on CPAP, you will know why they won't respond. So that's the point here. So this is a prominent salpingopharyngeal fold. Salpingopharyngeal fold is the fold that sits on the top of the eustachian tube, right? So that can sometimes be prominent, and that can be a source of obstruction sometimes. So this is an infantile epiglottis. This, in contrast, kind of collapses, you can see, right? So whenever the patient inspires, so this kind of collapses on itself. So this is an infantile epiglottis. And this, in contrast, is an arytenoid collapse. The entire laryngopharynx is collapsing. So these are the different types of collapse that you can have. So finally, words of caution, always do DICE in a theater setup. It is not an endoscopy procedure. Never, send to someone who says that he will do it in an endoscopy suite. It's definitely dangerous because obviously you all know OSA patients are abnormal airway patients. So never take chances. We always say we will only do it in the theater. We always take consent for ICU admission. We have had patients even before we started endoscopy, little bit of propofol, the patient rapidly desaturated. We had to almost intubate and support him. So always be prepared for that eventuality so that you do it in a good, well-equipped setup. And like I said before, the most important person is the anesthetist. He is the one who is doing all the thing. We are just putting in a scope and seeing, that's all. So he is the most important person in the team. Like I said, take consent for intubation and ICU admission. Always be prepared to handle an airway crisis. And finally, it is only the snapshot. Like I said in the beginning of my presentation, we still have a lot more understanding to be obtained regarding this complex condition. But given the current circumstances, this is the best tool we have. So it's only a snapshot. So we have to understand the patient from a broader perspective and always remember that we are here to give solution to the problem of our patient, not to argue like which is better or that is not better. We want the best for our patient. That's the idea here. So with that, thank you so much. And any doubts or queries, I'll be happy to answer your queries. Any doubts? Doubts இல்லைன்னா ஒண்ணு எல்லாம் புரிஞ்சிருச்சு இல்ல ஒண்ணுமே புரியலன்னு. Yes, sir. Total collapse, sir. We generally that particular patient, it's a concentric collapse, very tight collapse. Tongue base was normal. Those kind of patients, we kind of advise CPAP. But then, see CPAP, even in CPAP, that particular patient which I showed, also had nose block. He had a turbinate hypertrophy, he had a septal deviation. So for those patients, what we advise is, if we just simply give CPAP, his pressure requirement is going to be high. So generally, as a thumb rule, higher the CPAP pressure, the lower the compliance, long-term compliance for the patient. So one of the important role of upper airway surgery in today's world is to improve the compliance of CPAP. Simple nasal surgery that any ENT surgeon anywhere in our place can do can improve the compliance of your PAP therapy. So for those patients, we generally do, for that patient, we did a nasal surgery, gave him a good nasal airway, advised him to go for CPAP. He is absolutely happy because it's convenient, more convenient to use CPAP with a nasal pillow, lower pressure. He is absolutely happy. Sometimes we even do palatal procedure, not with the intent of curing obstructive sleep apnea, with the intent of improving the compliance of CPAP therapy by lowering the airway resistance. So these are the things that we do for those patients. For which, madam? No admission, madam. Generally, they daycare procedure, they go home 2 hours after the procedure, but then once in a while, some patient may need intubation and ICU. So you have to be prepared and keep them informed of that. Sir, that epiglottis collapse that I showed you, it can cause very severe sleep apneas. And that epiglottis collapse is often the one which causes cardiovascular morbidities because it's completely choking. So these patients eventually, I had my own patients, we were evaluating that patient, and 35-year-old, no comorbidities, absolutely lean fellow, severe sleep apnea. We were evaluating him for the surgery. In between, he developed an MI and he had to be stabilized, treated by the cardiologist. 1 year later, we had to operate. The treatment is like, say, you have what is called as this median glossoepiglottic ligament, which attaches the epiglottis to the, if you look at it, yeah, see, this ligament is the median glossoepiglottic ligament. So for those trapdoors, if you just kind of, we have a tool called as coblation. With that, it will take 2 minutes. Just kind of coagulate this area. So you cause fibrosis here. This will pull the epiglottis towards the tongue base. That will solve his problem. He doesn't, no, Bhagya. The fibrosis will hold it here. So very simple procedure, but that can have a lot of impact. In fact, that's one of the most rewarding thing because it has the most potential to cause a lot of problems. And they will not absolutely respond to CPAP.
But ENT surgeon not trained in sleep was.
These are all specialized surgeries, madam. Beyond nasal procedures, you require dedicated training. So it's not, yeah. So it's like nowadays, this has become a subspecialty of its own. So up to nasal procedures, any ENT surgeon can do, but beyond that, palate, tongue base, epiglottis, you need people with training. People with training. Sir, like I said, see, that's a different level of different specialty. Theoretically, yes, you can argue, but then the purpose that we do and the techniques that we employ are different. So it's important to have special training. It has become, like I said, laryngology is a different subspecialty. Obstructive sleep apnea is a different subspecialty. Thank you, thank you, thank you. Yes, sir. Choking is different, sir. Postnasal drip and related choking is different, sir. CPAP will not help, sir. We have to treat the cause, sir. We treat the cause of postnasal. Right. Have I answered your question, sir? You take over.
Before we hello. Before we move on to the next set of stations, we'll just quickly announce the results for the quiz. In no particular order, the teams that have qualified, we picked 5 top teams. So, Dr. Preeti and Dr. Sukrit from IIM MMC, Chennai. Dr. Mautika and Dr. Shivaram from Savita Medical College. Dr. Akshaya and Dr. Shiva Prakash from ESI Medical College. Are you here? Dr. Akshaya? They're not here. Okay. Dr. Reshmika and Dr. Syed from ACS Medical College. And Dr. Deepak and Dr. Kiran from ACS Medical College. So the other teams are all here. Yeah. Okay. So
See, the second batch of ENT is going to happen. Whoever has not finished ENT, please move on to ENT. ENT will now only has 2 batches. So, இந்த batch எல்லாருமே ENT முடிச்சிட்டீங்களா? யாராவது ENT இங்க இருக்கீங்களா? முடிக்காதவங்க, டைஸ் பார்க்காதவங்க. Because after this we won't have another session. Yeah. Thank you.
This is abdominal belt along with the livers. This is the top and the
మీకు ఏమైనా వచ్చిందమ్మా ఫోర్ స్పీకర్లో మీకు స్పీకర్లో వచ్చిందమ్మా
would say 100%. Even though CPAP is the gold standard treatment for OSA, the compliance rate of CPAP is just 30 to 40% all over the world. And of course, you know, the people undergoing phyllopalato-pharyngoplasty and the results post surgery, if you see it is 100% success rate, definitely not. So that's why now over a period of years, instead of being OSA as a pulmonology field or belong to ENT or dental, it's more of a multidisciplinary approach in the management of OSA. So that's where we come. ENT surgeons play a major role in the improving the management of the OSA, and this drug-induced sleep endoscopy will somehow help in fulfilling the spaces or filling the blanks where I said CPAP compliance, improving the CPAP compliance, or improving the surgical technique, because phyllopalato-pharyngoplasty is a surgery for OSA. But if you say that, if you ask me the question, if that surgery will be done for all the OSA patients, definitely not, because OSA nowadays, as you all know, I'm sure there will be some lectures in the morning regarding the phenotypes and endotypes of OSA. So they, in fact, tell that certain patients with OSA, they get benefited from treatment. Certain patients, they get benefited by CPAP. Some patients, somehow, they get treated with even medicines. So we start with drug-induced sleep endoscopy. Yeah. So as I said that in order to improve the efficacy of the treatment or management of OSA, we have to know certain basic things. What are we treating? How are we treating? And why we are treating? So this drug-induced sleep endoscopy, what does it mean? So it is nothing but an endoscopic examination in an OSA patient. But when we are doing, whether we are doing in awake state or sleep state, as the name suggests, we are doing in the sleep state. Next, the question will be, so sleep means, so whether the patient, when he's sleeping, whether we are putting an endoscope, yes, that's what initially they started. So that's called a natural sleep endoscopy. So the patient will be sleeping. We will attempt to put an endoscopy and see what is happening anatomically during sleep. But as you know, as you all know, it's almost impossible to do that because awake, a patient eventually will wake up and the procedure we cannot be carried forward. So next came the drug-induced sleep. So we are giving a drug, make the patient sleep, and then we put an endoscope and see what's happening. So that came the drug-induced sleep endoscopy. So we use a flexible endoscope. So drug-induced sleep endoscopy, I'm sure that it's relatively a newer term for you or to know about that. Even among the ENT surgeons who are specializing in sleep surgeries, most of us, including me, we do plain drug-induced sleep endoscopy. But there poses the challenges. As I said that even after DICE, even after we do a surgery based on the DICE findings, still the success rate of the treatment differs. So in order to have a better universal acceptance, then came an improvisation called DICE polygraphy, where we incorporated 2 or 3 other parameters in the interpretation of the DICE, so that if you are going to present this result, universally they can accept the result and they can formulate the treatment. So in our setup in Tamil Nadu, I think maybe hardly 2 or 3 people are doing this DICE polygraphy, and Dr. Saktesh is one of them. Is almost like pioneer in putting this DICE polygraphy, and is almost like advocating this this method for the last 2 years or so. So what are the indications for DICE polygraphy or the drug-induced sleep endoscopy? As I said that it is always better to make all the OSA patients undergo drug-induced sleep endoscopy. For small example, or other way I can put, it's always better to subject all the OSA patients at least for a basic ENT checkup, because CPAP failures or CPAP intolerability is one of the major causes for non-compliance. So, for example, CPAP shows positive pressure through the nose. If the patient is having a nasal polyp or a nasal deviation, septal deviation, or an inferior terminal hypertrophy, that patient will find it difficult to use CPAP because of the large pressures. Similarly, if the nose is also clear, that patient might find it difficult to use CPAP because he might be having some pathology during sleep, which we can find through DICE, again sleep endoscopy. So all patients suspected of OSA can be given for drug-induced sleep endoscopy, and patient considered for alternative therapy other than the PrEP should be undergoing DICE. And of course, so what's happening for the reasons for failure, CPAP failure or CPAP intolerance, DICE is an indication. And for example, in order to optimize the CPAP therapy, DICE can be done, because with the help of DICE, we can almost accurately measure the pressure levels needed for the CPAP therapy. So what are the contraindications? Yes, absolute contraindications. any anesthetically unfit patients should be considered as absolutely contraindication. Pregnancy and allergic to medicines which are used in drug-induced sleep endoscopy. Relative contraindication is morbid obesity, of course, because we are dealing with airway, and during the other coming slides, we'll be discussing further about the what's the exam procedure. So in case of an airway compromise, we should have a PACA setup to counter that. Anesthetic, stay scoring, sir. Yes. So what is the requirement for drug-induced sleep endoscopy? As I said that first and foremost should be a fact should be you all should know this. This is not an OP procedure, and this procedure should not be done in an endoscopic suite. So this is a procedure equivalent of a major surgical procedure, or at least you can say consider minor surgical procedure, but it should be done in an operation theater where you have all the necessary equipments and support and personnel for the entire procedure. So yes, what are minimum requirements? We need to have a SpO2 monitor, ECG monitor, blood pressure, flexible scopy, and video recording device. BIS monitor is bispectral index and a multi-video record. So the next, first we told we are doing the endoscopy when the patient sleeps. We are giving a drug and making the patient sleep. Then comes the question whether the patient is sleeping at what level. So there is, in order to accurately determine the level, there is a index called the bispectral index. So there is a value and a waveform. It gives us a number. So a number between 50 to 70 is considered almost equal to the sleep. So if the number is above 70, we should consider that patient is in the lightest state, whereas less than 50 is so deep, maybe we cannot be able to correlate the findings. So 50 to 70 is the ideal number for performing DISE, and multi-video recorder, yes, we'll be showing the next slides. So what are the drugs usually given for a drug-induced sleep endoscopy? Three important drugs. One is midazolam, propofol, and dexmedetomidine. There is no single choice of drug. It all depends upon the anesthetist, whether in what drug he or she is comfortable. And most importantly, in some anesthetists, they use a combination of all three drugs. So this is the improvisation of the routine drug-induced sleep endoscopy. As I said that for a very only drug-induced sleep endoscopy, we don't use all these things. We put an endoscope and we record it. But this DISE polygraphy is this one. I think this instrument you can even find here in the auditorium with the audiovisual department. It is nothing but a video mixer. Like 3 or 4 inputs can be mixed and can be shown in a single screen. So one camera will be from the flexible endoscopy picture. The other picture will be from the external camera. The other picture will be from the anesthesia monitor where we have the ECG, this thing and all. So another thing will be the one external camera. So what is happening with the examiner? So we have almost 4 videos almost showing what's happening in all the different vantage point, so that if anyone sees this, so they will be able to see, okay, this is BIS monitoring at this level, the patient is sleeping, snoring, there is airway collapse is there. So there will be a commentary also. So these are the 3 equipments. One is the video mixer, and is the scope, and is the laptop for the software. So we have an external camera of what is happening in the head end of the patient. And this is a camera for the monitor. And this is a mic, one for the patient and one for the examiner, so that while doing the procedure, the surgeon will commentate what's happening, and the snoring will be picked up by the microphone. So this is the studio. It's commercially available. It's a very economical as well. So what do you, apart from the equipments and the drugs, what else you need? Yes, as I said, the minimum, you need the people to experience or face any challenges. So it does not, because for example, as I said that again, the sleep endoscopy is a procedure, but we have improvised many things because there are something called positional OSA, which can be picked up by a polysomnography. So in that, we can even turn the patient during the drug-induced sleep endoscopy and see what's happening with the airway. So we need a support for the for turning the patients this side and that side. So as I said that, so we have to confirm whether the patient is sleeping or not, and we have to determine at what level the patient is. So ideally, bispectral index, entropy, all these and all will say the same thing. In what state of sleep the patient is there. And of course, BIS monitoring is not available everywhere. In those scenarios, what can be taken is the modified Ramsey sedation score. Ideally, we should interpret together, but in the absence of BIS monitoring, we can use the score level. So this is the bispectral index monitor. You can see the waveform, and this is the number. As I said, 50 to 70 is the magic number. So this is that score. So usually a crude method of saying that once the drug is given, we should call the patient by name. The patient is not responding. It means that patient is sleeping, and we can start the scoping. So how will we do? So ideally, what should we do is we introduce the flexible scope when the patient is awake. So we position the endoscope at the nasopharynx, and we'll ask the anesthetist to start the medications. Once the patient goes deep into these planes, then we'll go further advanced. Normally, we examine 4 different areas. One is the velum, which is the palate level. Next, the oropharynx. Third is the tongue base. Fourth is the epiglottis. So that classification we call it as BOT, VOT classification. Yes, and we do apart from the routine dice, we'll also look for the positional OSA, and also we do with the jaw thrust maneuver. So to find out whether the patient can be advised like mandibular advancement devices or not. And in fact, along with this, we also put a nasopharyngeal airway, and we pass the endoscope through the airway so that it will show us whether the intervention of the nose can alter the dice collapsibility. And as I said that there are so many cases where diagnosed OSA patient been using CPAP, but is not happy, and that is leading to improper compliance. So the reason being is it may be in the auto mode, or is not sure about the pressure levels. Whereas during dice, what can we do is we can put the CPAP, we can change the pressure levels, and we can record at what pressure level what collapse is happening, and which pressure level is ideal for maintaining the airway. So as I said that, how do we report drug-induced sleep endoscopy? 4 important levels: velum, oropharynx, tongue base, and the epiglottis. So at each level, depending upon the collapsibility, we give a grade. If there is no collapse, it is 0. If it is partial collapse, we call it as 1. Complete collapse, 2. So in the nasopharynx in the velum level, depending upon the pattern of collapse, we classify as AP collapse, lateral collapse, or concentric collapse. That's a different subject altogether. Okay. Yeah. So as I said that ideally this will be the picture. So this is the endoscopic picture. This is the patient external camera, and this camera for the monitor. So along with this, we'll also having the sound of one for the snoring and one for the surgeon's commentary. So what are the advantages of DICE polygraphy? As I said that we can confirm the findings of the polysomnography, and also we can almost correlate the physiological background with the OSA, with the sleep study findings, along with the DICE findings. So this is an example video of normal DICE where patient was having some sleep disturbances, but polysomnography showed no OSA. As I said, we advance the scope. You can see the heart rate and the BIS monitoring is 59, which is okay. As I said, 50 to 70 is the ideal range. There is no obvious collapse. The airway is patent. So it's a normal DICE. with the normal findings. So this is for simple snoring or primary snoring, where the patient will be having snoring, but on polysomnography there will be no OSA. So you can see the vibration of the uvula and the other structures. So any intervention you are going to do in terms of palate or anything for OSA, it's always advisable to go for a DICE and then proceed. Yes, sir. It's a flexible scope, sir. Flexible scope, sir. So either the surgeon will stand the right of the patient or at the head end of the patient. That depends on the surgeon's choice. So yes, sir. So ideally, what we'll do is before the start of the procedure, we'll give glycopyrrolate, all the pre-meds. So, but sometimes there are nowadays even thin scopes along with the suction port. We can use even ideally we should be done with a nasopharyngoscope, but even using a bronchoscope can be done. But only thing is the diameter should be as small as possible, because bronchoscope diameter will be quite huge. It will impinge the nasal structures, so that will cause other complications. So ideally, thinner diameter, and some bronchoscopes with pediatric, we use a 2.8 to 3, sir. 2.8 mm PS. That's what, sir. But only thing is, what we have observed with the bronchoscope is, sir, this ideally total DICE duration, the study period, at least it needs minimum of 15 to 20 minutes. Because it's not like you make the patient sleep and put a scope and we see. Ideally, at least we have to wait for at least two apneas episodes, then only we have to examine at each level. So altogether, it will take minimum of at least 15 to 20 minutes minimum. Maximum, he says, according to him, he will take at least minimum 40 minutes. Is usual. So you can imagine the bronchoscope. Definitely, there will be a lot of stress to your shoulders, and it will be painful. So ideally, there's a. That's what, ma'am. Yes, ma'am. Excellent point, ma'am. That's one of the limitations of DICE. Especially, we cannot cause REM sleep during a drug-induced sleep endoscopy. Whatever we do is it's a NRME sleep only. But only thing is, depending upon that's what one of the improvisation of the DICE is the all this videography, everything and all. But the extreme level, the best method we can what we do is we can incorporate level 1 PSG also with this. So we can correlate with the sleep stages and then the findings. No.
Yes, madam.
Yes, ma'am. Yes, ma'am.
Just to identify the level of pressure, madam, as you rightly pointed out, there is no way to recreate a REM sleep. That's impossible.
Yeah.
This is the closest that we can go to the natural sleep, but REM sleep is still a gray area.
Gray area.
Cannot be. Madam, see,
Uh-huh.
it's only our, the no snore is our objective. But okay. குறையறத பத்தி கேக்குறீங்களா மேடம்? இல்ல, I didn't understand your question properly. சரி மேடம்.
They want to rule out again. You have to money dona.
100%. Madam, actually, what you are saying is 100% right. In fact, the most difficult to treat patients are the simple snoring patients. So treating a patient is actually easy. You have to, if the daytime symptoms improves, So, but treating a system snoring patient is the most difficult. But it all comes to being very transparent with the patient. So, when I see my patient, OSA patient for the first time, I make sure that I spend at least 40 overfeeding with him with all the information. So whether he understands or not, we have to make every effort to give him all the information so that he understands what's really happening to him. So what I have found is when you do that kind of a detailed counseling, the patient themselves come to a realistic level of understanding. So if still after all these the patient has unrealistic explanation, I think those are the ones we should stay away from.
In fact, to answer your question, madam, அந்த மாதிரி ஏதாச்சும் கேட்டாங்கன்னா வந்துட்டு you can only tell that இது எதுக்குன்னா எதனால கொரட்டை வரும் கண்டுபிடிக்கிறதுக்காக மட்டும்தான். MAD, yeah.
It depends on like what is the patient's problem and what is the expectation. So I think a very detailed and transparent initially is very important no matter whether we are treating a severe sleep apnea or a snoring. More so important for a simple sleep.
Functional anatomy.
Yes, sir. Exactly.
We need a tool. See, polysomnography is a quantitative study. It will only tell us what is not what is causing. So you need a tool to say what is the predominant reason for the problem. So it can be many times multifactorial. You will have anatomical factors, you will have neuromuscular. You cannot say that there will be only neuromuscular problems, there will be only anatomy. So you need a tool. As you said, there are gray areas. REM sleep cannot be replicated. But then this is best you have. Maybe if you down the lane in the future, we may have a better pressure.
He's improving.
Madam, lot of we are living in the era of AI. Lot of exciting things are happening. We don't know. 2 years down the lane, we may be discussing about something else.
Yes. So again, this is a case of an OSA patient using a DISE. You can see there is actually apnea taking place and there is collapse of these structures. So we saw initially a normal DISE. We saw a patient with simple snoring, and this is actual OSA patient. So that's what I said. Again, there is what type of collapse, at what level the collapse is happening. So that plays an important role. So as I said that in the velum level, there are different types of collapses there. Antero-posterior collapse, where there is collapse between the anterior and posterior direction. Where the lateral collapse, the lateral walls collapse during the sleep. And in some cases, called the what we saw is the circumferential collapse, the first thing. So when you go down the T, that is the tongue base, you can see the tongue base collapse, and lastly, you can the epiglottis collapse. In fact, if there is an epiglottic collapse, patient can never use a CPAP. So that's now we come back to the first starting point, whether DISE is necessary for all OSA patients. The answer is yes. So this is these two fractures of these prominent salpingo folds. So that can also cause collapse of the airway. And in the last 3-4 videos, each video will have a different set of treatment. No, sir. 40 minutes. At least right. At least 2 episodes of apnea should occur. Each level, at least 2 apnea episodes should occur to record. So again, is a case of an infantile epiglottic collapse occurring in children. So you can see the epiglottis collapsing like sideways. There is also the arachnoid collapse. Here you can see. So coming to what should be done or what should be done or what should be taken care of before doing dice or during dice is, as I said, that always dice should be performed in a well-equipped OT setup because this looks attractive, this looks actually effective way, but at the end of the day, we are dealing with the airway. There is every possibility of airway compromise or airway collapse during dice. So only when there is a very capable anesthesiologist with you, all the theater setup you have, you should even think of dice because it's not recommended to do in a OP setup or like a minor procedure room where we don't have any setup. And this may sound scary for the non-ENT people for consent for intubation and ICU admission for a DICE procedure. Yes, but it's always better to get the consent before going for the procedure because 1 in 100, we may end up with an emergency and we may need to intubate and observe for a little while because OSA patients, they don't behave the same way. And as I said that we should always be prepared to handle airway crisis. So to conclude, DICE is only a snapshot. That's to answer ma'am's question. So it's just only a snapshot of the patient's OSA at one particular point. So understanding the patient from a broader perspective cannot be understated. And that's why, as I said, that in this ever-growing OSA field, that day by day, each and everything, like 2-3 years back, only we were using doing DICE. Then we are incorporating the other video recordings and along with this PSG findings in order to improvise the interpretation of the results so that the same DICE finding can be interpreted and treated in the same way in the other part of the world. So, thank you. So, any questions, sir?
Sorry, madam. You mean the disease process, madam? That depends on like his lifestyle, his BMI, and all those things definitely matter. If the patient, that's why the counseling is very important. Even at the first visit, we should make very, very clear. There are a few things which we cannot control as the treating physician. You cannot control the fact that the patient is going to age. Today, your patient is 40 years old, 5 years later, is going to be a 45-year-old. That's something that we cannot control. And if his lifestyle is bad, that in 5 years is going to cause even more problems. He is going to become a lot more obese, lot more weaker. So we have to impress on the patient that having a healthy lifestyle, focus on fitness and weight management is very, very important. No matter whether we give him CPAP or surgery or whatever treatment, maintaining a healthy lifestyle and maintaining the weight and fitness. More importantly, fitness. So when we say weight loss, they go for fasting. 3 months later, they come back, doctor, now on the 15 kilo cholesterol. 1 year later, you see, you would have gained weight. So that's not the idea. So it should be a long-term, sustained fitness is more important.
Which one? CPAP, ma'am? CPAP is not a treatment, ma'am. It's an like a walking stick. Exactly. Exactly.
No, it's not like a progressive disease. As the patient ages, the muscle is. But nowadays, we have certain studies which say that elderly people with snoring do not have all those morbidities associated with OSA. So they say that the OSA which is happening after 60 years is totally a different kind of this. That's see the 30 to 50 years. That's where all the morbidity and mortality happens.
CPAP, ma'am.
Madam,
CPAP,
it is you cannot call it symptomatic. they work in different ways. So see, ultimately they gives relief to all the problems associated with obstructive sleep apnea. So you cannot just simply call it symptomatic therapy. It is a way until a point where we have a complete understanding and control over all the etiological factors of OSA. This is in fact one of the proven treatment methods for children.
बेचारी मैं फोन में देख रही हूँ छोटी सी
Thank you,
हम
sir.
लोग के
Thank you, sir. Oh, man. Oh, காலையில வந்தீங்களா? காலையில எங்க? என்ன மீட்டிங்? ஓ, அன்னைக்கு.
We have a few friends earlier.
What does the friend saying? Do look up and do tell me.
Indian philosophy goddess. So that's the one who's connected to goddess.
One camera was specifications. What's the purpose of that?
ஏன்னா வந்து பேஷண்ட் அந்த டைம்ல ஸ்னோரிங் இருக்கான்னு பார்க்கணும். பிளஸ் பேஷண்ட் வந்து நம்ம கொஸ்டின் அப்போ வந்து ரைட் சைடு லெஃப்ட் சைடு திரும்புவோம். அப்பயும் நம்ம வந்துட்டு பார்க்கலாம். பேஷண்ட் கிட்ட நம்ம சொல்லலாம் இந்த மாதிரி நம்ம வந்துட்டு உங்களுக்கு ரைட் சைட் பண்ணும்போது வந்து உங்களுக்கு இந்த மாதிரி இருக்கு அப்படின்னு நம்ம சொல்லலாம்.
Also moving. Because this is the comfort of water. So you see, this may be what's this. Your understanding.
Study that is excellent home-based study with at least 4 leads. That is your pulse oximeter, oxygen, ECG, heart rate, and your chest breathing units and abdomen breathing unit. This will be enough. From that, we are seeing apnea, hypopnea, and we are diagnosing how to sleep apnea. So once the patient is diagnosed with obstructive sleep apnea, this the best treatment. PAP therapy, positive airway pressure therapy. So in PAP therapy, the first and foremost which that was introduced was CPAP. CPAP means continuous positive airway pressure therapy. Mic first
ரெக்கார்டிங் இது தனியா
obese patient நம்ம diabetic பேஷண்ட்டுக்கு 1 year பொறுத்து ECG எல்லாம் சொல்ற மாதிரி obese பேஷண்ட்டுக்கு OSA சஸ்பெக்ட் பண்ணா நம்ம ஸ்லீப் ஸ்டடி பிரிஸ்கிரைப் பண்ணலாம்.
ஸ்லீப் ஸ்டடி பிரிஸ்கிரைப் பண்ணலாம், முடிச்சிடலாம். அதுக்கப்புறம் நம்ம டவுட்ஸ் ஒவ்வொன்னா நம்ம கிளாரிஃபை பண்ணிக்கலாம். சோ நீங்க ஸ்லீப் ஸ்டடி பண்ணிட்டீங்க, OSA கண்டுபிடிச்சிட்டீங்க. நெக்ஸ்ட் ஃபர்ஸ்ட் லைன் ஆஃப் ட்ரீட்மெண்ட் இஸ் கோயிங் டு பி CPAP therapy. So first and best one is CPAP or the PAP therapy. In the PAP comes the CPAP. CPAP na continuous positive airway pressure. So idhula enna one pressure that which we will decide the patient will be getting throughout the night. For example, you can set 5 centimeter of H2O or 10 centimeter of H2O. That patient will be getting from night machine same pressure machine will give. How do you decide this pressure? It is by doing a manual titration. So how do we do titration? Day 1, we are doing a sleep study. Day 2, first day day 2, you have to do a sleep study along with the CPAP mask. So first 5 H2, you will run the sleep study. He's going to continue to have apneas. Then you will increase from 5 to 8, you are increasing. And then you observe how many apneas are there. Again apneas are there, again you increase. So this is how we titrate and set a manual pressure for a CPAP. But nowadays, we are not doing those things. We are more going in for auto CPAP. Auto CPAP, now, the machine itself will sense how much pressure we need at that point of time, and the machine will automatically deliver. So, this is an auto CPAP machine. So, in an auto CPAP machine, we are going to make a few settings before we give it to the patient. Main thing is minimum pressure and maximum pressure. Minimum pressure, you can go as low as 4. And maximum pressure, you can go up to 20. So between 4 and 20, the machine will sense when there is apnea, when there is hypopnea, and machine will decide to give how much pressure in each breath, whether how much a patient is needing, that much the machine will give. We are not setting one pressure. We are only going to set minimum and maximum. Then we have ramp time. Ramp time means the time taken from the start of the machine to the time taken to reach the maximum pressure of the device. Imagine 20 is the maximum pressure that you have kept and 20 the patient needs. If you have kept ramp time can be kept somewhere from 5 minutes to 45 minutes. So if you are keeping ramp time as 30 minutes, if the patient is starting the machine at 8 o'clock, by 8:30 patient will be getting 20 centimeter of pressure. Cause why this is kept is immediately ramp pressure is less or lab pressure is 5. The moment you put the machine, it is going to deliver 20 centimeter of pressure. Patient will not be complained. Immediately so much of pressure will be coming. Patient will not be complained. So ramp time will allow the patient to accommodate and accustom to the pressure. So it will start from a lower pressure and gradually it will increase so that patient will get adapted to it and he will be having better compliance. One. Second, we have EPR, expiratory pressure release. It is having 1, 2, 3, 4 modes. It basically what it does is it allows a moment for the expiration to happen. So always there is a continuous pressure that is going on. How do the patient expire? So you need to give a pause. So it's not exactly a pause. Basically EPR 1 means 1 centimeter H2O will reduce from the pressure. So that pressure difference will allow the patient to expire. That's all. That's all with auto CPAP. Auto CPAP now basically we see CPAP means we set one pressure after manually titrating, which we are not doing now. We are doing only auto CPAP. In auto CPAP, you can't give the number to the vendor and they will only set minimum 4, maximum 20, minimum or average or ramp for 30 minutes, and the EPR they will give 2 or 3, and patient has to just wear it, and that's it. Good to go. And all these machines will have something called a humidifier. This is the humidifier where you can remove it. This is the humidifier. Humidifier has to be filled with water. So this is the water. So every day patient has to either he can choose not to use a humidifier. If he is going to use a humidifier, he is going to wash it daily and fill it with RO water, drinking RO water. It is better to use a humidifier because it is going to, dry air is going to dryness of mouth, dryness of sore throat. Patient is going to complain of all these things and stop using the machine. For that, we need a humidifier. That's all. Next, we have BiPAP. BiPAP means bi-level positive airway pressure. We have two pressures. One is IPAP and one is EPAP. IPAP is nothing but inspiratory positive airway pressure. EPAP is nothing but expiratory positive airway pressure. So inspiratory pressure means you give higher pressure of 12 or so on. Expiratory pressure means you give a lesser pressure and allowing him to expire during that time, which is starting from 5, you can titrate upwards. BiPAP has few modes. One is BiPAP ES mode. ES mode means spontaneous mode, wherein the patient is going to take a breath and machine will support. For example, in obstructive sleep apnea, patient will have that breath trigger, patient will breathe, but there will be obstruction, so he is not able to breathe. So what the machine will do, it will give pressure and make the airways open, give a pneumatic splint and keep the airways open. What happens in a central sleep apnea? Patient is not having a trigger, patient is not triggering a breath. So machine is just going to sit there and wait for the patient to breathe. If the patient is breathing, it will give pressure. What if the patient is not even breathing, as in central sleep apnea? So that is when ST mode comes in, spontaneous timed mode, wherein there is a backup respiratory rate that is set, for example, 6 or 8. So whenever the patient's breath rate goes below 6, machine will automatically give 2 breaths. For example, patient is only taking 2 breaths. Remaining 4 breaths, machine only will give. And pressure also it will only give. So that is ST mode. In this also we have RAM time, inspiratory time, all those things, everything we can set in this also. In this also there is humidifier. And we have different masks that are available. This is the most commonly seen and used mask. This is an oronasal mask, which covers the entire face, starting from the nose, mouth, towards your chin. There are different sizes, SCML. Whenever we choose a mask, we have to choose the appropriate size for the patient's face. It has to be adequately fit, snugly fit. It shouldn't be loose. This portion shouldn't come outside your mandible, and it shouldn't be too tight. It should be easily removable for the patient also when if he wants to remove. Different sizes are available. So basically, this should be a vented mask. There are 2 types of mask available. Usually, the NIV ventilators that we are using in the ICUs, that will also, we will use similar mask. But that is a non-vented mask. So whenever patient is shifted from an MDCCU or we are using a mask that is used in the ICU, we have to make sure it is a vented mask, because ventilator NIVs will have 2 tubings. One will carry oxygenated and one will carry deoxygenated blood. So there is that is not the case by BiPAP. Only one tubing is there, that is for inspiration, and for expiration we need this port. This port will work as an expiratory port. This is needed. So where do we use BiPAP and where do we use BiPAP? Usually goes in with this mask. Where do we use BiPAP is where you're suspecting apneas, as in central sleep apneas and COPD patients, where there is CO2 retention, CO2 narcosis. You need BiPAP to wash out the CO2. Obesity hyperventilation syndrome, where OSA with OHS, where daytime hypercarbia is more than 45, BiPAP is preferred. Other masks that are available is, this is a nasal mask. This goes on the nose like this. This triangle one goes on the nose. Then we have nasal pillows. This is one type of, this is one type of a nasal pillow. This will go into the nose. And this is one type of a nasal pillow. This is also one type of a nasal pillow where nothing will go into the nose. It will nicely, snugly fit in the nose. And this is also one type of nasal mask. And there is oral mask, and there is another type of mask where it will be like this, but it will be attached to the mouth also. This is usually more comfortable. Patient compliance is better. Patient will be able to talk, eat, and all those things. With a bigger oronasal mask, patient will not be able to eat or talk, and that is a limitation. And sometimes they might find it not suitable for them. But the problem with this mask is there is going to be some amount of expiratory leak through the mouth. If the patient is a severe mouth breather, you should ask the spouse or the bed partner of the patient whether he has a habit of opening his mouth and sleeping. If that is the case, this might not be as effective as it should be, but still it can be used, and sometimes it just overcomes that. And also, if there is nasal polyposis or turbinate hypertrophy, if the intranasal pressure is more than 5 centimeters, this will not be enough for the patient. So in that cases, we might have to go for oronasal mask. What else?
They can lie.
They can supine or prona. They can lie supine and lateral. Prone also they can lie down, like and put their face one side and they can lie down. They cannot lie face down. They can turn their face to one side and they can lie down. If they want to go to the toilet or something in the middle of the night, they can just take it off, go to the washroom, come back and put it like a mask. It's very simple. Put it like this and take it out. When you take it out, machine senses it and stops on itself. When you come back and put it, machine senses it and it starts on itself.
This automatic CPAP recording recorded in
Yes, the recordings, the complaints report it is called. It comes to the patient's mobile app that is integrated. It also goes to the supplier's vendor's chip. Yeah. No, it doesn't go. There are some things that can go to the consultant, but here in routine setup, it goes to the vendor. So vendor can give it to us, or the patient can directly show it to us. So when the patient is coming after starting CPAP, when the patient is coming to us for review, the thing that we are going to look at is complaints report. So what are we looking at? We are looking at least 4 hours of usage per day and at least 5 days of week. This is the basic minimum that is needed to to overcome the complications that we are expecting out of OSA. But we are not going to tell the patients that you should use at least 4 hours and at least 5 days. If you tell full night every day, he's going to use it for at least 4 to 5 hours, 4 to 5 days. All these machines can be packed in a small carry bag. They can carry it anywhere.
sleep study பண்ணாம வெண்டாட்ட நேரம் நம்ம அவங்களை அனுப்பலாமா?
No.
Some patients are coming.
No.
நாங்க நெட்ல எல்லாம் பார்த்துட்டு
Never.
CPAP தான் எங்களுக்கு வேணுமா?
Never. You should always do a sleep study and you should clinically evaluate, rule out coexisting lung conditions, other nasal polyp. Even for selecting an interface, you should be knowing, is there nasal polyposis, is there nasal hypertrophy, is there any oronasal things, is he having any mandibular problems, whether any mandibular advancement device will be useful, any ENT procedure will be useful. We should clinically assess, and then you should do a sleep study and then confirm the AHI and make sure whether it is a sleep obstructive sleep apnea or central sleep apnea. Then you will tell them what machine to buy. You will tell them whether he needs an auto CPAP or he needs a BiPAP. With BiPAP, you will tell them the pressure, not the vendor.
CPAP without COPD, without CO2 return.
Correct.
With the retention, we have to go. But we have to first rule out other basic things.
Correct.
That's a must.
Correct.
நாங்க பேஷண்ட் லூஸ் பண்ணோம்.
Nasal congestion. No, it is not for such things. It will not work for such things. In fact, during nasal congestion, this will not work. This might not be that beneficial for them. Nasal congestion, we need to find out the root cause of the nasal congestion, whether it is allergic rhinitis, whether they need any intranasal steroid spray or intranasal antihistamine spray. That has to be addressed side by side along with OSA. Along with the OSA. Just for nasal congestion, definitely we are not going to give CPAP. If nasal congestion plus OSA is there also, we are going to address that nasal congestion. We are going to see whether it is allergic rhinitis. We are going to optimize the allergic rhinitis treatment. And then along with it, we are going to give CPAP therapy.
Thank you, ma'am.
And there is one more thing called adaptive servo ventilation. That is also like specialized type of bi-level ventilation, wherein there is IPAP and EPAP. But only thing is, this machine is like slightly intelligent, where it will assess your breath minute by minute, and you will tell the machine how much tidal volume needs to be delivered, and it will adjust the IPAP also to your need, so that your targeted tidal volume or minute ventilation is delivered accordingly. Adaptive servo ventilation can be used in central sleep apnea and all those things. The main contraindication, you should know where we should not use that, mainly in heart failure with reduced ejection fraction. There we shouldn't use high mortality.
But this can be weak. Automatic, it can be.
That is costlier, that is not easily available. So that is one of the least used or seen machines. The most common ones are CPAP and BiPAP.
Thank you so much.
Doubts? Sure.
If we put card or something, we have card. If we want to buy this, how can I approve it?
I'm a doctor.
Yeah. I understood it very well. And you told about COPD, thank you.
You are doctor?
I'm an orthodontist actually. My grandparents is using this COPD actually. So that's why we're thinking about it.
Hi. Tara.
You're it? Chapla.
வேண்டாம் வேண்டாம் அவங்க தான் ப்ரோ மாட்டிப்பாங்க இல்ல அவங்க தான் மாட்டுவாங்க Yeah. That's why we always make sure that kid has to chew both right and left. For chewing right and left, you should know the how much of quantity of food has to be kept in the mouth. Only just 5 to 10 this amount of food. But most of the people they stuff the food in the mouth. Kid doesn't know how to chew. They swallow. Where we start the respiratory problem. Once they swallow, all the muscles are getting spasm and airway blockage, and kid will start with a mouth breathing habit. When this mouth breathing habit continues in the adult phase, they will have a OSS symptoms. So we are looking for any obstruction in the oropharynx in terms of tongue posture and tonsils. And this is what we do most of the time when you want to check your patient. Okay. First, width of the arch. Width of the arch, intermolar. We always look into intermolar width. It's 36 to 39 mm is normal. When there is a V-shaped arch, totally collapse. When you ask the patient to open the mouth, you can see the tooth impression in the tongue on the lateral border. That shows the jaw sizes. In visual examination, whenever you don't have a V-shaped, U-shaped arch, V-shaped arch prone for OS. That's why only one race for me doesn't have a OSA is an African race because their arch is wider. Only our Caucasian and this side of the world is suffering with the OSA.
Who has a U-shape?
African race. African race or any tribe. If you go and see a tribe in Sentinel Island, Andaman, any tribe has got a because they use a rough diet. They use a rough diet. They chew properly, both right and. That's why you have to chew both right and left. If you don't chew right and left, your jaw collapses. Okay. So whenever you see the width of the molar, it's correct. Your airway is open. As simple as that. When you look at this patient, he is totally with the worst lifestyle he is following. When you look at the neck, throat, the collar circumference. When you look at this arch, the obesity, can you look at this arch? It's not V-shaped, but U-shaped. But for this type of patient, we have to advise a lifestyle management. And then where the collapse is vertical or transverse, again, you have to check for your airway. And deviated nasal septum. Can you able to see the deviated nasal septum here? Deviated nasal septum here, there is a collapse in the arch.
Most of them are deviated.
That's why most of the deviated means deviated septum is mostly with the bite force. When does the bite force started means they clench the teeth. Right from the childhood. Why do they clench the teeth? The stress factor. Even a kid has
Palate. Palate is the roof of the mouth and it's the floor of the nasal cavity. So if the roof is narrow and high, what is happening? It is actually encroaching into the nasal cavity space. So because of that, when the cartilage bone is very thin, it gets like deviation.
always the base of the skull, no, base of the dental arch is wider. Only the dental arch is collapsed. Why? Because you have two bone. One is a basal bone and one is an alveolar bone, which takes the dentition. Alveolar bone can be modified at any age. It's not nothing to do with the age. That's why we expand the alveolar bone by means of this screws, making a V-shaped into a U-shape. Okay. Is it
age this is done?
any age it can be done. It's not nothing to do with the age. Even after 70 also it can be done.
Our oldest patient is 71 years.
Okay.
Huh?
children, it works amazingly, madam.
Yeah, that's what
Children,
this.
it's the exercises, myfunctional exercises themselves will work. But if they come above the age of 12, we have to start with these kind of.
Like I've had two surgeries in my nose. One for the septum when I was 11 and a half, and one when I was 30 for the polyps. My nose has still collapsed and become worse because of that.
As simple as that.
We need
Put
to
a
check your-
palm over there, clench your teeth, your masseter will come out of it. Clench
Gently.
gently.
Here.
Yeah, this is
Aha, coming. That's the reason for that. Huh? The bite keeps bending your nasal septum, not removing the nasal septum.
The maxilla is a softer bone compared to the mandible, and the bite force can alter that bone.
Repeated,
What is the remedy for him?
you have to evaluate the vertical dimension.
Maybe I've had two surgeries on my
Trumpet surgery, you had a nasal polyp removed, you had a septum surgery.
two separate surgeries.
Surgery. But surgery that we are referring to is not going to in any way affect your nasal bones or the cartilage in any way, or not even the septum actually. You're only going to deal with your maxilla, which is your upper jaw, and the mandible was. So when sir spoke about expansion also, like when we as surgeons have to work with sir or ma'am, we sit together as an interdisciplinary team and we discuss as to how to actually plan for the surgery. So sometimes it's very difficult to just expand your arch. So what we do is we have a suture in the middle between the two halves of your upper jaw. So
We split the suture.
with the assisted rapid,
We split the mid-palatine sutures and then expansion happens.
it's already fused. We just simp along that region and expand it. So when we expand it, automatically this region has a fuller field. So
That will be there for some time.
Only for the temporary, only for until you get the expansion. After that, it will be removed.
2 months.
same with not just for expansion. So also now we have various plans of 2030 and I'll figure out how much of your upper jaw is behind in relation to your lower jaw, or your lower jaw is behind in relation to your upper jaw. That's called this pilometric analysis, or we do it with various scans that we have. Based on that, we advance just the upper jaw or advance just the lower jaw or both. They are all different types. It's called not orthodontic surgery.
Both these two surgeries essential to be done on my nose? Could have been avoided?
It would not be a question of comment answer because at that point I what you were presenting with. They don't know what you were presenting with. That would definitely not be
Yeah. That's why when you have a deviated nasal septum, you got this acute sinusitis.
Yes.
Vertical dimension collapse. There is no space for the tongue going back, collapsing the airway.
Exactly.
No, the dog has returned if you don't know. You just. No, that time how that is. No, no. She was mainly accepted. Mainly accepted. Oh.
1995. That 2000.
Most of the OSA patient, they start with allergy and land up in OSA. So when you look at this,
Lifestyle change.
lifestyle change is getting into the sun first, eating sunrise and sunset, and then no sugar, more protein, and healthy lifestyle,
More sugar and
more protein, no carbs, more protein, and then exercise, exercise, and then finally sleep quality, weight reduction, sleep quality. So
Yes, produce.
Okay. Somewhere something that comes in the picture is also train for patient.
and your mental hygiene, you have to be stress free.
That's the.
The mind is my mind is like that.
The concept of changing, basically in orthodontics, everybody wants to get the teeth back for aesthetic reason. So they pull 2 teeth in the upper, 2 teeth in the lower. That's the worst thing can happen. But we have to change. If you retract both upper and lower anterior for the aesthetic, you don't have a volume for the tongue. Tongue also goes back. This patient has gone with all 4 extraction. Again, the tongue gone back, and then there is a airway collapse. There are multiple reasons where you can get your airway collapse. Mostly in the oropharynx, it tongue posture. Whether you do iatrogenic or by default, your vertical dimension collapse, it goes for. This patient has gone with all 4 extraction, all premolar extraction. There is no space for the tongue. Can you able to see this? When you don't have a space for the tongue, you have a tooth impression on the tongue. That shows that the patient has got collapsed arch. Vertical collapse. Vertical collapse means people losing the vertical dimension. Vertical dimension may be attrition or removal of teeth. Most of the people, they think that 32 teeth, you can lose one. 32 teeth is managing your airway.
Yes.
If you remove your teeth, this is condition applied, not for wisdom tooth. Wisdom tooth only we have to remove at present. All other teeth, it has to be replaced. If you have already removed, you have to reconstruct the, what you call the vertical dimension. And then vertical dimension is constructed according to a airway, not just giving a denture or what are called ceramic bridge, not for aesthetic or chewing. We are working on the airway. We have to relieve the vertical dimension, then the airway is open. When you look at this patient, can you able to see the airway collapse?
There will be, if it is because of a dental construction, dental problem, once we do the corrections, you will see in the CBCTs later taken later, there will be opening up of the airway. Patient, basically better quality of sleep will be there. Morning tiredness will not be there for these patients. They will not clench their teeth. And as sir was telling, this masseter muscle, the hyperactive masseter muscle will come down. Sorry, ma'am? Practicing.
I didn't get you.
The surgery. For bruxism இருக்குன்னா நம்ம bruxism is not just the muscles or the teeth. It is also your mental status, your stress protocol, your entire soul. So if you're able to give a holistic approach to it, you deal with the mental health. You give. There are some muscle reduction surgeries called as myotomies that we do. Some surgical procedures that we do, like advancing or retruding, or even providing the mandibular like devices like these. Obviously, 100% surety we cannot get because we don't know which aspect is actually working in terms of bruxism. So 100% cannot be assured ever. But at least an 85 to 88% of betterment overall is something that we can at least, I would not say assure, but we can give him some positive betterment to the patient. And I don't think there is any surgery in the world that can 100% replicate or 100% give you complete assurance. Everything has its positives, its negatives, and even side effects to a lot of extent. With surgery, ma'am, the facial surgery, splitting of the. So that was how it was before it fused. So when a baby is born, it was not that the sutures were fused. Over a period of time, around the age of 5 to 8 is when it starts fusing. We are simply along the fused sides creating a barrier so that we can expand and provide a better output for the person. But at the same time, we will not do it for all patients. Now, the splitting of the upper arch is for certain patients. There are certain indications to it. For some patients, that will not be required. Just taking the maxilla in the front. Now, taking the maxilla in the front has some 4 or 5 procedures by itself. We just take the anterior aspect or we take the entire maxilla. That also cannot be done for all. If we're talking about the mandible, just the anterior or the whole. When we talk about whole mandible in the front, there are 3-4 other types of surgeries associated with it. So we definitely have to look into the indications of the patient and then give a holistic approach to the patient. So if you're asking for assurance, 100% is not there, but maybe an 85 to 88% betterment overall for the person can be given as a positive output for the patient. Outlook for the patient.
Are these done on
Side effects, ma'am, yet again, okay, now if every surgery has its own side effects, it could be in terms of the paresthesia, wherein there's a loss of sensation around that region. That also could be reversible or irreversible depending. So we have to determine what is the greater positive we are looking at as against the negative. So complications are something that would arise based on the procedure. Now, if you talk about mandibular advancement device, I'm sure sir and ma'am have a lot to add on, but I don't think there are any side effects to mandibular advancement apart from some stress along the temporal mandibular joint. Yes. We are definitely not creating a cleft palate for the absolutely. We'll not be completely, when we talk about splitting of the palate, we are not completely splitting till the end more. It's just the anterior aspect of the palate that is splitting so that we can provide some expansion.
Only the hard palate.
Hard palate.
Yeah. Good evening. So after the workshop, we've come to the last event, but it's always the event that we look forward to. It's the quiz event that happens annually. And it gives me immense pleasure to welcome back our quiz master, Dr. Sridevi ma'am, consultant pulmonologist from Jericare Hospital.
Good evening. First of all, I would like to thank Jayaraman sir and Sleep Summit for again giving me this opportunity to conduct quiz finals. And I hope all of you are as excited as I am. Yes? So can you all shout, say yes? Are you all excited for the quiz finals? Yes. Okay, so we have like 5 teams, 12 teams participated in the quiz preliminary round, which happened during the pre-lunch session, and out of which we have selected 5 teams for the finals. And I request all the participants to introduce yourself, starting with team A. Please introduce yourself, from which medical college?
Sivaprakash, General Medicine PG from ESI Medical College.
Myself, Dr. Akshaya, General Medicine Research from ESA. I'm Dr. Moftika from Savita Medical College, Pulmonology.
Dr. Shivaram from Savita Medical College, Pulmonary Research.
Reshmika, Pulmonology PG from ACS Medical College.
Sushma, ACS Medical College, Pulmonology. Kiran, Pulmonology PG, ACS Medical College. Dr. Deepak, Pulmonology PG from ACS Medical College.
Dr. Preeti, General Medicine PG from Madras Medical College. And Dr. Sukrit Nanda, General Medicine PG from MMC.
Yes. So audience, again, there'll be few questions for the audience. Please, you can also participate as you have some exciting prizes to win. So let's start with the quiz rounds. So first we'll start with the general round. So the instructions, each team will be posted 1 question and the time given is 20 seconds after the question is read. Okay, the correct answer will carry 10 marks. If unanswered, it will be passed on to the audience. Are there any audience here? Yeah, there are few audience. Yes, it will be passed on to them. And there's no negative marking. So can we start? So starting with team A. Are you ready? So this is your question for general round. The sleep parameters estimated by actigraphy includes the following, except A, sleep latency, sleep architecture, wake after sleep onset, sleep efficiency. Your time starts now. Time is?
Sleep architecture.
Yeah, that is the right answer. Can we have some claps, please? Yeah. So team B, are you ready? Yeah. What is the role of melatonin in sleep cycles? A, it helps the brain transition into wakefulness. B, it keeps the brain from becoming overactive during the REM stage. It is released during the transition between stage 1 and 2. It triggers the sleep onset.
D.
D is the correct answer. Team C, are you ready for the question? Yeah. So the gold standard for measuring airflow during sleep includes A, pneumotachographs attached to the masks, B, thermal sensors, C, nasal prongs, D, face mask. B. B is the correct answer. So team D, are you ready for your question? So the following is true regarding slow wave sleep. It predominates during the last third of the night. B, it predominates during the first third of the night. It is equally distributed throughout the night. D, it predominates during the middle third of the night. Time's up. What's the time? B is incorrect. It will pass to the audience. B is the correct answer. Can you tell me your name? Who told the answer? Dr. Ritika, where are you from? You are a postgraduate or? Okay, fine. Yeah, please note down the name so that we have some audience prize. Okay, fine. Yes. So, team D, are you ready for your question? So, women have the following sleep stages longer as compared to men. A, stage 1 and 2, B, stage 2 and REM, stage 3 and REM, D, none of the above.
And C.
C is the correct answer. So can we have the scores at the end of round one, the general round?
B is at 10, B is at 10, C is at 10, D you're not, maybe you're opening yes, C is at 10.
Yes, thank you, Supraja. So next, moving on to round two. So are you all ready for round two? Yes, round two is a rapid fire round. So let's see the instructions. So each team will be asked a set of 5 questions. Okay. So time allotted after I read out the question will be 5 seconds. The correct answer will carry 10 marks. The questions will not be passed to the other teams or the audience, and there's no negative marking. So team A, can start with your set of questions. The circadian sleep rhythm is modulated by which part of hypothalamus? A, suprachiasmatic reflex. Yeah, that is the correct answer. Second question, a split night sleep study can be considered when the following condition is met. AHI more than 40 events per hour during the initial first 2 hours of PSG, or more than 60 hours, or at least 2 hours remaining during the study to conduct the titration, or 1 hour remaining. That is incorrect. The following are the causes of nocturnal hypoventilation except A, mixed edema, B, obesity hypoventilation syndrome, central sleep apnea, or COPD. That is incorrect. The correct answer is C. So the following drugs are used in the treatment of RLS except pramipexole, methylphenidate, iron supplements, gabapentin. Okay. Correct. That's a correct answer. So how does oral appliance therapy work in treating OSA? It increases nasal airflow by widening the nostrils. It advances the lower jaw and tongue. It stimulates the diaphragm to promote deeper breathing, or it increases oxygen levels through mouth breathing.
Option B, it advances the lower jaw.
That is correct answer. So team B, your set of questions. Are you ready? Yes. The following physiological changes occur during sleep, except A, increased parasympathetic tone, increased cardiac output, decreased renal blood flow, increased hormone secretion.
Increase to cardiac.
That is correct. Video PSG is recommended in the following conditions, except PLMD, narcolepsy, circadian rhythm disorders, parasomnias. That is incorrect. Correct answer is C. So the following are the mechanisms of cardiovascular disease in a patient with OSA, except parasympathetic overactivity, chronic systemic inflammation, metabolic dysfunction, decreased capacity of respiratory muscle pump. That is correct. I want all the teams to answer louder, please. So fourth question, which of the following is not the treatment for a patient with narcolepsy? Modafinil, pitolisant, solriamfetol, or pramipexole? Yeah, that is correct answer. RLS is characterized by the following except urge to move body parts, especially legs. There's family history of RLS. Symptoms occur during period of immobility. Symptoms are worse early in the morning after a prolonged immobility. D is the correct answer. Yes. So next set of questions for team C. Are you ready, team C? So sleep spindles occur at the age of the following age: 4 to 5 weeks, 6 to 8 weeks, 8 to 12 weeks, or 6 months. C. That is incorrect. Correct answer is B. In OSLED test, that is Oxford Sleep Resistance Test, patient presses a button when a dim red light flashes, and how many number of consecutive misses should be present for the diagnosis of narcolepsy? A is 4, 5, 6, or 7. B. That is incorrect. Correct answer is D. So, which of the following is the most common causes of excessive daytime sleepiness? A, obesity, hyperventilation syndrome, CSA, chronic sleep restriction, D, narcolepsy. A. That is incorrect. Correct answer is C. So, which of the following drugs used in the treatment of neurodegenerative disorders can cause sudden sleep attacks? Benzodiazepines, dopamine agonists, anticholinergics, anticholinergics. B. B is the correct answer. Last question. To minimize air leaks from a CPAP mask, the following should be done. Use chin straps or oronasal mask, lower the head end of the bed, allow the tube to move freely, all of the above. That is incorrect. Correct answer is A. So next question, a set of questions for team D. Are you ready, team D? So which of the following does not decrease with age? Total sleep time, stage 1, N3 or REM latency?
Stage 3. Yeah, C option C.
And that's incorrect. It's B. So the following are useful tools in evaluating patients with sleep disorders, except functional outcome of sleep questionnaire, sleep apnea quality of life index, Burke's depression inventory, or Barthel index.
Option C.
That's incorrect. Correct answer is D. So the following is true about REM parasomnias. It occurs in old age. Events occur in the later half of the sleep, typically occur once or twice a night, occurs in adults.
Option C.
That's incorrect. Correct answer is D. So the following drugs cause insomnia, except leukotriene receptor antagonists, beta blockers, corticosteroids, and alpha blockers.
Alpha blockers.
That's incorrect. Correct answer is A. So why do shift workers often experience obesity, diabetes, and increased risk of accidents? Their suprachiasmatic nucleus is impaired, their melatonin levels are higher, around 3 or 4. They often do not experience low-wave sleep. Their circadian rhythms are disturbed by changes in sleep-wake times.
D.
That's incorrect. Correct answer is D.
D only.
D?
Yeah. D.
D. Okay. D is the correct answer. Okay. Yeah. So I think you can just read out a little bit so that it'll be clear for me. Yeah. Next, the last team, team E. So are you ready? Yeah. So at what age and above the adult sleep scoring rules can be used by the clinician? 12 years, 13 years, 14 or 16?
16.
That's incorrect. B is the correct answer. Subjective assessment of excessive daytime sleepiness is done by the following scales except ESS, Stanford, Stockbank, Pittsburgh. Time's up. Correct answer is C. Sleep initiation insomnia is due to the following conditions except RLS, delayed sleep phase disorder, anxiety, CSA.
Central sleep apnea.
That is correct. The pharmacological treatment of patients with hypersomnia includes methylphenidate, acetazolamide, lamborexant, or Ramelton.
C.
That's incorrect. Correct answer is A. The last question, sleep disordered breathing disorder can be seen in children with Down syndrome due to the following abnormalities except facial hypoplasia, macrognathia, macroglossia, or narrow nasopharynx. Time's up. Correct answer.
Option D. Option D.
B. D is incorrect. Correct answer is B. So can we have the scores at the end of round 2? So at the end of second round.
Hello. So I'll first read the round scores. Team A had 3 correct answers at 30. Team B had 2 correct answers at 40. Team C 1 at 10. Team B 1 at 10. And Team B 1 at 10. The total score is currently it is led by B team at 50, followed by A at 40, then C and E at 20 each, and D at 10. I think the last round will make a huge difference because you have your.
Yes, yeah. Okay, so at the end of round 2, team B is leading. Okay, so the final round, all the teams are ready for the final round. So it is going to be a buzzer round. So I want you to, listen to the question or look at the picture very carefully. And these are the instructions. So the team who knows the answer, we don't have the buzzer here, so you can just raise your hand. And I need somebody to make sure. Yeah, you have to raise fully. Okay, there's no hesitation. Abdul, you can come and see to make sure, which team raises the hand first. And after the question is read out, I want you to raise your hand, and the correct answer will carry 20 marks. Okay, if unanswered, it will be passed on to the audience. So you have some chance to win, audience. So be ready. And there is negative marking of -5. Okay, if the answer is wrong, so be very careful when you. It'll be a buzzer round. Yeah, it's a buzzer round. Yeah. So first question or the picture, are you ready? So identify this device, 20 seconds. Okay. Nasal pillow is incorrect. The audience, it will pass on to the audience. Audience, any guesses? Yes, okay, sure. Yeah, yeah, sure, ma'am. Yeah.
This is an EPAP device. So it's just actually slapped onto your nostrils and it creates, it is basically expiratory pressure. You see, and this is disposable.
Yeah. Yeah, that is the right answer. So it's a nasal EPAP device, Theravent. Yeah.
Please raise your hands completely, no half is, so fully raise your hands.
Yeah. So Abdul is carefully watching. So make sure you raise your hands fully. Okay. Before you answer, please make sure your hands are up. So identify this newer treatment modality. Yeah. That is the correct answer. So previous there's -5 for the other team who answered wrong. Yeah. So team E will get full 20 marks. So can we move on to the next picture? Yeah. So what is the name of this therapy used for the OSA patients? The set of exercises. 20 seconds we have. Time's up? Not yet. Yeah. That is incorrect. The question will pass on to the audience. Yes. That is the correct answer. Yeah. Can you tell me your name and where are you from? Subumar, Savita Medical College. You're a postgraduate or consultant? Okay, fine. Yeah, right. So all the audience who answered the question can stay back. You do have some exciting prizes at the end of the quiz. So moving on to the next pick. So identify this PSG report. 20 seconds, time starts. Yeah. That is incorrect. Audience, any guesses? That's incorrect. The correct answer is UARS, upper airway resistance syndrome. Okay, there's flattening of the inspiratory limb and then you can see some arousals. Yeah. So identify this PSG report. Time's up? No. 10 seconds more. Yeah, time's up. Audience, any guesses? Yes, ma'am. Loudly, ma'am. Wake. No, it's not actually. Yes. Yeah, that is correct answer. Yeah, it's a mixed sleep apnea. Yeah. You can see some flattening and then there are some wave here, at the end. So I think this brings us to the end of all the 3 rounds. If there is any tie, we have a tiebreaker question as well. So let's see the marking. Supraja, can we have the scores at the end of round 3, the final round?
At the end of third round, I'll first read the round scores. So we have -5 for team A, team B, team D. Team C didn't score anything, and plus 20 for Team E. So that brings us the final scores to top by B at 45, E at 40, A at 35, C at 20, and D at 5.
Yeah. So, the first prize winner team is Team B with 45 points. I request everyone to give a big round of applause to Team B for the winners of first prize. And they're going to take home cash prize of 10K. Okay. Yeah, it will be given during the valedictory function. And the second prize winners we have Team E. So Team E, well done. And the third prize winners we have Team A. Yeah. So I have one more question which I had kept it as a tiebreaker. If anybody wants to answer, we'll just see. So 45-year-old female is referred to you by a primary care physician with a PSG report showing AHI of 25 and clinical evaluation. It reveals snoring, excessive daytime sleepiness. She was a known hypertensive and diabetic. On examination, she was an obese lady. BP was 130/80, saturation of 89, and ABG showed a PCO2 of 51. So what is the most likely diagnosis? Open to everyone? Which is, yes, correct. Yeah. I know. So, yeah. Right. Thank you. So we have come to the last session, last end of the day event. I thank all the PGs who have come here enthusiastically participated, and I thank Dr. Jayaraman for inviting doctors from IMA and all from different specialities. And I thank Dr. Shivani Swami from coming all the way from Jaipur, and a lot of faculty who have come from Sydney as well, who have left for the day. And the sponsors for the event and for the AV setup and GRT hotels and housekeeping. And in case I have missed out, thank you all once again for coming, making this a grand success. And it was a full house from morning till evening. So I really appreciate all your enthusiasm and staying back. Thank you so much. So I would like to request the faculty for the workshop to come on stage to receive the memento. To give it, I request our course director, Dr. Shivani Swami, to come in, Dr. Jayaraman to come in. Dr. Sendil, please. Dr. Hema Malti. They are the dental team who helped us with the devices, MAD devices. For ENT, we had Dr. Shaktish and Dr. Shankar Subramaniam. I invite Dr. Ria to come on stage to. Dr. Mahima. Dr. Hema Malti, ma'am. Next, we would like to request the prize winners also to come on stage. Team B. Team B is from which college? B is special. You're from which college? Savita Medical College. Please come.
Cash.
Second prize, Team E from MMC.
Third prize goes to ESI Medical College. Yeah, Team A. So for the audience prize, Dr. Ritika, she actually got it twice. The answer twice correctly. And Dr. Sukumar. Both from Savita, right? Meenakshi. Both of them from Meenakshi. Which one? Meenakshi and Savita Medical College. Go to the center of the page. Yes, ma'am. Please come. Sir. Please come back.
Shashikala, thank you so much.
Dr. Shashikala. Yes.
Thank you, Pap.
Thank you.
Yes.
One second.
Requesting all the quiz participants to come onto stage, please.
All the quiz participants. All the participants.
Some of them.
You can sit from me now. And sit.
Please come to the stage, Lana.
No? Yeah, it's come to seven sports. Ma'am, please.
Just, before that, as we proceed with the picture, a quick thank you to our score master for the day, Suprata ma'am, and of course, workshop coordinator.
குட்டீஸ் எல்லாம் கீழே உட்காரலாம்ல சீட்டே நிற்கலாமா
இது கொஞ்சம் சைடுல போகுமா
சைடுல
இன்னும் கொஞ்சம் சைடுல போட்டா
PG mount up with the PG club. Come on, launch for me. One minute, this PG guy will go. I request all our PG student, Dr. Apramaya, come to the stage and get your Momoton certificate. Dr. Pumalar, Dr. Vinny, Dr. Abdul. Yeah, please come. Yeah, Dr. Uttarasan, Dr. Anandaraj, please.